Доброго дня всім! Шановні акушери-гінекологи, лікарі репродуктивної медицини, ембріологи, адміністратори, всі, хто займається репродукцією людини. Чекаємо вас на симпозіумі Української асоціації репродуктивної медицини 9 та 10 жовтня цього року. Досить цікава та незвична програма. Очікується більше 600 учасників та 30 спікерів з різних країн світу. Зокрема, школи Pre-Symposium, а також унікальна школа Pre-Symposium щодо ультразвукової діагностики. 6 секцій на самі різноманітні теми репродукції людини. Реєстрація відкрита, вона безкоштовна. Чекаємо вас на симпозіумі онлайн 9 та 10 жовтня, тобто в п'ятницю та суботу цього року. Дякую, до зустрічі!
What would you say if I were to ask, what is the greatest invention ever? Lipstick? Your favorite sandals? The camera? Some would say it must be the fire that started everything. Something worth waiting for? Or something worth staying for? The plane. Not these planes. These planes. Or others would argue, it is the civil rights.
We will not be satisfied until justice rolls down like water and righteousness like a mighty stream.
4, 3, 2, 1.
Something that brought us to other further horizons.
Roger, we'd like to get both of you in the field of view of the camera from there.
Here at MSD, we believe it's all of these things. It's life. It's her, him, us. It's you. Life is the greatest invention ever. And we at MSD are here to protect it, nurture it, improve it, make it longer, make it easier, make it safer. By discovering, developing, and providing solutions for people for today and for tomorrow, to make a difference by inventing for life.
Доброго дня всім! Шановні акушери-гінекологи, лікарі репродуктивної медицини, ембріологи, адміністратори, всі, хто займається репродукцією людини. Чекаємо вас на симпозіумі Української асоціації репродуктивної медицини 9 та 10 жовтня цього року. Досить цікава та незвична програма. Очікується більше 600 учасників та 30 спікерів з різних країн світу. Зокрема, школи Pre-Symposium, а також унікальна школа Pre-Symposium щодо ультразвукової діагностики. 6 секцій на самі різноманітні теми репродукції людини. Реєстрація відкрита, вона безкоштовна. Чекаємо вас на симпозіумі онлайн 9 та 10 жовтня, тобто в п'ятницю та суботу цього року. Дякую, до зустрічі!
What would you say if I were to ask, what is the greatest invention ever? Lipstick? Your favorite sandals? The camera? Some would say it must be the fire that started everything. Something worth waiting for? Or something worth staying for? The plane. Not these planes. These planes. Or others would argue, it is the civil rights.
We will not be satisfied until justice rolls down like water and righteousness like a mighty stream.
4, 3, 1.
Something that brought us to other further horizons.
Roger, we'd like to get both of you in the field of view of the camera from there.
Here at MSD, we believe it's all of these things. It's life. It's her, him, us. It's you. Life is the greatest invention ever. And we at MSD are here to protect it, nurture it, improve it, make it longer, make it easier, make it safer. by discovering, developing, and providing solutions for people for today and for tomorrow, to make a difference by inventing for life.
Доброго дня всім! Шановні акушери-гінекологи, лікарі репродуктивної медицини, ембріологи, адміністратори, всі, хто займається репродукцією людини. Чекаємо вас на симпозіумі Української асоціації репродуктивної медицини 9 та 10 жовтня цього року. Досить цікава та незвична програма. Очікується більше 600 учасників та 30 спікерів з різних країн світу. Зокрема, школи Pre-Symposium, а також унікальна школа Pre-Symposium щодо ультразвукової діагностики. 6 секцій на самі різноманітні теми репродукції людини. Реєстрація відкрита, вона безкоштовна. Чекаємо вас на симпозіумі онлайн 9 та 10 жовтня, тобто в п'ятницю та суботу цього року. Дякую, до зустрічі!
What would you say if I were to ask, what is the greatest invention ever? Lipstick? Your favorite sandals? The camera? Some would say it must be the fire that started everything. Something worth waiting for? Or something worth staying for? The plane. Not these planes. These planes. Or others would argue, it is the civil rights.
We will not be satisfied until justice rolls down like water and righteousness like a mighty stream.
4, 3, 2, 1.
Something that brought us to other further horizons.
Say again, Houston. Roger, we'd like to get both of you in the field of view of the camera for a minute.
Here at MSD, we believe it's all of these things. It's life. It's her, him, us. It's you. Life is the greatest invention ever. And we at MSD are here to protect it, nurture it, improve it, make it longer, make it easier, make it safer. By discovering, developing, and providing solutions for people for today and for tomorrow, to make a difference by inventing for life.
Доброго дня всім! Шановні акушери-гінекологи, лікарі репродуктивної медицини, ембріологи, адміністратори, всі, хто займається репродукцією людини. Чекаємо вас на симпозіумі Української асоціації репродуктивної медицини 9 та 10 жовтня цього року. Досить цікава та незвична програма. Очікується більше 600 учасників та 30 спікерів з різних країн світу. Зокрема, школи Pre-Symposium, а також унікальна школа Pre-Symposium щодо ультразвукової діагностики. 6 секцій на самі різноманітні теми репродукції людини. Реєстрація відкрита, вона безкоштовна. Чекаємо вас на симпозіумі онлайн 9 та 10 жовтня, тобто в п'ятницю та суботу цього року. Дякую, до зустрічі!
What would you say if I were to ask, what is the greatest invention ever? Lipstick? Your favorite sandals? The camera? Some would say it must be the fire that started everything. Something worth waiting for? Or something worth staying for? The plane. Not these planes. These planes. Or others would argue, it is the civil rights.
We will not be satisfied until justice rolls down like water and righteousness like a mighty stream.
4, 3, 2, 1.
Something that brought us to other further horizons.
Say again, Houston. Roger, we'd like to get both of you in the field of view of the camera for a minute.
Here at MSD, we believe it's all of these things. It's life. It's her, him, us. It's you. Life is the greatest invention ever. And we at MSD are here to protect it, nurture it, improve it, make it longer, make it easier, make it safer. By discovering, developing, and providing solutions for people for today and for tomorrow. To make a difference by inventing for life.
Доброго дня всім! Шановні акушери-гінекологи, лікарі репродуктивної медицини, ембріологи, адміністратори, всі, хто займається репродукцією людини. Чекаємо вас на
Happy to announce that today we are starting the Symposium of Ukrainian Association of Reproductive Medicine, Theory and Practice of Human Reproduction. This year it takes place in somewhat unusual format, online, but those are conditions dictated by the pandemics today, so we are conducting it remotely. We have a record number of participants registered, almost 2.5 thousand of persons. For the main program for 2 days, there are 1,200 persons, another 200 for youth, U-arm, and about 100 persons for live surgery. I remind you that you can see us at the website of Ukrainian Association of Reproductive Medicine. When you open our website, there are 4 windows, 2 windows for the main program of the symposium in Ukrainian, Russian, and English, and a separate window, use U-arm, and a separate window, live surgery. Today we start on Pre-Symposium on Ultrasound, diagnostics in obstetrics, gynecology, and reproductive medicine. Parallelly, there will be a section of use U-arm and a section of live surgery from 4 surgery sites in Vinnytsia city, Ivano-Frankivsk, Chernivtsi, and Odessa. I hope that we shall satisfy all the needs which our reproductologists, embryologists, and surgeons have. I remind you that you can also ask your questions in chat, and every section will be facilitated by a certain person, and we shall try to answer your question online, or afterwards we shall pass your question to our speakers. Today, the scientists, lecturers, well known in their countries and internationally, take part in our event from 14 countries of the world. So, dear participants, we are beginning. Now I give the floor to Professor Grishenko Mykola, who will start the section for ultrasound diagnostics. I want to thank all the sponsors, all the companies, our partners who participated in the organization of our symposium, because it's a great event. I hope that these 2 days will pass as 1 second very successfully. I wish success to all of you in your work. Mykola Grigorьевич, you have the floor. Thank you, Alexander. Great, thanks. And let us start our section. Traditionally, we start the first day from the so-called School of Pre-Symposium, which are very practically dedicated to certain topics. Even before pandemics, when there was no need to have only online events, we thought and we decided that the most interesting 3 symposiums are usually taking place at the intersection of the disciplines. Also, it's difficult to say whether it is intersection or no, because nobody can imagine a reproductologist now who is not possessing ultrasound scanning, and every minute can use ultrasound transducer. We have a narrow specialization, certainly, that's connected with certain professional deformations. You know, in Ukraine, it is not clear up to now the scanning reproductologists and gynecologists, do they have to have full-fledged courses, full-fledged training on ultrasound diagnostic? From the point of view of law, yes, eventually they have to. from the point of view of practice, it's much more important for us to ticks and trips, to use them in our day-to-day practice. We encounter them every day, and we tried to prepare our today's agenda with attraction of experts, of international experts, colleagues, scientists from different countries. And our today's section is dedicated to ultrasonic diagnostics with special focus on reproductive medicine, on ovarial reserve, on congenital malformations, uterine malformations that we are meeting and encountering every day in the practice of reproductive medicine. So it's my great pleasure now to start this section and to introduce to you our first speaker, Professor Karine Tofuns, the Doctor of Medical Sciences, and in Armenia, Karine is heading, not only representing, if I'm not mistaken, the international organization, the School of Inter-University School of Medical Ultrasound Jan Donald, which has a very great mission and provides a lot of quality information to ultrasonic specialists, doctors, and not only. It's my great pleasure to introduce Karine to you. Every second of your presentation is very valuable, so I finish a little bit earlier my speech. Karine, now it's your turn. We are waiting with impatience. Good morning, colleagues. Allow me to thank the organizers for the invitation and also to express my huge thanks and gratitude to all of my colleagues and friends who expressed their support in such difficult days for my homeland. Now let us switch directly to the presentation. It has the name of ovarial kaleidoscope through the eyes of an ultrasound doctor. I have no conflicts of interests. Why kaleidoscope? Because it's a favorite toy of my childhood. Who knows that all the rest of my life I have to put up like a puzzle from different small details, a comprehensive picture we see during the ultrasonic study to help diagnostics. See how different are these images of ovaries. This is just a small part of possible eventual images, and each of them is associated with certain endocrinopathy. This patient for many years was treated for infertility. After gynecologist has got an ultrasonic conclusion which described normal in size and echostructure ovaries. Everybody understands what happens in this concrete case. This patient is after surgical treatment, endometrioma removal. We see that there is only follicle in this ovary, notwithstanding all the assurance of the surgeon that the ovary will be preserved and will have normal function. And we have to stop doing conclusions on nothing when only an ovary is described without any specific features. The resolution of modern scanners allows to differentiate very well the anatomical structures, and it makes our study almost as morphological one. The application use of ovarian morphology structure is closely connected to different specialists' interests. Reproductologists will be interested with everything connected with violation of ovarial function. In this case, we can generally divide the morphology of ovaries into three groups: ovaries with normal count of follicles, ovaries with excessive count, and ovaries with reduced count of follicles. To understand the principles of ultrasonic diagnostics of these pathological conditions of ovaries in reproductive age, you have to remember about physiological particularities of folliculogenesis. Follicle is a morphological unit of ovary during endocrine and reproductive function and is determined with ovarial reserve. This slide shows the stage of follicles from primordial, primary, secondary to pre-ovulatory. The first three groups are antral follicles in size from 2 to 10 millimeters. The antral follicle over 10 millimeters is a dominant follicle and passes to pre-ovulatory stage. To associate correctly the ultrasonic images of ovaries to different violations of functions of ovaries or syndromes, we have to know the definitions. Ovarial reserve is individual reserve of oocytes which haven't been still exhausted to certain age, which are adequately responding to stimulation with growth of comprehensive full-fledged follicles containing healthy oocytes. We know that about 4 to 5 million of oocytes are present in girls at birth, and their number is reduced towards puberty, and about 100,000 remain at mature stage of the women. There are different stages of development, including the so-called sleeping follicles. The follicles are primordial, primary, secondary, tertiary. The primordial, secondary, and primary are not accessible for ultrasonic differentiation. Unfortunately, certain persons write that they see primordial follicles with ultrasound. It's not possible. We start to see from tertiary follicles with ultrasound. They are subdivided on the classes, and here we see the classes 4 and 5. The size is from 2 to 5 millimeters. Starting from class 4-5, we can already visualize them, and class 6 also belongs to our interest, area of interest, and above that. Antral follicles count is the next definition. We have to know why it has been introduced into practice, because currently there are no direct tests which could define the true ovarial reserve, and antral follicles count is a surrogate marker of ovarial reserve. To do it correctly, we have to understand for ourselves certain provisions. Ovarial reserve consists from a functional ovarial reserve for primordial follicles. Then we have to define the count of follicles for each ovary. It is the English abbreviation FNPO, and a Russian one, recruited follicles or recruitable follicles. And also we have to understand the notion of number of antral follicles. That is the total amount of rectal follicles for both ovaries. The follicle count is calculated separately for each ovary, and AFC, FNPO is made for each ovary, and AFC is made for the total amount of both ovaries. Antral follicles are counted as follicles of 2 to 9 millimeters size in an early follicular phase. We'll dwell on it. AFC correlates well with overall number of primordial follicles and is an important indicator of ovarial reserve, and consequently of the reproductive age. Why antral follicles should be counted? Because the assessment allows to assess the age of ovaries and also helps to be guided and to advise the patient in case of delayed pregnancy, allows to prepare for cryopreservation of oocytes, and allows to gather more complete information for family planning, allows to choose contraception methods and to avoid ungrounded hormone therapy, hyperstimulation, and are predictors of aneuploidies as well. We shall dwell on that. Antral follicle counts correlates with histology. It is already established. It was found out also that the level of AMH, anti-Mullerian hormone, more correlates with AFC than other hormonal markers. As now no direct tests exist which would define the true ovarian reserve. The AFC is a reliable indirect marker. Another marker, as we all know, is AMH. It's obvious that AFC and AMH have equal or comparable diagnostic accuracy for ovarian reserve definition and predicting ovarian response to stimulation. We do see all this on the diagrams. AFC allows to predict the response of ovaries to stimulation. With AFC less than 6 in RT programs, we shall get average 2.2 of a size and accordingly 1.3, and the relevant other numbers 7 to 19 we shall have 5.6, 6.6, 3.8, and with number over 20 we shall have 11 on sites and an average number of 6.6 embryons. AFC allows also to predict live birth rate. Here are two different studies showing that with low ovarian reserve, live birth rate is just 19%. How we find out the low ovarian reserve? Also with AFC. With AFC over 7, we have 30% of live birth rate. If it is lower or equal to 6, the number of live birth rate is close to 10. AFC allows also to predict menopause occurrence. With when it's more than 4, the risk of menopause is increased in 3 times in the nearest 7 years. The number of fertile follicles allows to predict and forecast aneuploidy risk. AFC as a marker of biological age of ovaries reflects the basic risks of fetal aneuploidy. AFC lower than the age-related indicator is the better screening test compared to age to calculate the risk for fetal aneuploidy. This study shows that AMH and AFC have equal predictive value in forecasting IVF results. We do see the matching sensitivity and specificity curves for AFC and AMH. The meta-review of 2011 shows that AMH and AFC do have equal predictive value also in prediction of hyperergic response of ovaries, meaning hyperstimulation. And this is a summary table to interpret the AFC for definition of stimulation and ovulation, whereas we have the number from 0 to 4. It is very poor ovarian reserve, and the risk of poor response to stimulation is very high, and also low chances for pregnancy. With AFC 5 to 8, it is a low functional ovarian reserve and high risks of insufficient response to stimulation. 9 to 19 is a normal FOR normal response is expected for stimulation, and over 20 there is a high risk of hyperstimulation. Also, the follicle counts in ovaries is being made. There are different methods and the technical possibilities, capacities of modern ultrasonics count give a lot of opportunities for the researcher, for the sonographist. 2D studies, here we use real-time, cine loop, and harmonics option. We shall dwell on it. And to the right, you see all the options and possibilities of 3D scannings when defining AFC. In 2008, a group of authors, those are experts of world level, top names are here. They developed practical guidelines on counting ovarian and antral follicles with a comparative characteristic of 2D and 3D methods with description of each method's characteristics and differences. We shall dwell on that. Obviously, as in whatever ultrasonic visualization area, we have to strictly adhere to certain rules, meaning we have to standardize our studies. Earlier, we have observed is only the rule of making AFC in an early follicle studies, but Refenix studies showed that it is not necessary to do yearly count. We have only 10% of intracycle variation. In 2014, Frank with co-authors developed practical guidelines to improve standardization. They believe that the automatic follicular diameter measuring, this is the 3D sonography, is a chance for standardization. 3D ultrasound, in their opinion, has potential advantage, including a reduction of variability and repeated measurement, a reduction of ultrasonic study time, possibility to measure images post factum, and also increasing diagnostic possibilities to study the appearance and the internal structure of ovaries. Now I introduced to you the Sono AVC. It is a function which allows to automatically recognize follicles and also analyze the shape, volume, and average diameter of each follicle. Moreover, there are two options which help to identify the follicles. That is the resolution, the separation, and the size. With increased resolution, we have a risk when few follicles can merge. When we increase the size and parameter, we can lose the number. You have to work on that with US device. 3D Sono AVC allows to calculate the eco-negative structures in the ROI, and the main algorithm allows to calculate all volume, all masses in the region of interest. So we can eliminate the bias. There is an option of Sono AVC with manual correction because the devices sometimes miss some small anechoic inclusions. In this case, we just add them manually. Very often the doctors ask how it happens, and I tried to record on video how it looks out really. So in this case, you make a click and each follicle is outlined. You see in the table to the right the number of follicles, the size, the volume, all the quantity parameters of our interest for each follicle. Next option is multiplanar mode. There are many options and variants. Everybody can choose. They are basically comparable, and the voluminous contrasting is one of 3D contrasting options to increase the contrast by reducing the interferences with better clearance of margins of the tissue and with better accuracy. The methods are different, but VCI improves 3D image quality with similar harmonization we have in 3D. Or there is an option to convert echogenicity to change between dark and light without changing the number of parameters. I just am showing you the possibilities of modern US scanners. And now let us dwell on our syndromes of interest. The excessive count of follicles, as we already mentioned, is normally associated with polycystic ovary syndrome, multifollicular ovaries, and also ovarian hyperstimulation syndrome. PCOS, very briefly, we all know it. It is a complex of violations characterized by infertility, hirsutism, obesity, and menstrual function disorders, oligomenorrhea, amenorrhea, and ovulation. Ovulatory dysfunction and hyperandrogenism are, in the opinion of the author, a determinating one, and the metabolic component of the syndrome is insulin resistance and lipid exchange disorder. The frequency is from 3 to 30% depending upon population. In Armenian population, women, this percentage is rather high. I know that in India there are also many PCOS women. For many years already in the diagnostics of polycystic ovaries, we are based on Rotterdam Consensus of 2003, according to which to establish diagnosis of PCOS, you have to have two criteria from three: undergoing the hyperandrogenism, anovulatory dysfunction, morphology of polycystic ovary with ultrasonic study. The ultrasonic criteria of PCOS, according to this consensus, is the number of more than 10 to 12 follicles with 2 to 9 millimeters size, volume of ovary more than 10 cubic centimeters, and the one polycystic ovary is sufficient to assert this criteria, according to the authors of this consensus. Based upon a Rotterdam consensus in 2004, the following PCOS criteria were considered as obsolete, as out of date: increase of ovarian volume over 10 centimeters, distribution of peripheral distribution of ovaries, increase of the area of the ovary, of ovarial stroma, ovarian uterine index, stromal ovarian index, increased echogenicity of ovarian stroma, and overall count of follicles per ovary of 12 and more. I do not agree with certain of those provisions. We shall dwell on it later. In 2014, a statement appeared from the Society of Androgenism and Polycystic Ovary Syndrome Society about definitions and significance of PCOS morphology, a famous article by Duval and co-authors, which puts everything from head to feet, topsy-turvy everything. They say that much more follicles are visualized with certain techniques. So currently, an average count of follicles in healthy women of reproductive age is from 7 to 16. So the use of the criterion of over 12 will result in that we shall assume polycystic ovary syndrome in over a half of young patients, because the average number of follicles in them is from 7 to 16. They also proposed to review the threshold cut-off number of AFC for polycystic ovaries. In opinion of those authors, the best specificity and sensitivity is 25, with sensitivity 92% and specificity 81%. This number, 25, was proposed to consider as cut-off one. It was reviewed. The same work makes main recommendations for definition and significance of PCOS morphology, polycystic ovaries morphology. These guidelines with cutoff count of follicles over 20. This threshold value is defined with modern technology using high frequency transducers with over 8 MHz. AFC is a prognostic factor for PCOS with excessive volumes of ovaries, and also is correlated with the relevant population of 18 to 35 years. These all parameters depend upon and are correlated with age. The methods of real-time study provide for standardization available. The cutoff value of ovarian volume in obesity doesn't allow to define FNPO. AMG level instead of US can be used in clinical practice before the standards of the technology being studied should be developed. It can also help to define ovarial reserve in technical difficulties for ovarial follicle counts. For example, poor visualization of ovaries not only in obesity but also with low mobility or where when there are some messes, and also with lack of experience of the operator or no relevant settings of the ultrasonic device. In 2018, a new ASHRAE consensus was published with high levels of evidence. It was developed by 3,000 researchers. Let's look what they do propose us. According to this consensus, morphologically polycystic ovary is not a PCOC synonym. Ultrasonic criteria of morphologically polycystic ovary are not applicable at the gynecological age of less than 8 years after menarche, due to high frequency, high rate of multifollicular ovaries in this age period. TV ultrasound is preferable for PCOC diagnostics. Threshold values of AFC should be reviewed parallel to development of technical possibilities of the devices. We can expect something surprising in a sense. With TV with transducer of 8 MHz, the threshold AFC in each ovary over 20 or volume of ovary over 10 milliliters, you should account that the volume of the ovary would not be measured without corpus luteum or dominant follicle. With transabdominal scanning, the threshold value should be over 10 milliliters due to difficulty of reliable assessment of follicle count. So earlier the threshold or cutoff value was 12, then they proposed to make it 19, 25, and now the compromise cutoff or threshold value proposed is 20 for AFC. We have also to remember that there are different phenotypes of PCOC. I want to say a couple of words about misunderstanding or low understanding in colleagues. Always PCOC morphology means true PCOC. Always PCOC has a morphology ascribed to it. For example, with B phenotype of PCOC, we have hyperandrogenism and anovulation. And here we shall not see morphological features of PCOC. Should remember that only 10 to 20% with PCOC morphology have classic PCOC. I want us not to forget about it. Another point of view, we have to consider certain authors, for example, the Brazilian Professor Martins, do not agree with the term polycystic ovaries because polycystic ovaries normally are associated with bilateral increase of ovaries containing different follicles, not cysts. The term polycystic ovaries was introduced in 1955, according to Martins, is an error. And this term is very often a reason for confusion or concern of patients, because in your practice you also encountered the concerned mothers who have fear in their eyes saying, you know, my daughter was established a diagnosis of polycystic ovaries. What does it mean? Do they have cysts, etc.? And also unnecessary interventions of medicinal, pharma or surgical treatment to remove the so-called cysts, and also requires regular conduction of control TVS for the so-called monitoring of those cysts. What he proposes, he believes that beta suiting terms are ovulator dysfunction to be divided in primary and secondary one, and all types of secondary ovulatory dysfunctions. Dysfunction of ovaries are listed here. Hyperandrogenism and insulin resistance are believed to be too variable to assess clinical presentations. Another dilemma. Stromal hyperplasia, we already mentioned. It is an obsolete definition, not worth to pay attention to, but we know that stromal hyperplasia and its echogenicity, which are not included due to the subjectivism of the assessment, are frequent specific feature of hyperandrogenic dysfunctions, and hyperechoic stroma can be a sign of silent PCOC. In this case, AMH definition is recommended independently from AFC. This problem requires further study. In my opinion, we have to develop criteria with high inter-observers credibility. I can say you that a great number of patients have a number of those follicles on this threshold. But with such stroma, they always do have high AMH, so these problems requires further study. Multifollicular ovaries. Another item of the so-called diagnostic errors. Those are ovaries of normal or slightly increased size or volume. They contain number of follicles over 6 with 4 to 10 millimeters diameter. The stroma is not changed. You see, not changed stroma can suggest a correct diagnostic solution or decision. No hirsutism, LH and FSH in norm or slightly reduced. Multifollicular ovaries can be met with different physiologic pathologic conditions. We shall not list them, you know all of them, and also with different pathologic conditions. They can also be available. That is how they are present. The whole ovary is shown with follicles of different size. And let us dwell on hyperstimulation now. Hyperstimulation, the risk of hyperstimulation can be suggested by AFC. Also, it's difficult to do it in hyperstimulated ovarian. The prediction of this risk can be given by AFC over 15. With equal AFC in patients with further hyperstimulation, the volume of follicles was reliably higher. With a total bilateral ovarian volume of over 190 milliliters, hyperstimulation risk is very high, and IVF cycle has to be cancelled. IR of stroma normally is over 0.5, and the stromal peak systolic velocity over 10 centimeters per second, and the stromal perfusion index is over 15. The hyperstimulation, to exclude it, we have to do ultrasonic studies at 4th day of embryo transfer. We have to be aware of it, to be alerted when we see the longest, highest longitudinal ovarian diameter over 10 centimeters, and we see free liquid in Douglas pouch. And also, don't forget about the cities and pleural effusion or renal perfusion. Reduced number of follicle count we have to dwell on. It is associated with preterm insufficiency of ovaries, resistant ovary syndrome, and testicular feminization syndrome. The terminology, these are different terms. Preterm ovarian exhaustion syndrome is preterm climax, preterm menopause, and preterm ovarian insufficiency. According to recommendations, the term early or preterm ovarian insufficiency is proposed. This is a clinical syndrome with a main sign when ovarian function is stopped before 40 years. And is characterized with menstrual functions violation, oligomenorrhea for at least 4 months, increased level of gonadotropins FSH over 25 IU. You should also remember it should be proved with 2 studies with not less than 4 weeks between them. AMH is reduced in most cases in these cases, except for autoimmune case when it can be normal, and is defined also by estradiol concentration reduction. You see the prevalence. It's also variable depending upon population. The clinical signs of ovarian exhaustion or primary ovarian insufficiency syndrome and primary preterm ovarian failure. Most of them are established during ultrasonic studies. This is a multifactorial syndrome, and there is a list of its reasons. The genetic aspects, high risk of POI is observed at Frank's syndrome or Martin-Bell syndrome, at Turner syndrome or its variant Turner mosaics, and Swire syndrome. We have to remember about it. And also the significant autoimmune reasons, antiviral antibodies, autoimmune antibodies, rheumatoid arthritis, and systemic lupus. There are two types of preterm ovarian insufficiency, follicular and afollicular. We have to remember very important technical aspects of our scanning. The harmonization of the image increases the contrast. You see, to the left, we see an ovary without harmonization. We cannot see any follicles there. When we make harmonization of the image, we do clearly see that this ovary has 1 to 2 to 3 follicles. With ultrasonic study, with primary ovarial insufficiency, as a rule, the reduction in volume of follicles is seen. We already mentioned number of follicles reduction, also reduced blood flow parameters in ovaries increased. According to the authors, ovarian volume of less than 3 centimeters is a reliable predictor for IVF failures. Very often doctors do ask how the volume of ovary is determined. It's very easy. You just outline in each plane. I will go ahead a little bit, and in the end we see such an image of a voluminous volume rendered ovary with all the relevant parameters. What else can we see? And we already looked at class 4-6 of ovaries. Now let's pass to the classes 7-8. The resolution of modern scanners allows to see the hidden life of follicles. The periovulatory follicle daily growth is 2 to 3 millimeters. Ovulation happens at the size of 18-22. Very important. 36 hours before ovulation, cumulus appears already. Anechoic halo appears 24 hours before. And the delimitation of follicular wall happens 6 to 10 hours before ovulation. These are the hints to reproductology. This is how the follicular wall is separating, deliminating. The visualization of cumulus correlates with maturity options. According to the authors, the follicles not containing cumulus oophores do not contain mature oocytes. We see different modalities of 3D ultrasound when we can visualize very well this cumulus. I'm sorry. There are discussions about certain authors believe that cumulus availability is not an objective parameter. In my opinion, these controversies happen due to that there is a so-called acoustic interlapping or overlapping. You see, in 2D we see follicles and even cumulus. When we see through 3D, we see that no, the follicle is empty. There are some overlappings of projections. In the case when the doctors saw the so-called pseudocumulus, but didn't go to size when puncturing, when picking up. This was due to this overlapping. Follicular angiogenesis can say a lot about functional maturity. In 2012, Kulik presented a work which was describing the connection of vascularization to functional maturity of the follicle. You see how well the vascularized follicle appears. The preovulatory follicle with even perifollicular vascularization do contain potentially fertile oocytes according to the authors. Once more, we see different modalities. We see very well to the left the follicle with insufficient vascularization, to the right, well vascularized one. It is a semi-quantitative assessment mainly subjective, even when we use the score of vascularization. But in experienced hands, it works. To optimize, we can use 3D powered Doppler with automatic calculation of vascularization index. In this case, we shall have absolutely reliable numbers. Another example of follicular volume calculation is vascularization calculation. A very good work in this direction is presented by Irina Arkadievna Ozerskaya. She says, this slide is used with her permission. Luteal insufficiency can be predicted by us with 3D ultrasound. When at 17th, 22nd day of the cycle, we see a decrease of corpus luteum size, thinning of its wall, and hypervascularization with relevant indexes, and also the thinning. Okay, we have still about 5 minutes. We shall quickly browse in the step-by-step algorithm of diagnostic search when studying varial mass before IoT and ERATS era. And now it's very easy, everything. We have our assistants, IoT or ERATS. According to ORATS2, this is the category which unites practically all the benign conditions which we very often meet. The reproductologist frequently meets them. If we will have time, we'll dwell briefly on that. Those are follicular cysts. Everybody knows how they appear. But those are most frequently encountered ovarian masses. You have to remember that regression can take time of 2 to 3 months. With differential diagnostics, we use unilobular cystic adenomas. In this case, there is no regression, and with no fibers of specific features. Tomographic ultrasonic study allows us to differentiate between follicular cysts and, let's say, hydrosalpinx. To the left, we see follicular cysts. To the right, hydrosalpinx cysts. The 3D ultrasound. Once more, to the left, we see the image of the mass, which reminds us cystically changed ovary. To the right, we see it is a uterine tube. The follicular cysts are also necessary to differentiate them on paratubal and paraovarial, and the relevant signs are listed in the slide. Very often, the diagnostic errors happen due to the so-called inclusion size of a peritoneum, which can be very big in size. Another example of inclusion cysts. It is very easy to differentiate them because they change their configuration even when pressing against them with the transducer. Luteal cysts are characteristic by hypervascular wall, a lack of internal vascularization, and variance of the image in time. So when it's difficult to understand for you, because they are very much similar to another pathological masses, you just review the patient in certain interval of time. Another luteal cyst with a knee wall coagulation simulating papillary inclusion. And the statement by Philip Konings, who believed that 20 years ago I was writing that the luteal cyst can persist for more than 1 year. Then I came to a conclusion that it can persist for over 2 years, and today I found out it disappeared after 3 years. So please don't run to the surgical knife very quickly. Don't jump to surgery. It's a hemorrhagic signs. A fissury net sign, ground glass sign, which makes it very similar to endometrioma. Let's not look at the dynamics. Very often the hemorrhagic cyst with wall coagulations are very similar to hemorrhagic cysts. Doppler helps us a lot, which defines the vascularization. Hemorrhagic cysts are similar to hemangioma. Endometriomas is very specific. The availability of new hyperechoic inclusion is very well seen with 3D ultrasound. Use 3D ultrasound, please. Endometriomas do have atypical features. Sometimes you have to remember about this. Sometimes very small endometriomas are very difficult to see in the ovaries with 2D, and you can see them very well with 3D. So I call to you to use these options, the 3D, and obviously there is genital endometriosis. We have to remember on it when we see the so-called kissing ovaries. Another example of kissing ovaries. And a matched teratoma once more. It is a frequent ultrasonic finding in our ovarian kaleidoscope. We should just show browse through few slides without dwelling to talk about the signs. Very specific pattern for teratoma. Granulosa cells, tumors of small size. Be careful, very often they could be missed. It is a serious pathology. This is a granulosa cells tumor, was 18 millimeters in diameter. Also, if it is a mass with mixed cystic solid structure, you have to see very carefully to visualize it. So you should be very careful to very little masses in the ovaries. These germinomas are missed with small size. Why I'm talking about it? Sometimes due to very bright vascularization, we have to increase diagnostic search. For this germinoma, the lactate hydrogenosa is increased up to 3% FSH level, and also the hypercalcinemia. This is a very interesting image. What do you think about it? What do we see in the ovary? These are scars to see. So after follicle puncture, when performing ovum pickup, and here I managed to see the bleeding in the cavity, in cystic cavity. You see how the vessel is visualized, and this vessel confirms the availability of the bleed, and it is my great pleasure now, and I would like to have a big gratitude to my colleague Doshechkin, who makes a lot so we can merge, we could unite our ultrasonic findings, make them relevant for the clinical practice. And also my favorite and respected colleague Inessa Safonova, who every day, every week on Tuesdays, tries to perform her mission to introduce the ultrasound in the clinical practice. I believe it's a very important mission. I thank you for your attention. With love from Armenia. This is my grandchild, this small boy. We shall overcome, we shall win. Thank you for your attention. Thank you very much, Karine, for very good practical, very rich visual lecture. I already have messages from our listeners. They are very happy with what happens now. They are not very actively asking questions, but I believe towards the time of Q&A sessions, they become more active. I see that Inessa Nikolaevna joins us. We are very happy to see you, and we hope to hear to your presentation as well. And now, in our program, we have the presentation by Antonio Lamarca, a professor from He is the head of obstetric and gynecology department of Modena University in Italy. He is the person with a huge number of publications dedicated to reproductive endocrinology, controlled stimulation of ovaries, prediction of response to stimulation. Those who work for a long time in reproductive medicine do know him and do use Lamarck nomograms, having his name of his publication, to choose the start dose of FSH with controlled ovarian stimulation. Today we have the opportunity to hear to Antonio. He is completing and continuing the first lecture. First lecture talked about ultrasonic markers and criteria. The idea of Antonio's presentation is to show from the clinical side how such markers are used in the reproductive medicine and what other markers do they use in reproductive medicine and how do they use them. Now, let's have a lecture by Lamarck. Its name is How to Best Predict Ovarian Response to Stimulation. Please, Antonio, the floor is to you.
Thank you very much. Thank you very much for this very kind invitation. Let me thank the MSD company for having asked me to talk about the prediction of ovarian response to gonadotrophin stimulation. First of all, let's start from talking about ovarian reserve. Ovarian reserve is referring to the number of primordial follicles remaining into the ovaries of women. But what really clinicians are interested in is the function of a reserve, which is defined by the number of antral follicles which can be recruited by gonadotrophin stimulation. Interestingly, the number of antral follicles is a steadily constant relationship with the number of primordial follicles. That's why the number of antral follicles is declining with the physiological decline in the true ovarian reserve with advancing female age. Good news here are that we can measure ovarian reserve in vivo by measuring antral follicle count in the AMH and in the past day 3 FSH. We can retrieve information, reliable information, on the number of primordial follicles remaining into the ovaries. That's the main conclusion by this American authors articles published 10 years ago now. AMH is a protein, is a glycoprotein, which is produced by granulosa cells from primary and mainly small antral follicles, and the AMH is secreted into both follicular fluid and into circulation. That's why you can measure AMH into the blood of your patients. And if you measure AMH throughout female reproductive period, you will find a curve like this. This is the decline in circulating AMH with advancing female age, which is resembling the decline in ovarian reserve. From my point of view, this is another observation that AMH is really a good marker of ovarian reserve. AMH can be measured throughout the menstrual cycles because, according to many authors, AMH is stable throughout the menstrual cycle. Others have reported a small but significant decrease in AMH soon after ovulation. Probably the reason explaining this variability in AMH may be found in how basal level of AMH are. I mean, this is an interesting study in which women have been divided into 4 groups according to basal AMH levels. When AMH is low, AMH is stable. You see here the black line is indicating a high stability for the AMH. On the contrary, if AMH is very high, well, this is the case where you can find some significant variation in AMH in individual patients. For example, this lady had 8 nanogram in one measurement and 12 nanogram ml in another measurement. So probably the variability of AMH is depending on how high is the basal level of this hormone. Of course, AMH is a hormone, and as well as all other analytes you can measure into the blood, variability must be taken into account. You see here other markers that usually clinicians measure in patients. They have some intra-individual variability. So the variability found for AMH is not surprising, and this is in line with biology, I think. Also, variability for this hormone can emerge from methodology. Historically, we had different assays for the measurement of AMH, the DSL, the Immunotech, and in reality, these assays gave different absolute values for AMH because they used different antibodies to link and to measure this hormone. More recently, it was 7 years ago, the Beckman-Coulter introduced into the market the so-called AMH Generation 2 assay, which was believed to be the best solution at that time for the AMH measurement. But in reality, there were some problems with the original version of this assay. And this again introduced for some years some errors in AMH measurement. Also, the ELISA assay per se is not so reliable as you wish. There's a very high interlab variability when using the manual ELISA assay, and this may, at least in part, be solved by using always the same lab. So if you're using the ELISA assay for measuring AMH, please use always the same lab, because this will contribute in reducing the overall variability around this hormone. But the best solution came with the introduction of the new automated assay. I'm talking about the Beckman-Coulter or the Roche companies which developed the automated measurement for the AMH, which now is considered to be the gold standard. According to this independent validation study, the two automated assays really perform very well with a very short time to result, a very low limit of detection, and a very good coefficient of variation. So yes, this is the gold standard now for the AMH measurement. And as I said now, studies using this modern measurement tool for the AMH are accumulating and are in a very consistently way demonstrating the goodness and the reliability of this assay. As always, the AMH measurement assay changed. Studies on the physiology of AMH were repeated and repeated. So now studies on the AMH stability throughout the menstrual cycles have been repeated with the use of the automated access AMH assay. Interestingly, authors concluded again that AMH was overall stable throughout the menstrual cycle. As you can see here in the figure here in the middle, the stability of AMH could be demonstrated. But again, we have to look at individual patients to understand what's going on. And again, the conclusion here, well, each bar here is referring to the variability of AMH during 1 month in one single patient. And as you can see here, if AMH is low or within the normal range, we can say below 2 nanogram ml, well, the AMH is very, very stable, very low variability in each individual patient. if the AMH is below 2. But if AMH is high, you see here 4, 5, 6, 8, 9, 10 nanogram ml, then you can have a very relevant intra-individual variability. But here, for me, the concept is very clear. Even if AMH is highly variable in women with a high AMH, in any case, the right message is given to the clinician. I mean, if a woman has 9 nanogram ml for AMH, or if she has 14 nanogram ml, well, for me it's the same. When talking about IVF, I understand that in front of me, I have a patient with a very high ovarian reserve. In front of me, I have a PCOS patient. In front of me, I have a patient at high risk of OHSS. So no wonder to see this high variability in AMH values when talking about very high AMH concentrations. On the other side of the moon, we have the antral follicle count, and the antral follicle count expectedly is decreasing with advancing female age. And you have here the normal values for the antral follicle count we elaborated in 2011. This may be very useful for clinicians. As we saw for the AMH, also for the antral follicle count, there has been a huge improvement in the technology behind its measurement, great improvement in the ultrasound equipment, a great improvement in the quality of the images, a great improvement in the resolution techniques, and also the development of the 3D technology led to a significant increase in our ability to detect, identify, and counting antral follicles. So you see here how technology can really improve our ability to detect the antral follicle count, and nowadays we are able to identify follicles as small as 1 or 2 millimeters. The problem with the antral follicle count is, again, the intra and inter-operator variability, which of course can be greatly reduced with the introduction of the 3D automated systems. In order to possibly reduce the intra and inter-operator variability, I really think you have to create rules within your clinic, within your medical staff, to talk the same language. I mean, you have to create rules for a common setting of the ultrasound equipment and for the a common way of display ovaries on your screen and identify and count the antral follicles. And we recently published a list of rules which can be of some help for doctors when using GE, General Electronics equipped instruments. Ovarian reserve markers are very useful for clinicians for many reasons. Today I'm talking about the prediction of quantitative aspects in IVF, which means number of retrieved oocytes. This is an old story. I mean, many years ago, 14 years ago now, we demonstrated a very good correlation existing between AMH antral follicle count and the number of retrieved oocytes, which interestingly have been repeatedly elsewhere. I mean, there are now hundreds of articles dealing with this object, and in a very consistent way, authors could confirm the very good relationship between these two markers and ovarian response in IVF. This is the curve we calculated many years ago, reporting a very good performance, very similar performance of AMH and antral follicle count in predicting poor responders here in the left side of the slide, and the high responders in the right side of the slide. With cutoff values we calculated and reported. This was the basis for the introduction of AMH and antral follicle count in the Bologna per response diagnostic criteria elaborated by the ESHRE. Successive meta-analysis, individual patient data meta-analysis could confirm the goodness of these two markers and the similarity of these two markers in predicting poor response and high response. And as I said, the improvement in the technology is clinically significant. And this is the scientific demonstration of what I said. I mean, the overall improvement in the sensitivity of AMH and ultrafollicle count in predicting poor response and high response over the years because of the improvement in the technology we now have for the measurement of these two markers. Let's come at the performance, diagnostic performance of the new AMH assay. And we see that in the clinical practice, we can rely on just one marker, AMH or ultrafollicle count. It seems that, I mean, the addition of other markers is not useful in increasing the overall diagnostic performance of these two markers. So in clinical practice, you can rely just on one of the two. It seems that there is no role in combining both. And when using the new modern AMH assay, the cutoff value for predicting a hyper response could be 2.1 nanogram ml, according to this study coming from the Netherlands. And according to Americans, this cutoff value is probably 1.75 when we want to predict those patients at risk of high response. On the contrary, to predict poor response, 0.9, which is very similar to 1 nanogram ml we found 15 years ago. So 0.9 could be useful to predict poor response. And when we want to predict cycle cancellation, well, AMH and ultrafollicle count have a very similar diagnostic performance. A cycle cancellation can be predicted when AMH is as low as 1.5 picomole, which is 0.2 nanogram ml, or when ultrafollicle count is lower than 4 ultrafollicles. Very often I asked whether one marker is superior to another one, to the other one, and well, I can say that if we look at the clinical practice, at the real life clinical practice, I really think the two markers have a very similar performance. On the contrary, studies seems to say that AMH is superior, and it seems to be superior because of the low intra and inter-operator variability in its measurement. This is a post hoc analysis of two trials. Each row here, each line here is referring to one recruiting center. The blue line is the blue circle here is the diagnostic performance of AMH. The red symbol is the diagnostic performance of ultrafollicle count. And as you can see here, overall, the diagnostic performance of AMH seems to be superior to the performance of the ultrafollicle count. But again, I think the reason behind this is a lower variability, inter-operator variability for the AMH. Same results were shown in this European randomized multicentric control trial, in which different centers were recruiting patients, and 7 different clinics were recruiting more than 450 patients. For each patient, AMH and ultrafollicle count were measured, and well, as you can see here, the variability found between different centers was lower for AMH when compared to the ultrafollicle count. So, as I said, you can do your job relying on AMH or on ultrafollicle count, but keep in mind, I mean, that if you're comparing your own center with other centers, probably you may find variability in ultrafollicle count higher than when using the AMH. Coming to the use of AMH or ovarian reserve markers when using chorefolitropin. I think for this medication, the use of ovarian markers is very, very important because chorefolitropin is always inducing maximal ovarian stimulation. So I think is fundamental here for clinicians to identify women at risk of a hyperresponse. And to do that, you need markers of ovarian reserve, follicle count, or AMH. We wrote this concept many years ago. Ovarian reserve marker can must drive the correct use of chorefolitropin alpha. And very recently, we have published a multicentric study, prospective study, in which we measured the AMH and the antral follicle count, and we give chorefolitropin to more than 200 women, and we could calculate the cutoff value for AMH and antral follicle count, predicting poor response and high response. For the AMH, we had again 1 nanogram ml and 6 antral follicles. For a hyper response, we had 10 antral follicles or 2.2 nanogram ml. So in particular, when talking AMH, I think we now have many studies confirming that these are the right kind of values for the clinical practice. Take-home messages: AMH and antral follicle count have been relevant objective of clinical research, and they had a very quick translation into the clinical practice. This led to great interest by companies developing the tools to correctly measure the markers. In less than 20 years, many different antibodies and assays have been introduced into the market. All the assays are strongly related to each other, but they gave different absolute values for the AMH. The manual assay shows some imprecision that could not be acceptable by clinicians aiming to base the therapeutical decision on the AMH itself. The variability in the manual assay also depends on the lab and operator's experience. The automated assay represents an expected improvement of the AMH measurement and is associated to reliable results. The time to results is very low, and also costs are expected to be reduced. This may permit a wide diffusion of the assay itself. Huge improvement in the technology behind antral follicle count measurement led researchers to continuously revise reference range for this marker, still waiting for a consensus on what is normal at any specific stage. The most recent machines tend to give values for the antral follicle count higher than the oldest equipment. The 3D software is greatly contributing in reducing intra and inter-operator variability. Soonway VC, the 3D version of the antral follicle count, is the last update version of the software. Its performance seems quite good, but low diffusion among clinicians. No significant superiority of one marker over the other in terms of different clinical outcomes in IVF results, but from published trials, it seems that the MH may have a better performance in predicting ovarian response to stimulation. Thank you very much for your attention.
Thank you, Antonio, for a brilliant lecture. And as already mentioned, I ask everybody to use your possibility to ask questions. Moreover, Antonio, unfortunately, will not be able to be present during the discussion because he has a very hard operational day. He apologized And he was sorry for being with us only during his speech, during his lecture. He will not be present during Q&A sessions. We will try to answer questions to his presentation. And now we have time for the next presentation of Karine. Antonio saved 10 minutes for us, and that's wonderful. So Karine, the floor is to you, and the next topic of your presentation. 3D ultrasound in the diagnostic of main gynecological pathology associated with subfertility. We are concentrated on subfertility here. And the 3D and the possibility of 3D ultrasound recently opened more and more opportunities for us, taking into account relatively new data on the role of, for example, the uterine septa in the formation of, in the generation of recurrent miscarriages. I believe Karine will tell us about this. Thank you very much. Notwithstanding, there are many data from the literature already, old ones. Nevertheless, the introduction of 3D into our day-to-day practice is a little bit delaying. The doctors who have very good modern ultrasonic devices with these functions, they do not use those functions, maybe due to the lack of time for training, or they maybe believe those functions could not add much to their diagnostic research. I inform on no conflict of interest. Let's switch to the topic of the lecture. We know all main reasons of infertility. I would like to draw attention to the so-called fertility of uncertain etiology, which makes about 10%. Certain authors say up to 15% of all infertility. Do we always in our clinic practice consequently and really using all available visualizations method up to now? Since 3D sonography appeared, there are discussions about whether it expands our diagnostic possibilities. In the obstetrics, it is already a well recognized and broadly used method. In gynecology, it is not so. Although, to my great pleasure, recently, and also in our professional networks, I see that the doctors start using it very actively. The advantages of voluminous sonography, 3D sonography, consist in that, for example, we can see simultaneously 3 different planes. We can perform rendering in the planes which are not accessible for 2D mode. What is most important, we can see the coronal plane, and also the inversion modality, tomographic parallel slices, the possibility of archiving, the possibility to send volumes for revisions. These are the options which help us a lot in our practical activity. The most important advantage of 3D in gynecology is exactly coronary plane. Similarly, MRI coronary plane shows the angles, the external contour of the uterus, the body cavity and cervix of uterus simultaneously. The quality of 3D ultrasound, you shouldn't forget about it, depends upon 2D ultrasound quality, and the volume rendering should include difficult angles. Only in this case we shall have correct and reliable information. See how well the isthmic sections are seen, the isthmuses of the tubes. And also we have to remember that the image of uterine cavity, depending on cycle phase, is changing. In the first phase we see acute angles and isthmical section of the tubes. In the second phase, these angles become rounded and becomes difficult to get good image of tubes. These are the advantage of 3D. We can simultaneously see internal and external contours of uterus. The technical parameters are sagittal section. The patient has to hold the brace, not move, and the technical parameters are shown here in the slide. And it should be made at 17th to 25th day of the cycle, not to forget about it, because the doctors very often send women to 3D scanning as the first phase of the cycles, and it can be difficult at that time. The 17th to 25th day of the cycle is an ideal time for 3D ultrasound. Limitations of the method, dependence upon the menstrual cycle phase. We already mentioned it. Thin endometrium reduces diagnostic possibilities of coronary plane. Large uterine myoma prevent from getting this coronary plane, and this is a problem which engineers were solving, namely in general electric, for a long time. Impossibility to get a correct coronary slice with torso uteri when it is rotated around its axis. I don't have such a transducer up to now. Matrix transducer BP21. They say the transducer solved this problem. Modern scanning techniques, 3D scanning, which we broadly use in our activity, are OmniView, rendering, contract sonohysterography, with tomographic slices rendering, contract sonohysterography with AVC, sonohystocervicography, and the definition of different volumetric indexes. Let's dwell on the images which could be received with use of different modalities. They are not much different in the sense of advantages of one modality over other, so you can choose what you like better. I can dwell here on the quantitative assessment, which is allowed by hysterosono-AVC option, meaning one cavity of uterus is just filled with contrast, and the option is switched on. And this quantitative assessment, according to Ludwig and Martens, is more informative than all other measurements we do in standard modality of 2D for definition of uterine septation. What's important here? Look, with this option, you can determine the volume of uterine cavity, and it is obviously very important to predict reproductive outcomes. Another option, volumetric index, septation index C, you can separately calculate the volume of each section of uterine cavity, those areas we are interested to, and the residual volume as well. And obviously we understand that chances to bear good pregnancy in such uterus are much lower than in such one. Now there is a trial to somehow systemize, standardize it, and to get the threshold values. Sonovaginal cervicography, you can see perfectly two cervixes here, and the genetic pathologies. The 3D sonography helps to establish it. There's a list of it on the slide. Let's dwell briefly on congenital malformations of uterus. It is difficult to find the real rate of uterine anomalies. It is generally recognized that this pathology is accounting for 7% of general populations, and the women with infertility and recurrent miscarriages, this number is from 8 to 16%. According to certain authors, even up to 32%. It is difficult to establish true rate because uterine abnormalities are very often missed with routine 2D scanning. Very often the history itself says, please look for uterine abnormality. With the previous introduction of 3D ultrasound, there was a new effort in discussing uterine abnormalities. We could see it in its different variants. And now we understood the doctors have got a method which is not worse than MRI. At the same time, the doctors were confused with different classifications, how to standardize. This is a famous slide of Beryl Benacerraf of 2012, from which everything started. This is the dilemma of two cavities with 2D ultrasound. You see in the top, you see the longitudinal plane section of the uterus, practically the same image in uterine cavity. You see how different are uterine cavities in 3D ultrasound. These are my cases. You see absolutely similar, absolutely equal uterine cavity structure in 2D ultrasound. In one case, such a broad septum. In another case, we have such an image of uterine cavity. Simultaneous visualization of external uterine contour allows us to differentiate bicornal uterus from a broad uterine septum. It's a clinical case. Primiparis of 29 years, preterm delivery at 29 weeks, due to seems a normal image of the uterus in 2D ultrasound due to exclusion of all other reasons. In this case, we can assume uterine abnormality. We switch on the 3D ultrasound and we see this is a hemiuterus or a unicorn uterus, which has the most frequent rate of infertility, up to 20% of recurrent pregnancy, and also high extrauterine pregnancies with this technology. Currently, the most applicable are three classifications which used as morphometric criteria: prolapse or indentation, and the different translations into the Russian of myometrium in fundus area. Those are classifications of ACRM. This is the classification of Escher, and new classification. This shows the uterus which corresponds to all three classifications, definitions of the septum. The first, second, and third classification. Such uteruses are found rarely in the clinical practice. More often they correspond to one of the definitions. This slide shows the parameters which could allow to refer it to septated uterus according to one of these three classifications. Very quickly, this is well-known American classification, including 7 classes. First 4 with subdivision on subtypes, 5th and 6th are saddle type septi. According to American classifications, we have the definition of saddle-shaped uterus, and the 7th class, the T-shaped uterus. This is a European classification proposed in 2013 by European Society of Human Reproduction and was updated in 2016. This classification created by working group on Cornuta, which included 90 researchers from all over the world. This classification is based upon anatomy. It includes 6 classes with relevant subclasses depending upon the anatomic variants and clinical presentations. The 6th class are non-classified cavities. This slide shows parameters according to which a uterus could be referred to one or other classification. We shall not dwell on it. It is a topic for separate lecture. Let us just mention that, in my opinion, the lack of European classifications is that they use the thickness of uterine wall to define septation degree. The difference between tubal angles first is defined, then the thickness of myometrium in this area, and is correlated with uterine wall thickness. But we know that uterine wall thickness can be different in different women. why two uterus with equal degree of convexity are normal according to American classification. Depending upon myometrium thickness according to European classifications, they could be considered as septated to the left, although this distance is equal in both cases. Why so? Because this distance resulted to be over 50%, more than half of this thickness. In this case, it will be less and will be considered as normal one because this distance was less than 50% of myometrium thickness. In 2015, a study was made on comparative assessment of European and American classifications for identification of uterine septa, with 261 patients included random sampling. It was found out when using criteria of European Association that diagnosis of septa was established 3 times more often than when using American classification. Most of septated utera, according to European classifications, were classified as arcuate or normal according to classification, to American classification. From the point of view of authors, it is incorrect to use myometrium thickness because it gives errors. Normal or arcuate uteri could be classified as septated with irrelevant, ungrounded, unjustified interventions further on. So to have a consensus, in 2018, a group of experts consisting from 15 persons studied sonograms of 100 women. 4 different techniques of scanning were used. So to conduct clear differentiation between normal or arcuate uteri and septated ones. And the most relevant were found to be the criteria of the depth of prolapse over 10 millimeters. I also believe it's correct classification. I believe it's the most simple and the most relevant one. From those 100 women, according to European classification, 80 were established uterus with septa. 20 from them were recognized normal. The criteria is that 50% more or less of wall thickness. According to American classification, only 5 uteri were recognized as septated. 82 were recognized as normal or arcuate, and 13 were non-classifiable, not covered by any classifications, with the relevant criteria shown as well. According to this new study, or expert consensus, expert opinion, 18 uteri were recognized as septated, 82 as normal. According to expert opinion, the best criteria are the depth of prolapse over 10 millimeters and this angle of less than 40 degrees. Here, to illustrate, you see the same, let's say 20 women with uterine septa according to European criteria are in white shirts, and the only one woman with septated uterus according to American criteria. In 3 cases, the uterus will be recognized as septated according to QMIS study criteria. Practically, according to European classification, 16 septa, which were classified according to European classifications, were referred to normal variants, or arcuate or saddle-shaped uteri. A conclusion about this issue: how relevant are all those findings? How much the saddle type of the uterus or availability of septum will impact the reproductive function? we know that there are women with rather marked septa, but they have good pregnancy, good delivery, and there are women with all the other infertility reasons excluded and recurrent miscarriage. In such case, uterine septum can be a reason for such reproductive failures. It's recognized currently that infertility, the frequency of septated uterus establishing is not higher than in general population. According to American classification and QMS, the rate of establishing diagnosis of septated uterus is associated with histories of miscarriages. Reliably high percentage of uteri classified according to HRSG as septated one was clinically non-relevant. In this case, due to the limitation of small size of sample. A practical application, only clinical relevance of the definition of the diagnosis justifies their use for clinical protocols and patients management. It's possible that the diagnosis of uterine septum, according to ESHA, could be iatrogenic. Studies appeared recently. The presentation by Nick Rainey Finning in ESHRE 2019 Congress trying to associate reproductive outputs with the stabilization of uterine septum, with vascularization of uterine septum. Also, the length of residual cavity can be a prognostic factor. We already mentioned about septal vascularization and also endometrium volume. When it's impossible to perform 2D, because it's a rather frequent question, both during 2D, how could we suspect septated uterus with 2D? We shall try from sagittal scanning, then we pass to longitudinal plane. See, in one case, we see that the endometrium is merging, is adjoining. In such case, we shall have arcuate, most cases. In other case, you see how deep it passes. The septum divides the cavity of the uterus. That's how, in longitudinal plane, we can suspect availability of septum or other abnormalities in uterine cavity. I would like to address now to U1 class, according to European classification, the so-called T-shaped dysmorphic uteri, which are subdivided on T-shaped and infantilis. What is the difference between them? You might not well see it on the picture. With dysmorphic uteri, we have a normal outside contour, thickened lateral walls, and abnormally narrow cavity. With T-shaped, 2/3 are occupied by uterine body. With infantilis uterine, 1/3 is the body and 2/3 is the cervix. That is the definition proposed by this classification. Also, pay attention, with T-shapes, lateral wall thickness is rather well expressed. With infantile uterus, it's less so. The anatomic substrate of that is hypertrophy of internal circular muscular layer with formation of rings which press on the cavity of uterus. That's how you can see it on hysteroscopy. You can see different shapes of T-shaped uterus with 3D ultrasound. Why should we focus on this? Because T-shaped uterus is one of the reasons for uncertain etiology infertility. The variants of T-shaped uterus have been recognized. Pacheco and co-authors presented the description of those variants. Mainly, it is based upon subjective opinion. I know that the researchers now are trying also to develop the quantitative parameters to refer a uterus to one or other subtype. With T-shaped uterus, we see the thickened lateral walls. That is a subjective study. The narrowing of middle and third cavity and normal distance at the wall. With another type of uterus, we see second lateral walls, narrowing of middle cavity and decreased distances between the ostia. And now another type of uterus, very thick lateral walls, narrowing of the ostium. The uterus has a tube form all over its length. This slide also contained, I had a slide with our 2018 information, which found out that the tube-shaped cavity of women is predominant in women with adrenal cortex dysplasia. So I urge you to focus on that direction. So this was one of the first studies on the impact, on the influence of T-shaped uterus on reproductive outputs. 26 T-shaped, 25 septated, and 25 normal uteri were studied, and it was found out that the T-shaped uteri can be more significant, can have a high 62% in infertility population. So to establish the diagnosis of T-shaped uterus, the measurement of lateral angle should be made, and also the correlation of wall thickness in this area, cavity broadness in this area and this area. August 2019, the criteria for assessment of T-shaped uteri were developed based upon a consensus between 15 experts, taking into account the highest number of votes in favor of one or other morphokinetic criteria. And the beta consensus between experts have got 3 morphokinetic measurements shown here schematically. The lateral angle should be less than 130 degrees. The thickness of myometrium in lateral wall when we pass a line connecting the tubal angle with internal loss. This myometrium thickness to this line should be over 7 millimeters, and T angle should be less or equal to 40 degrees. This is how it looks out in echogram. You should note when there are 2 criteria, this is a borderline sign. The uterine is a borderline. If there is only one criterion, is the uterus is normal. How to suspect T-shaped one? We start from longitudinal plane scanning. You see exactly how endometrium was irregular in case of septated uteri with very insignificant turn of the transducer. You see this line of endometrium is broken. We put 3D, and this is such a configuration of this uterus. You should be careful, because sometimes the contraction of myometrium simulates availability of this lateral angle. To remember how this uterus was appearing in the beginning of the slide, and now you just have to wait for a few minutes for the contraction of myometrium to resolve, and we shall not have a diagnostic error in that case. Fernandez proposed the pre-surgery assessment of T-shaped uterus. See the distance he proposes to measure. Those are the parameters we have to describe in the report to be used by the doctor who will perform a hysteroscopy for him to know the depth of resection in the area of lateral angle. Another study proposing somewhat different hysteroscopic correction technique of T-shaped uterus. 3 insections are proposed here, and the data shows that after hysteroscopic correction, we see significant increase in average volume of uterine cavity, and other parameters are improved significantly. After all we said, a question comes: is hysteroscopy same as before a golden standard for uterine abnormalities established? And according to Beryl Benaceral, stated at ISO 2017, 3D currently is a golden standard to establish diagnosis of uterine abnormalities. Next pathology we should dwell briefly are myomas. Obviously, we shall dwell only on those which have to do with infertility. I know this is one of the most frequent gynecological pathologies, and we, as reproductologists, are interested first of all on the impact of myomas on reproductive outputs. We have to answer three questions here. Is the cavity of uterus intact? Should we remove what we see inside the cavity, and how could we and should we remove it? In 2015, a group of Musa group proposed to standardize the terms, definitions, and measurements to describe sonographic sheets of mammary and uterine masses according to a classification proposed to figure the number of nodes, topography, and the relation to cavities being assessed. The 3D study and the 3D schemes allows us to very accurately determine the topicality of the nodes and its correlation with the myometry. I will not now list all the nodes, they are on the slide. How the 3D ultrasound helps us? Sometimes the submucous nodes of grade 0 or 1 are rather well seen with 2D ultrasound, but their true size and their relation to the areas of uterus, their topics, is better seen on 3D ultrasound. Another example. Video doesn't play here. A submucous myoma. Not quite sure, especially see what shadowing is here, where it finishes. It's difficult to grade here in 2D. On 3D, we see absolutely clearly that this node is most of grade chosen one. Different examples of submucous myomas. When the node is very difficult to outline, to contour, we can't understand where it starts, where it finishes. On 3D ultrasound, you see this picture, it has such a configuration. Its smaller part is inside uterine cavity and a larger part is inside the myometrium. And similar example. And we can be confused here. On 2D, it appears to be grade 2 node, but really it was, and it was confirmed hysteroscopically that this node with its greater part is inside uterine cavity. So the 3D ultrasound allows us to avoid diagnostic errors. In this case, what do we see? Once more, the node is completely interfering the cavity of the uterus. In the lateral wall and sagittal section, we don't see the cavity. But the 3D ultrasound allows us to see that the cavity of uterus is intact, although a little bit narrow for such a large uterus. The 3D ultrasound allows us to clearly, in case when the doctors, due to some reason, would like to enucleate the node, to define, to measure the distance to cavity. We can write here the relevant distance, 2, 3, or 7 millimeters, for them to avoid perforation of uterine cavity wall in case of another case. When there is a node, it gives some shadow, not quite clear with 2D scanning, where it finishes, where is the border. You see, in 3D case, we see that only a small part of the node is found inside the cavity, but the major part is found in the wall. In this case, a protrusion coefficient of the node was proposed to be used, which allows us to define the level of protrusion and suggests the doctor hysteroscopist whether it could be one stage enucleation or two steps enucleation. A is the part of the node inside the cavity and B part in the myometrium. The coefficient is found by dividing A distance on B distance multiplied by 100%, and the clinical significance of this ratio, this coefficient, is believes that the myomas greater than 38 millimeters with protrusion of less than 43% should be removed in 2 steps. This can be useful to our patients. The management of myomas in subfertile patients. Basically, data are shown here. New data and very new ones. The removal is indicated at any myoma deforming the cavity of the uterus, grade 0, 1, 2. The removal of submucous nodes increases the spontaneous pregnancy rate. It is seen the improvement of reproductive outcomes when removing intramural nodes greater than 40 millimeters. There are no evidence that removal of subserous nodes improves IVF efficiency or spontaneous conception efficiency. No proofs that GnRH analogs before surgery improves performance of IVF or reduction of miscarriages. Next pathology to be seen, adenomyosis. This slide shows the uterus with several signs of adenomyosis in 2D study. We shall not list them all now. Let's see what the 3D ultrasound gives us in the diagnostics of endometriosis. In 2018, Isaac with co-authors proposed to establish diagnostics endometriosis depending upon the difference in thickness of junction zone of 74 patients. We studied 32 of them had adenomyosis, 37 myomesis, had myoma, and 5 had normal utero. It was found out the junction zone could be described as regular, irregular, interrupted, non-visible, or non-accessible, according to IoT. In research goals, any distortion of junction zones should be described like cystic areas, hyperechoic points, according to their protocol, to the report. To calculate correlation of JZ and uterine wall thickness, all the measurements should be made on one frozen slice. So you choose the best slice from your point of view, and all measurements you make on that slice only. If junction zone is visualized poorly or if it's not identified, you should mark it as unmeasurable. The value of junction zone distortion is expressed as a difference between maximum and minimum junction zone thickness. The degree of remarked irregularity of junction zone is expressed in the subjective assessment in percents of junction zone, which is being exposed. The assessment could be made for the uterus as a whole or for each site separately, and the interruption of the junction zone can be produced by focal infiltration of endometrial tissues. But endometrial contractions also can result in junction zone changes. You should be attentive. See how regularity of contours is appearing. We see the protrusion of endometrium very well here. To the left, the signs of adenomyosis are listed in 2D and 3D. We know when there are at least 2 signs from the described, the diagnosis of adenomyosis can be believe that's correct one. With 3D, you propose to assess the distortion of integrity of hypoechoic junctions on by the endometrium, which infiltrates its junction maximum thickness over 8 millimeters and the difference between maximum and minimum values over 4 millimeters. The sensitivity and specificity of the science for establishing diagnosis for adenomyosis are relevantly shown here. See how the normal junction zone is looking and how it appears in case of adenomyosis. Diffuse adenomyosis. We don't see normal uterine contour practically. The whole uterus is kind of eaten different degree of marked adenomyosis is now being recognized. Subendometrial insula can be seen, islets can be well seen with 3D study. Here we'll try to see, this is 2D ultrasound, the sagittal plane of uterus is not so good. It's difficult to suspect maybe some irregularity, but no direct manifestation, direct signs of adenomyosis. Moreover, there is no spheric shape, thickening of the well. We don't see it on 2D, but on 3D we can see expressed signs of myometrial protrusion to the wall of the uterus. Another sign having high diagnostic accuracy is, this is the thesis of my disciple. This is a US science of adenomyosis having high diagnostic accuracy with diffuse adenomyosis. The deformation or unusual shape of uterine cavity with irregularity of contours. You see due to local myometrium hyperplasia and increased area of uterine cavity as well. These signs allow us, when we want, for the purpose of treatment, to use intrauterine contraceptive agent. It allows us to avoid this because the expulsion of this intrauterine device is for sure to be happening here. Also, the scarring, endometrial scarring is also definable. All cases confirmed hysteroscopically here, and the ultrasonic diagnostics of endometriosis with absence of its clinical signs is not an indication for hormonal treatment. When we say endometriosis, we shall not be very surprised and we shall not scare the patient like it happens frequently. Often in Armenia, I don't know how about Ukraine. If the patient has no claims, if the endometriosis is not clinically manifested, we just follow this patient. These are international guidelines on clinical treatment of endometriosis associated with infertility in symptomatic patients. I will not list all of them. You can just take a photo. Next pathology is polyps. Would seem polyps are very well establishable with 2D, especially when using contrasts and sonohysterography. Let's not dwell on this, on polyps. They are found in 10 to 26 women with infertility of uncertain etiology. They can be single or multiple, few millimeters to few centimeters. They can be transient, may disappear after menses, or can be manifested during certain days of menstrual cycle. I was seeing a lot of such patients. This transiency is specific for small polyps of less than 10 millimeters. They could not be identified at the time of treatment. So please don't throw stones to your colleagues which could see this polyp last month. In 1 or 2 months you haven't seen this polyp in this patient. It happens. In this case, how the 3D ultrasound helps us. These two small polyps with 3D ultrasound were missed, but their presence was confirmed hysteroscopically, and the largest polyp you can see it well in 2D and 3D ultrasound. It's very important in such case also to use Doppler. Just to remind about it for our colleagues, the sensitivity of Doppler is up to 95, specificity is up to 80, and the best method of sonohysterography shows the relevant sensitivity 95, 92, specificity 81. Are polyps impacting on infertility? Should they be treated, or can we believe we could ignore them? That it is a physiologic variant of proliferation? I believe it depends upon the size and location of polyps. Look, in this case, we see a huge polyp which practically covers the entrance, the ostium of uterine tube. In this case, obviously, this polyp will be impacting on subfertility or infertility. It is reasonable to remove polyps larger than 10 millimeters, in the opinion of the author. Although I had cases when pregnancies were occurring and without complications were developing with multiple polyps. Certain of them were over 10 millimeters in size. I haven't found this video just to show it to you now. This is a diagnostic difficulty could be produced by polyps on a broad base. They are missed with usual 2D study, even with 3D study sometimes. Although personally, I believe the sonohysterography helps me a lot. If you see the slices, determine the slices correctly, you will see any polyps on the broad base. You see that sonohysterography helps to find out polyps on broad base. Our next pathology, we shall dwell on it, are intrauterine synechiae. The true rate is not known. 20% of them happen after intrauterine interventions. The ultrasound is a very good way of assessment of therapy efficiency. The sensitivity is rather high. 3D ultrasound helps to define the level of development of the adhesive process. Could be from moderate to complete obliteration, infringing the menstrual function and obviously significantly impacting the infertility. Menstrual cycle violation is a risk factor. Asherman syndrome rate is increasing 12 times. The hysteroscopy is a golden standard for diagnostics and treatment, combined with antibacterial prevention and further additional treatment, including systemic estrogens and intrauterine contraceptives, gives good indicators for pregnancy and live birth. Intrauterine synechiae. Shouldn't forget that the most frequent complication after hysteroscopy in reproductive age women are those, and their rate correlates with availability of intrauterine pathology. Sometimes we observe scurry changes of uterine cavity and obliteration of uterine cavity as well. You see how remarkably is expressed one part of endometrium, another part disappeared in cavity image. On 3D we see like of a hemi-uterus. Also, in reality, this part of uterine cavity has been obliterated completely. What are the etiologic factors? Traumas, injuries after birth curettage, the curettage after miscarriage, abortion, and also the myectomy, septum resection, polypectomy, embolization, infections, and estrogens deficiency. The rate of spontaneous miscarriages due to synechiae is about 40%. After successful therapy, this frequency is significantly decreasing. Should remember that synechiae could produce higher risk of abnormal placentation, including placenta accreta, high risk of pre-birth bleedings, IUGRs, and preterm births. This is a clinical significance. How should you define the degree of obliteration? By the area of obliteration and this area of obliteration is divided on cervix area and multiplied by 100. That's how we have quantitative indicator. 2017, the Advancing Minimally Invasive Gynecology Worldwide Organization proposed the relevant classification for synechia. You can take a photo. The treatment of intrauterine synechia is multi-step one. It assumes restitution of normal uterine cavity, repairing or restitution of endometrial function, support of endometrium, prevention of recurrences. Hysteroscopic adhesiolysis could be made without assistance, with laparoscopic assistance, with ultrasonic assistance, and the concomitant therapy, high doses of estrogen, intrauterine systems, and once more the adhesive technique. I want you to take a photo of this slide, which in 2013 was proposed, 2017 was proposed by Jurkovic on ISO Congress about the management of patients with synechia. It is focusing on reproductologists. In the same report, this was the conclusion of it. The true prevalence of intrauterine synechia is not well known. The systemic review showed that adhesions after curettage of uterine cavity appear at every fifth patient. The 3D ultrasound is an efficient test for synechia establishment, assessment of their severity, need for assisted surgery, and assessment of treatment result. The women with intrauterine synechia have an increased risk of unfavorable outcome of pregnancy. All women with intrauterine synechia who plan to have pregnancy should be proposed treatment because, notwithstanding pregnancy occurrence, it could be a complicated pregnancy. We already discussed it. I like very much this systemic review and meta-analysis of 2017, which shows that the 3D sonohysterography with saline infusion, saline contrast, is a highly specific, highly sensitive method of study comparable to hysteroscopy. All patients with suspicion on intrauterine synechia should be referred to 3D SCSH. In the same kind, certain cases of moderate intrauterine synechia could be separated during this SCSG with simple and minimally invasive technique using the catheter or ballooning of cavity. This article describes cases of successful balloon and catheteric dissection of synechia with a detailed description of 4 steps technique. You can read this article. Another option which allows us not so to predict infertility, but to improve our IVF results. In 3D diagnosis, we find a point of maximum potential of implantation. There is a referral, a link to authors, and systematic Cochrane review showed that the reliable improvement of pregnancy rate and birth rate with IVF with OS assistance and embryo transfer increased from 25 to 46%. And embryo transfer, if you perform embryo transfer into the point of maximum implantation potential, that is how this distance is being measured individually for each patient. This report shows that this point, for example, is found 23 millimeters from os internum. In this case, the authors believe that it improves efficiency implantation from 34 to practically 50%. And the next practical application of ultrasound is quantitative determination of volume. Modern devices do have this function. You have to know how to use it. Why we do it? Because the data are rather controversial. How to do it? The volume endometrium should be determined during ovum pickup or embryo transfer. Sometimes the doctors refer the patients at third, fourth, fifth day of the menstrual cycle. No, at the day of ovum pickup or embryo transfer. It has been established a reliable reduction of pregnancy rate when the volume of endometrium is less than 2.5 centimeters, cubic centimeters. The implantation practically becomes impossible with the volume of endometrium of less than 1 cubic centimeter. That's how it is conducted with a simple manual outlining of uterine cavities, a quantitative Dopplerography, Doppler angiography of endometrium and of subendometrium could serve a predictor for receptivity. Endometrial receptivity. Rain Fennick showed in his studies the cyclic changes of vascularization of endo and subendometrium characterized by pre-ovulatory peak, post-ovulatory reduction, and maximum values in implantation window period. Most of the modern studies have shown reliable vascularization index at the day of ovum pickup, which shows the relevant response to gonadotropic stimulation, and the quantitative 3D Doppler assessment and blood flow assessment is highly accurate. The vascularization index, flow index, meaning intensity of blood flow, the volume of blood cells moving inside the vessels, and vascularization flow index showing the perfusion of the organ. You should learn how to determine all those parameters. Histogram. This is defined. You show with calculation of all the above mentioned indexes. We see rather high numbers of vascularization flow index. It's believed that for this endometrium, the receptivity is rather high. Another option, if due to some case there is a local disorder of endometrium vascularization, we can choose separate region of interest and to calculate the vascularization in every separate region of interest. That's how it could look out. This is the voluminous rendering of endometrial vessels. In case when pregnancy occurs, what's important? In one case, we do see vascularization. This kind, it is poor and weak. In other case, we see an expressed endometrial vascularization. What it gives us? In case pregnancy occurs in absence of intra and subendometrial vascularization at the day of embryo transfer, more than half of those pregnancies could result in spontaneous miscarriages, according to the opinion of authors. It can be made very simply. You just should start to learn and should start to do it. Upon permission of Irina Arkadyevna Ozerska, I would like to show you her slides, which were shown by her in her lecture. Blood supply of uterine endometrium with chronic endometritis is also changed depending upon the morphotype. For example, with hypoplastic morphotype, we shall see hypovascularization of uterus endometrium, increased RI of uterine arteries, reduction of arterial perfusion index. How all this is defined? With 3D local, and also the blood supply of uterus and endometrium with chronic endometritis of mixed and hypoplastic morphotype is quite different. We see the hypervascularization of uterus and endometrium due to disorder of venous outflow, and also the parameters of blood flow in uterine arteries and perfusion are shown here in histograms. All those are very useful options. Let's very shortly dwell on the nexus where how 3D can help us here. tomography of slices in the diagnostics of adnexal masses help us. In this case, we see ovarian cyst. In another case, we see hydrosalpinx. When we perform these slices, we see practically one and the same image of ovarian cyst. In case of uterine tube, ultrasonic tomography allows us to differentiate. You see how this image changes from first to other slides, how clearly we see on the next slices that it is exactly the intrauterine, it is uterine tube. Ovarian cyst. It is adnexal mass which is visualized as ovarian cyst, but it is really a tube, a uterine tube. In this case, it is very unclear contour. You cannot see where the ovary, where this tube. The 3D helps us to see the uterine tube. In this case, at the background of expressed inclusion cyst of peritoneum, this patient was referred with a diagnosis of a large hydrosalpinx. We included VCI option, and we saw clearly the fimbria of the tube and the whole tube along its whole length at the background of this inclusion cyst of peritoneum. With diagnostic difficulties, you should use this option as well. It's once again very frequently the colleagues ask us to explain how it's conducted, but due to lack of time, I will just try to jump to the next slide. And we can see this final image. Practically, you can see the intact uterine tube at the whole length of it. We already mentioned it. This 3D ultrasound allows us to accurately count the antral follicles. All the options, we already discussed them today, allows us to determine ovarian volume, which can help to predict IVF failure in cases when it's less than 3 centimeters. The failure will make above 50%. The 3D ultrasound helps to find follicles not containing tumulus ovorus, because as a rule they don't contain mature oocytes. We already mentioned it. And finally, the 3D ultrasound helps us to find out small masses in ovaries, which is difficult to see in the non-changed, non-increased in size ovaries with 2D ultrasound. This is a small ovarian teratoma. I want to conclude with the words of Beryl Benasera, who believes that 3D ultrasound will give to a gynecological patient more than to, will be more useful to him than to obstetric patient, and it will be used routinely very soon in the gynecologic practice. Good thanks, we see it already to happen. Our colleagues are now actively using it. I want to thank everybody for attention and to conclude with this slide. I love very much this picture. These are two greatest values of Armenian people, a child and our Armenian bread, which codes this child. Thank you for your attention. Thank you very much, Karine, for your, as always, wonderful lecture. The only which frustrates during this lecture, we would like them to continue, not to finish. Thank you very much. It was a wonderful lecture. Our colleagues from the lecture hall are more active. We have a little bit shifting of timing, and we are constrained now to start a little bit later the presentation of Ines Nikolaevna, but I believe it's quite necessary now to ask questions. We have not very much questions, few questions, couple of questions we have. I don't know what plans Karine has, but meanwhile we are all together here. Inessa joined us. Ines Nikolaevna joined us. And Karina is not still away. Let us answer the questions which arrived from our audience. The first question, a rather interesting one. Our colleagues asked to share some unique case from your practice, maybe some anecdotal case, preferably with good outcome, when the patient with uterine abnormality had a pregnancy and everything resulted in good outcome. Maybe not in very good, but better to be good outcome. You know, it is a very interesting thing could be observed here. Same as populational rate of polycystic ovaries is rather high. I don't know what is the reason. Maybe our nation is old one. Maybe we don't have mixed marriages. Very little of those, and those defect genes are circulating in our population, and the rate of abnormalities is rather high. Unfortunately, to our shame, there is no official statistics. Every reproductology center in Armenia has its own statistics. What I paid attention to for a long time ago, when corresponding with Ludwig, sometimes we exchange our cases with him. And T-shaped uteri, he said, I have just observed 2 cases of T-shaped uterus during my practical activity, but there was a day when 3 patients with T-shaped came in. All of them has hyperandrogenism. 2 of them have a congenital dysfunction of adrenal cortex. Maybe the patient from reproductology centers are referred to me who already passed all circles of infernum. They were treated in all possible places, and finally they come to reproductology centers. Those are patients with unfound, undetected, but available pathology. There can be several of cases you're asking for the bicornual uterus with very narrow cavities. For example, no possibility of pregnancy prolongation was assumed there, but that woman delivered in term, even not preterm, and the child was healthy and normal. Normally, when I see a uterine cavity abnormally, taking into account the hysteroscopic complications especially, but the synechiae, I don't know how about Ukraine, but we rather frequently observe after hysteroscopic resection the synechiae. And we have to do it a second or third time. Normally, I do not recommend to refer to hysteroscopy. I warn very carefully. You try, but there may be unfavorable outcome, and the woman decides herself about what to do. There are rather many of such cases. Unfortunately, I haven't prepared them beforehand. Next time I will include them into the lecture. I remember that case I am talking about now. That woman decided herself, yes, I want to prolong pregnancy. And then happen what happens. And she perfectly delivered the child. Inessa, same question to you. I will try to reword it. The pregnancy in patient with uterine abnormality, which surprised you most of all? Good morning, you hear me? Yeah. First of all, I'm very happy to participate in this forum. Thank you very much for the invitation. It's a great honor for me. I don't know how anecdotal case, but the pregnancy with intrauterine septum abnormality, it's a pregnancy connected not only with early reproductive losses and early miscarriages, but also with later pathology, perinatal one. We had a situation of placentation in the area of septum, septal placentation and IUGR, you have to take into account also such kind of obstetric risk, perinatal especially. Also, when developing the tactics, consulting the patient, taking decision on hysteroscopic metroplasty, you should take into account not only early reproductive losses, but also further course of pregnancy, later pregnancy as well. Thank you very much. Second question we have, I believe it will be not a surprise for the lectures. In your opinion, what is the threshold size? What is the size of myoma node would be an absolute contraindication for IVF? It depends, first of all, of location, not only of the size. If the node is over 4 centimeters and it is located, it is subserous, it is not interfering. Myomatic node, if those are grade 0, 1, 2, are subject to hysteroscopic removal and are contraindication to IVF. Cases can happen when pregnancy could occur, but a very low number of those pregnancies should be prolonged and are normally prolonged. Thank you, Karine. Inessa, what would you comment? I believe it is not a question to me. Regards tactical recommendation, I am purely involved in the diagnostic. I'm trying to always avoid. It is my position. I believe there are especially trained, dedicated persons who will understand about those criteria for indication or contraindication. We are visualizers, we are imagers scanning. We have to, as accurate as possible, to measure all parameters and to pass this information to gynecologists. Okay, we didn't manage to make you answer this question, but I shall comment. I do agree completely with Karine. About the degrees 0, 1, 2, 3, it's difficult to say, but everything that distorts the uterine cavity, and with all that we are referring to the publication, rather surprising publications which says that the size of myoma over 40 centimeters of whatever location. I cannot imagine what is the pathogenesis of myoma impact with myoma with pedicle or other, how it will impact on reproductive outputs with IVF. I cannot imagine such cases, but you will find them in the literature, and we have to consider them because many authors do refer them. Although, from point of view of clinicians' logics, it is important. All that distorts the uterine cavity is important. All that doesn't distort is not important. That's how you can answer. Okay, we have no questions. If you have time to join discussion at the end, if you would stay with us, we'll be very happy. If not, then we thank you once more on behalf of all Ukrainian community of reproductive medicine. On behalf of all the audience, over 100 persons are following us during the day, even more they will be, and even more people will watch the recorded video. We appreciate your time very much. We appreciate your expertise, and especially we appreciate that in such a difficult time for the whole world and for your country specifically, you have found this opportunity to share with us your valuable experience. I want to prevent you that sometimes power black can happen, energy disconnection can happen. If I manage, I will try to stay with you. Thank you very much. Just in case, we thank you now. Inessa, hello. I admire you. I love you. I thank everybody. It is my pleasure to announce next presentation, next speaker, Professor Safonova Inessa Nikolaevna, Doctor of Medical Sciences, writer, blogger, not only medical one, but she has also non-medical work, which are very much worth to read, to be read. But today, she will present us information which will be helpful to practical doctors. She is a wonderful professional. She pays a lot of time to education to bring knowledge to the people and the practical skills and the popularization of the ultrasonic developments, practical ultrasonic scanning plus books which Inessa Nikolaevna writes and publishes. I believe it's an invaluable contribution for reproducers also. The next lecture is Ultrasound in the complex diagnostic of pregnancy of unknown location. We meet with such cases rather frequently, so Inessa Nikolaevna, please. Good morning once more, dear colleagues. Good morning, Nikolai Gravich. It's a great honor for me to participate in your forum of very distinguished association of Ukrainian reproductologists. The reproductology is my big love, hidden love, and non-performed song of obstetrician gynecology is those who made the way of visualization. I want to thank Karina Tehuns for friendship, for wonderful lecture and presentations, which make pleasure with its aesthetics, with its saturation, and with some charisma of the author. Good morning, dear colleagues. I welcome all those who are online and who will watch this lecture in record as well. I propose to your attention the lecture on ultrasound support of unknown location pregnancies, uncertain location pregnancies. I may start. The ultrasonic support of pregnancy of uncertain location. The ultrasonic studies in different stages of the first trimester, the ASHRAE recommendations 2020, which were published and were dedicated to first trimester pregnancy. Special attention was paid to the fact that during the recent years, the role of such studies is increasing. It's due to many reasons: optimization, improvement of visualizing devices, quality, the possibilities we have today thanks to technical progress, and great level of confidence and compliance of our patients. To that, the coverage with ultrasonic studies in the first trimester and the early first trimester is observed almost everywhere in the countries where ultrasonic obstetric techniques are available. This echogram shows early term, shows a very small embryo at this stage This is embryon without a yolk sac. It's been compared with a ring, with a diamond ring. By the way, the pregnancy obtained with IRTs is also valuable. It is a great diamond, great value for the woman, much more than some jewelry. During preparation for today's presentation, the literature sources were used dedicated to the study of the quality of diagnostics, principles of diagnostics of early-term pregnancy, the reviews of up-to-date web portal were used, the results published on ISOC World Congresses during the latest years, certain consensus classic publications of Timmerman, Boron, some multi-center analysis reviews, and also my own ECHO archive, ENDO archive received during many years in a tertiary obstetric unit of Kharkov Oblast Clinic Hospital. One of the main document for reproductologists, the constitution, the main law, is obviously the guidelines of the relevant specialized society, the ESHRE. In 2020, a new document was published dedicated to ultrasound in the first trimester. It was dedicated more to ectopic pregnancy, but it also includes few directions connected to pregnancy of other location. This paper contains recommendations on practical description and use of terms for normally located and ectopic pregnancy. According to its recommendation, normal pregnancies, which we name gestational sac or GS. This abbreviation I will use in my presentation, so I just draw your attention to this abbreviation. Normally located pregnancy is a pregnancy which is located within uterine cavity without getting out, without invading outside the relevant zone, and the borders of uterine cavity are ostia of uterine tube, fundus, and the internal os. The cavity of uterus is triangle shape. In case of abnormalities are known there, about which we hear it in the previous lecture. And the whole cavity is lined with endometrium. When something is wrong when we perform US, but we don't see this diamonds, this gestational sac, and typical image of the chorionic cavity. What should we tell patient? What should we recommend here? How the report should be worded? The ultrasonic support of abnormal early first trimester assumes use of a special terminology. This terminology is described in the relevant publications and recommendations. The following terms are used: pregnancy of uncertain localization, failed pregnancy of uncertain location, intrauterine pregnancy of uncertain viability, failed intrauterine pregnancy, ectopic extrauterine pregnancy, and ectopic uterine pregnancy. Today's presentation will be dedicated to a part of those terms and some part of those areas which our diagnostic protocol can follow. Coming back to SHRE guidelines, the authors propose as the following classification: early term pregnancy can be located normally or ectopic. It can be early, progressing, and failed pregnancy. In our protocols, we can translate it as still pregnancy or spontaneous abortion. The pregnancy can be ectopic one, and there are two types of localization: ectopic intrauterine and extrauterine. Extrauterine ectopic is a tubal pregnancy. Can happen in can be interstitial, isthmic, ampular, and also a varial and abdominal one. The guideline focuses rather seriously on uterine forms of ectopic pregnancy, cervical, scurry, and intramural, and it underlines that the intrauterine ectopic pregnancy can have even more severe clinical consequences than extrauterine one. And the pregnancy could not be found. When the pregnancy was not found, we classify it as a pregnancy of uncertain location. So during the next hour in my two presentations, we shall look at the protocol for management of failed or still or spontaneous abortion with normal ectopic pregnancy, and also I will allow myself to dwell on certain variants of extrauterine ectopic pregnancy, such as tubal, ovarial, and abdominal. Why on those options? Because with those options, the location of extrauterine pregnancy, difficulties visualization can happen. We might not see it during certain steps of ultrasonic scanning. So the patients with such variants of extrauterine pregnancy location could be referred to diagnostic protocol of an uncertain location pregnancy management. The ultrasound in the early first trimester when something went wrong. Let's look at the three clinical tasks. The first one, there is anamnesis, there's a positive test, positive serum indicators of this biomarker, but we don't have the gestational sac. Such a pregnancy is interpreted as a pregnancy of uncertain location. In 1981, Cadar de Romero published one of the first papers dedicated to diagnostics of pregnancy of uncertain location, ectopic pregnancy, corresponding to discriminatory zone of HCG. And the authors of this publication insisted on that if HCG levels from 6,000 to 65,000 units, if at those levels the gestational sac is not visualized in uterine cavity, such a pregnancy should be considered as ectopic one. And many years of active surgical tactics was used in such cases. We understand how different the sonologist practice in 1981 is different from sonologist practice in 2020. First of all, with the quality of scanners and the resolution capacity. So today, the so-called discriminatory zone, the level of HCG where uterine cavity is visualization is obligatory, is much lower than in 1981. Upon recommendation of most of the associations, American College of Obstetricians and Gynecologists, British NICE, and most of publication of updates, with the level of HCG from 1,500 to 305,000, the visualization of gestational secondary uterine cavity is obligatory. And the relevant guideline recommends us to manage such patient as PUL patients when there is no pregnancy with transvaginal ultrasound with positive qualitative HCG test. Pregnancy of uncertain location. What a kind of situation, clinical situation is it? It can develop into three different directions and have three different clinical scenarios. This can be a situation which finally might bring to ectopic pregnancy. It might be quite different clinical scenario, prolonged ovulation implantation interval, or at the moment of study, very little chorionic cavity, very small gestational sac in the cavity of uterine, we cannot differentiate from some other anechoic structures of endometrium. Also, one of the scenarios of clinical course of pregnancy of uncertain location is the so-called self-resolving pregnancy of uncertain location or spontaneously resolved pregnancy. So to understand which of the clinical scenario is corresponding to our specific situation, we have to control dynamics of HCG and to control the ultrasonic picture. Let's pay attention to that patients with one and the same gestational, menstrual, other term of gestation can have different variants of gestational sac visualization in uterine cavity. It can be of different morphology, different size, like in those 3 echograms. With a patient 4 weeks, 5 days, anamnestically, the term is one and the same, but they have individual features of tubal implantation, etc. They may have different ovulation implantation interval, and the picture we shall see can be different in the uterine cavity of those patients. The question of association of length of ovulation implantation interval was discussed with this association of that interval with reproductive outcomes were discussed by special presentation during ISO congresses. It was shown that both shortened and prolonged OI is associated with miscarriage risk, and the predictor of clinical output in such cases is HCG profile starting from the first day of its gain, of its growth. Doubling of HCG every 2 to 3 days, 48 to 72 hours, confirms the effect of viability of the pregnancy, viable pregnancy. Very low serum concentration of progesterone do exclude the progression of the pregnancy. Those are biochemical indicators for protocol of PUL management. Task number 2. The cycle was violated. We do have HCG positive test. There are some numbers of lab data, but we have no gestational cycle. But in the course of management of such patient, HCG was reducing to 0. No gestational cycle was seen. What was it? This situation might be which reproductologists name biochemical pregnancy, the so-called spontaneously resolved pregnancy of uncertain location. In 2019, in Sonography journal, the result of the study was published, including 112 cases of pregnancy of uncertain location and the statistics of outcomes. It is not a complicated little study, very elegant in design, and very useful for practitioners to understand what we have to deal with, what risks are there when we have a patient with relevant symptoms. So from 112 cases with spontaneous abortion resolution, it resolved in 72%. The 15% of patients did had the developing uterine pregnancy with prolonged ovulation implantation interval or very small gestational sac in the cavity, difficult to visualize at certain early stage. Self-resolved pregnancy of uncertain location happened in certain cases, a certain percent of cases. Ectopic pregnancy happened in 11% of patients. ectopic pregnancy of complicated visualization. That's how I named those few variants of location, several variants of clinical course of clinical scenarios. The ectopic pregnancy of complicated visualization is a direct part of diagnostic process with PUL. Task number 3. The cycle is violated. There is ACG but no gestational shock. There is a manifested growth of ACG with a relevant dynamic which shows that the pregnancy is viable and is progressing. Ectopic pregnancy of complicated visualization. The ectopic pregnancy, in certain cases, you could visualize it well with no doubt for the diagnosis. It has to be of certain term, of certain size. The sonographist has to have some minimum experience, understanding of echographic semiotics. In such situations, the uterine tube in its ampler area with empty uterine cavity, you can see the developing ectopic pregnancy, typical gestational cycle in the with embryo in uterine cavity. Ashure prescribes how to report, how to describe this. Describes in detail the management of such uterine tube. We'll talk about it today. We'll talk today about that certain variants of such ectopic pregnancy are visualized very difficultly and could remain non-diagnosticated. In such case, we may have to deal with diagnostic error, with conflict situation. With reproductive assisted reproductive technology, the risk of tubal or heterotopic pregnancy is practically equal to general population risk, and is encountered in 2% of cases. You have to remember about it all. Both obstetrician gynecologists who manage this pregnancy after IRT and the reproductologists themselves as well. According to publication data, the risk is higher with yearly transfer and lower with cryo protocols. There is a risk of repeated ectopic pregnancy. It increases a few times after tubal surgery. After tubal surgery, the risk of ectopic pregnancy is from 3 to 20% increased. Those are patients with tubal infertility factor and the patients who are using IRT programs, ART programs. The ectopic pregnancy in more than 90% of cases is located in the uterine tube. In less than 10% is of other locations, cervical, interstitial, scary location, not only in the after cesarean scar, but also in after ectomy, intramural, and also ovarian, abdominal, and few variants of heterotopic pregnancy. When the pregnancy develops in the tube and uterus cavities simultaneously, also concurrent pregnancy, uterine and cervical. I refer to complicated visualizations variants, the tubal one, because it is encountered most frequently, and some variants are rather difficult to visualize, to recognize. And also the ovarial, abdominal, and some variants of heterotopic pregnancies. Pregnancy after ART, tubal one with very difficult variant of visualizations, a rather small chorionic ring described as a sign of a ring inside the tube. It's rather close to the ovary. It's very easy to miss such pregnancy in the US. Even several US studies didn't find this type of location of gestational cycle. So this pregnancy was managed as PUL with repeated dynamic scanning, sometimes to establish the diagnosis of ectopic pregnancy. For such morphology, you should need 2-3 ultrasonic studies, not one. Extrauterine ectopic pregnancy in 2 tubes, both tubes. Once more with empty uterine cavity, you have both tubes. Very small densification, thickening sites you found of ectopically located gestational sacs. It is not easy to establish such a diagnosis. It's not a service. The sonologist should have experience, should be aware, and should have certain experience of such studies. So to be able to recognize such a pattern and to identify 2 uterine tubes with ectopic pregnancies. So this is bilateral tubal gestational sex location. By the way, there's such a topographical phenomenon as a pseudo-gestational sac. It is a reason for diagnostic error. It is a situation when the patient may be established the diagnosis of uterine normally located ectopic pregnancy, and at the development, with the development of ectopically located pregnancy, one or other clinical picture can be present with different degree of threat to the health and life of the patient. What is the reason of the so-called pseudo-gestational sac phenomenon? Very different conditions can result in that. There can be blood in uterine cavity. There can be a narrow cavity with a liquid component in the wall of the market. There can be small cyst. It can be changed endometrial gland. We can mix with gestational sac. All those variants require careful attention of the sonologist, not to make an error for uterine cavity or false diagnosis of ectopic pregnancy. This situation is very controversial, very conflicted, almost always. Ovarian pregnancy, one of the variants of very difficultly diagnosticated extrauterine pregnancy. The ovarian pregnancy could be located completely or partially in the parenchyma of the ovary, and there is a relevant symptom. It's impossible to separate the ovary from the pregnancy, but also definitions and descriptions do not always help us in practice. With early terms, the diagnostics can be easier than at the later terms. In the early terms, you have to treat such pregnancy using the corpus luteum. Here you have 2 cases of ovarian pregnancy from our practice, from our visual archive. First case, the patient was treated the inflammation process. She was treated against pain. Even HCG assay was not performed for her. For a certain time he claimed about the pains without having a typical menstrual cycle. She was treated with some anti-inflammatory agents. But when they found there was a gestational sac in the ovary and an embryo which was found in the ovary, in the ovarian cavity under the capsule, the diagnosis was established pre-surgically from the surgery, from the clinics where this surgery was made. They passed these images to us, so for us to prepare this publication with intraoperational verification. Another case of ovarian pregnancy. It was a typical case of pregnancy of uncertain locations, the typical dynamics of HCG with pains, with empty uterine cavity, This patient has preliminary diagnosis of ovarian cyst, and really, such a cyst basically could remind us of a hemorrhagic cyst, typical hemorrhagic cyst, but something in this cyst was alerting with its structure. It showed it is not a normal cystic corpus luteum of pregnancy. There was a suspicion for such diagnosis on the pre-op stage, and really the surgery found out the capsule cystic cavity which contained hemorrhagic substrate, decidual tissue, and the diagnosis of ectopic ovarian pregnancy was confirmed histologically. What should we understand from this, and what should we remember? We should remember that ovarian pregnancy is the situation which most frequently comes to gynecological stationary with the clinics of acute abdomen pain and ovarian cyst rupture. These patients manifest signs of disrupted integrity of ovarian cyst, and only through some time after the histological verification, the true diagnosis of ovarian pregnancy might become into this service. Abdominal pregnancy, also dramatic case, and it is found in patients after ectopic pregnancy with a rate of 1.5%. By the way, it is described after ART and even after hysterectomy. Location of abdominal pregnancy can be very different, most frequently omentum and abdominal peritoneum, but also is location of abdominal pregnancy is possible in the area of broad ligaments, retrouterine recess, spleen, liver, intestine, large pelvic vessels, even on the diaphragm and the serous coating of the uterus. The pathogenesis of abdominal pregnancy is not much clear up to the end. It could be a secondary or primary implantation. What do we meet in practice? When the patient comes to us, they don't have a table, say an abdominal or ectopic pregnancy. They come with a diagnosis of pregnancy of uncertain location or with normal uterine pregnancy diagnosis. According to ASHRAE 2020 guidelines, abdominal pregnancy is implantation outside of uterine cavity, outside of ovary and uterine tube lumen. Doppler can be useful here. In our practice, we met a case that is a recent case. You can see it from the quality of the image. We worked on devices with quite another quality of the image. And a patient with 16 weeks of gestation came to us with some strange symptoms. It was assumed she had a bicornal uterine. In one of the corns, the endometrium was not changed, and another corn was assumed to have the fetus. And this is a strange pregnancy with a uterus with abnormality. So few sonologists who made study for this patient believed it was one of the Mullerian abnormalities, and the fetus is developing in one of the uterine horns. But she had an abrupt ascites and the hemoglobin 40, and there was a live fetus. After certain diagnostic procedures and surgical treatment was found out it was an abdominal pregnancy, and the ascites was a hemoperitoneum and was the reason of anemia for the patient. This patient was rescued, was saved, although the clinical risks of such situation are obvious for everybody. The risks of abdominal pregnancy are double one, perinatal and maternal ones, and even The probability of a serious bleeding is much higher, and the placenta separation of such atypical ectopic pregnancy is very high. There is a low probability of possible viability and development of pregnancies, and the fairy tales about the live fetuses who survived in the abdominal pregnancy, all the gynecologists know such fairy tales. It's very important not to be seduced by such. Yeah, such cases can rarely happen, but in most situations, the fetuses are dying, and very often also women are dying. So the clinic is saying the growth of HCG can happen. There can be acute abdomen pain, intra-abdominal bleeding, and the clinical symptomatics. What UpToDate says? They say that in early terms, it is difficult to differentiate the abdominal pregnancy from tubal pregnancy. The protocol of American College of Obstetricians and Gynecologists postulate on that the pain and or bleeding in reproductive age is an indication for study for pregnancy, including HCG, SA, and TVUS, and the syndrome of MRI, an empty uterus. It is a reliable one, but you should know whom to refer for such a study. Our cases of abdominal pregnancy, the pre-op diagnosis was extrauterine ectopic tubal pregnancy. We assumed it was a tubal pregnancy. Pay attention. A typical picture which corresponds to the definition of ESHRE recommendation. The gestational sac is found in between the intestinal tubes. The color Doppler shows the blood flow signals, vascularization signals, and it was found out it was an abdominal pregnancy implanted to the serous coating of the intestine. I believe nobody should be convinced anymore that ectopic pregnancy is a serious, critical, conflicting clinical scenario. Everybody is working, everybody knows that such a development of events is very unavoidable, both in standard pregnancy and in post-ART pregnancy. Let's come back to the recommendations on management of pregnancy of uncertain location according to its diagnostic protocol. Pregnancy of uncertain location is the situation when we have no convincing ultrasonic signs of gestational sac location. PUL, that is how the conclusion of ultrasonic study should be. It's obviously not a diagnosis. It's an intermediary stage of the diagnostic process. The patient is stable if there are no hemodynamic disorders. If the patient is interested in possible prolongation of pregnancy, we saw that there can be 15 to 20% of such pregnancies can be prolonged as uterine pregnancies. Such patients are recommended to have dynamic tests, both ultrasonic and biochemical, with test of HCG. If not, another protocol with aspiration, histology, it found presence or absence of chorionic villi. If the aspirate has chorionic villi, the diagnosis of failed uterine pregnancy can be real. When there are no chorionic sign, 20 to 24 hours after aspiration, you have to monitor HCG. If there is a plateau or decrease less than 15% or growth of HCG, then different assumptions can be valid. It could be residues of chorion, could be ectopic pregnancy, or even some hypoplastic disorder. These are the numbers published in several papers where study of chorionic hematropin was studied in 48 hours with different variants, with different scenarios of PUL. This dynamics was different. If in 48 hours the gain of HCG was less than 0.87, in such situation you could think it is a drop. The gain of less than 1, it is a drop of HCG. It is a resolved pregnancy of uncertain location. If the HCG is over than 166, such a dynamics of ECG is characteristic for progressing uterine pregnancy. Ectopic pregnancy is found in the intermediary zone between those two variants. What does it mean for us in practice? In practice, it means that we have to, when consulting the patient, when managing her, we have to take into account these dynamics by calculating the percentage of gain of HCG, should refer the patient to a second ultrasound study. In practice, all this can take is labor consuming, especially in the conditions of routine visits, the need to accelerate the process. Many of you are working in the conditions when there are certain temporary limits acute to your office. You have to take quick decisions. The management and recommendations for the patients with pregnancy of uncertain location could be somewhat difficult. In 2015, on ISO Congress, such a mobile application was presented. A small program worth $5 you can download to your telephone. It's strange a little bit for me to be such an advertiser of somebody's commercial product, but frankly speaking, I like a lot the mobile applications. I like the mobile calculator, online calculators. It's a very useful instrument. They are implemented in time practice more and more. The online calculators allow us to immediately, simultaneously introduce few clinical parameters into the interface of the software and to get a very quick result, a very quick recommendation. So, the mobile application under the name Early Pregnancy is has such a name. You can try to find it in the relevant stores, and to install into your mobile when using such a mobile application. Two-step diagnostic protocol is implemented into the software of this application. It includes the growth of progesterone and the growth of HCG. The progesterone is taken into account only in the case when the patient didn't get progesterone therapy. As I understand, the patients in ART clinics do have progesterone maintenance. If not all, then most of them, if I'm not mistaken. So, eventually, for the pregnancies after ARTs, you can use only HCG gain data for spontaneous pregnancies. For patients without progesterone treatment, the use of both parameters, both indicators is possible. So, we're introducing into the program certain parameters. This calculator gives as a result such a diagram, and this diagram shows that the patient, we remember 3 scenarios are possible for PUL. This patient has certain percentage of probability of different scenario of probability of ectopic pregnancy, self-resolving pregnancy of uncertain location, and the possibility of uterine pregnancy. And the program itself recommends what should we do with this patient. If there is a risk of ectopic pregnancy, we have in 2 days to repeat HCG measurement and ultrasonic study. If it is self-resolving uterine pregnancy, we can also repeat ECG in 2 days. If it is uterine pregnancy, of uncertain location. In 1 week, we should repeat the ultrasonic test. The clinical and biochemistry data are all here resumed to a single algorithm. That's how interface looks out. How the interactive page from which we communicate, we choose a model to predict. In this case, for management of PUL, because same mobile application has also another model for determining the viability of pregnancy when there is assumption of cystic of mole, and we shall talk about it in 30 minutes and 1 hour. Meanwhile, we are in the model for prediction of the pregnancy of uncertain location. When entering the baseline and repeated HCG levels, and also the baseline progesterone level of the patient who didn't get progesterone treatment before, we get such a diagram. What should we do with it? What for such tools are suited? First of all, to provide a relevant and necessary recommendation for the patient, and for the second, it's very good deontologic tools. In 2012, ISOC published a special information sheet about communication with patients. The International Association of Ultrasound in Obstetrics and Gynecology is the organization, the scientific community, which not only implements scientific developments for practitioners, not only supports scientific research, but also give examples of communication with patients. A special publication of ISOC in 2020 was dedicated to pregnancy of uncertain location and the ontology when managing such pregnancies. They proposed special communication sheets focusing on clinical risks of ectopic pregnancies. The diagrams of special programs help us to explain the patient possible scenarios, to assign repeated visits and tests, and to place accents on the necessity of such repeated tests. Such information sheets could be created by you for your clinics, for your offices, and the patients could receive this information so it understand us correctly. We know all colleagues what conditions are we working under now. The medicine today becomes more and more conflicted every day, so the mutual understanding between the patients, sonologists, and obstetrician gynecologist is very important. In 2018, Tom Bourne, working in UK, during the Singapore World Congress of ISOEC, at that time everybody was mobile, the world was open, we fly to different countries, to Congress, we meet each other in live. Tom Bourne conducted a whole session dedicated to ectopic pregnancy and pregnancy of uncertain location. He focused on that there are certain problems, the problems of competence, of problems of guidelines and consensus, problems of tests, problems of causes. In the modern conditions, the accuracy of establishing ectopic pregnancy should achieve 90%, and the sonologic signs are also important. That was underlined by Professor Bourne. Task number 4. There is a gestational sac in the uterine cavity, but the size of the embryo and the extra-embryo structures doesn't correspond to the term. The forecast of viable or non-developing pregnancy. This may be discussed after the Q&A session, that is to the discretion of the facilitator. How do you hear me? We hear you very well. Frankly speaking, we have a little bit problems with timing, so meanwhile we can skip the discussion. We sacrifice it for the sake of the timing. So currently we have 35 minutes left. I don't want to take any second from your presentation. The advantage of and the problem of online conference consists in that all the speakers start exactly at time. So we have to finish exactly at 1 p.m. I apologize for this particularity. So I ask you to pass to the next presentation, which is also very important. Ultrasound diagnostic with early term pregnancy, non-developing pregnancy is also very important. Unfortunately, we have to shrink to 35 minutes. I have no problems with timing here. I have a possibility to fit in this time. Okay, I have 35 minutes. Lecture number 2, ultrasonic support of the pregnancy of uncertain viability. You can hear me well. Shall I continue? The ultrasound support of the pregnancy of uncertain viability. We are found in the same place, the Office of Ultrasonic Diagnostics. We have the same patient with early pregnancy term, maybe after ART, maybe it is a patient with spontaneous pregnancy. We can meet what clinical tasks can we meet here? It's practically the same sources, same consensus, same classic publications, same reviews, and obviously own cases, own examples, and own archive. In this point, in this part of our lecture, when talking about pregnancy of uncertain viability, it is an absolute need for us to discuss such term as gestation term, because its interpretation and calculation can be difficult sometimes. Normal practice of gestational term calculation is the so-called menstrual, from the date of beginning of the last menses. The use of ART protocols, this calculation of pregnancy term should be made with correction for ART protocol type. And as a professional consensus about that, from several international associations, American first of all, and the European one, and international ones, different types of protocols, use of own oocyte, donor oocyte, cryo protocol, transfer of 3 to 5 days embryo. In those situations, there is a need to conduct certain correction of pregnancy terms. Why so? To interpret correctly the ultrasonic picture. And here we can be helped by online calculators. I already mentioned about it in the previous lecture. I'm very great fan of using such gadgets. It is not toys. Those are very useful things which can be used instead of those paper tables. They allow us to perform very quickly some calculations. There are online calculators which allow us to calculate the term of pregnancy with correction for the type of protocol. So we have a patient, we know exactly the term of pregnancy. If it is a patient with spontaneous pregnancy, we calculate it according to the date of last menses. If it is a patient after ART clinics, so we insert the relevant corrections. For example, we have 6 weeks gestational term. In 2009, the American College of Obstetricians and Gynecologists published the following data. If in 6 weeks there is such an ultrasonic pattern, the average diameter of gestational sac is 12 millimeters and more, the yolk sac from 2 to 6 millimeters, and there are pulsations of embryon observed. Those are ultrasonic predictors of successful pregnancy. 90 to 95% of such pregnancies are successful independently from some additional risk factors, the age of the pregnant and the parity ratio. It is very interesting perspective of ultrasonic diagnostics of urogerms, but our empiric experience suggests us that we already guessed on that 6 weeks visualization of pregnancy always allowed us to be optimistic in the prediction of pregnancy development. When studying the gestational sac or chorionic cavity, it's important to have its average diameter calculated by average size of three mutually perpendicularly situated lines. The location in the upper or middle part of the uterus, the daily growth of gestational sac makes 1.2 millimeters with the average JS diameter 16 to 20 millimeters in norm. Both yolk sac and embryo pole should be visualized. And here it is indicated with a white arrow, the term of pregnancy. Determined judging from JS size is very inaccurate. An example for you: triple pregnancy, triplet pregnancy, trichorionic one with different size of all gestational sac. All the embryos are one and the same term. We shall not try some conspiracy here. Obviously, this pregnancy is a pregnancy with certain term, but we see three different diameters of gestational sac. So we cannot accurately establish gestation term judging from just JS size. An average diameter of JS we need it for another purpose, to determine certain factors of prediction of forecast. For developing pregnancy, I remind you there are different implantation ovulational interval, different terms of ovulation implantation, resulting that the patient with one and the same term. We can see different interval, different echographic variants. Eventually, they have some association, some correlation with the outcome, but in any case, it doesn't allow us to judge here on different terms of pregnancy. All these patients have equal term of gestation, 4 weeks, 5 days. Another confirmation on that average diameter of gestational sac doesn't allow for accurate gestational term definition. You have two pregnancies with practically equal term, 7 to 8 weeks, and we see a large sac and a very small one with a size less than first percentile. Maybe it might associate with failure of pregnancy, but now we don't talk about that. If you see a viable embryo and we measure its crown rump length, then the diagnosis would be progressing pregnancy of 7 to 8 weeks. Crown rump length, the length of embryo, if it has daily growth of 1.2 millimeters, and this daily gain is very strictly correlated to gestational terms. In 7 to 12 weeks, using the crown rump length, it is the most accurate factor for gestational term definition ultrasonically at this time, at this period. Heartbeat pulsations could be registered in 3 millimeters embryon, but also it can be missing in 4 millimeter embryon. Без перебоев, все было хорошо.
Все хорошо, все, я продолжаю, прошу прощения.
Окей, ничего,
Желточный мешок виден с 4-5 недель, и его размер в норме 2-6 мм. При этом эмбрион расположен в полости амниона, а желточный мешок расположен в хориальной полости. И это важно понимать, потому что в некоторых вариантах, когда мы будем видеть пустую амниотическую полость, это будет очень важно. Визуальное расположение гестационного мешка непосредственно в децидуальном эндометрии без деформации срединного комплекса. Возможно, в сроке 5 недель в очень раннем, но в этой ситуации необходим контроль и эмбриона, и хронического гонадотропии. В большинстве случаев, как нормальный вариант программы первого триместра, мы будем видеть вот такой признак так называемого двойного децидуального мешка, когда мы будем видеть как бы две полости в матке и полость и рядом дополнительное онкогенное пространство между париетальной и базальной децидуальной точкой над некоторой частью гестационного пузыря. Эргографический вариант нормы для 4-5 недель беременности. Это не отслойка, не гематома, не состояние, которое явно связано с угрозой невынашивания. Менее миллиметра, и она ограничивает амниотическую полость. На ранних стадиях амниотическая полость занимает 1/4 хориальной полости к 8-9 неделям, 1/2 хориальной полости, просто две оболочки хориальная и амниотическая сливаются и образуют единую с точки зрения эхографии полость. Обратите внимание на то, что диаметр амниона практически в большинстве случаев диаметр амниотической полости на 10%. Соответствует сроку. Я обращаю ваше внимание, коллеги, на то, что мы сейчас говорим только о той ситуации, когда срок установлен. У нас плавает срок, если у нас непонятно, откуда вообще вести исчисление, здесь задача еще усложняется. Она становится еще более сложной. Мы сейчас пока будем говорить о тех ситуациях, когда мы достаточно неплохо знаем, какой здесь срок беременности пациента. Итак, 9-недельная беременность по менструальному анамнезу и вот такая картина плодного яйца, или, например, 8-недельная беременность и вот такая картина плодного яйца. Такая ситуация в профильных публикациях трактуется, интерпретируется как беременность неопределенной жизнеспособности. Pregnancy of unknown viability. Или вот такая вот аббревиатура. PUV. Заходя в эту зону беременности неопределенной жизнеспособности, важно понимать, что здесь наиболее место либо с диагнозом, либо с предикцией. Диагноз – это однозначная норма или однозначная ненорма. Предикция – это неоднозначная картина. Предикция – это серая зона. Ну, примерно вот так. Однозначная норма – это когда мы точно видим в окне, что идет дождь. Неоднозначная картина. Предикция – это когда в Киеве вероятность дождя то ли 70%, то ли 100%, то ли вообще будет солнечно по данным прогноза погоды. Несколько слайдов, которые покажут определенную ненорму. Несостоявшаяся тройня, 13 недель. Один живой эмбрион с нормальной морфологией, сердцебиением, он вот вверху, расположен, нормально развивается, и два небольших замерших эмбриона в своих собственных реальных полостях без наличия пульсирующей сердечной области. Это определенная ненорма, и диагноз несостоявшейся тройни с двумя замершими эмбрионами может быть поставлен при первом визите, при первом осмотре такой пациентки. Еще два варианта определенной ненормы. 8-9 недель, аморфный эмбрион без пульсации в первом случае, напоминаю цепочку. Во втором случае мы видим черты более-менее напоминающие нам структуру эмбриона, но без пульсации, без регистрации пульсации сердечной области. Определенная ненорма и диагноз неразвивающейся беременности может быть установлен при первом визите, при первом осмотре такой пациентки. Еще определенная ненорма, два случая. Желточный мешок 12 мм и нет эмбриона 7 недель. Да, такие ситуации, практически всегда ассоциированы уже все-таки с выкидышем, замершей беременностью. 8 недель, пустая амниотическая полость. Если вам помню, что полость амния у нас всегда должна содержать эмбрион. Если уже сформирована полость амния, эмбриона нет, то беременность это не развивающаяся, это определенная ненорма. Двойно не развивающийся, 9 недель, два желточных мешка, 2 мм и 9 мм. Вот такая двойная кармическая ошибка. Какой случай вашему вниманию? Помните, мы говорили о том, что плотное яйцо в большинстве случаев должно располагаться в средних и верхних отделах полости матки. Это случай беременности у пациентки со сложным анамнезом. Анамнез у нее вторичная аменорея, хроническая бесплодие. Ей проводилось гистеролизектоскопическое лечение эндометрита с рассечением, гези с устранением синехий. И, наконец-то, пациентка получила долгожданную беременность. Вот в сроке 8 недель такая картина. Низкая имплантация, очень низко расположено плодное яйцо. Обратите внимание, вся верхняя часть полости матки облитерирована, по-прежнему облитерирована адгезией. Рецидивирует, к сожалению, нередко у таких пациенток. И в нижнем отделе, практически в перешейке, даже частично в шейке матки, у этой пациентки располагается плодное яйцо. Здесь вообще такую ситуацию нужно дифференцировать с другими вариантами маточной эктопической беременности, с частичной шеечной беременностью и неразвивающихся эмбрионов, и сердечной деятельности эмбрионов. Это, конечно же, определенная ненорма. Диагноз замершей неразвивающейся беременности может быть поставлен такой пациентке при первом посещении, при первом визите. Еще один случай неразвивающейся беременности, определенная ненорма. После длительного бесплодия, первая беременность, задержка 10 дней, какая-то невразумительная динамика ХДЧ. 450, 380, 620, 350. Вы помните, что такая динамика по данным профильных публикаций характерна для саморазрешившейся беременности, для спонтанного выкидыша, либо для спонтанного разрешения беременности неопределенной локализации. Создавалось впечатление вообще наличия какого-то феномена четырехплодной беременности. Повторная ультразвуковая картина была без динамики у этой пациентки несколько дней, если даже несколько недель мы ее наблюдали, поскольку пациентка была беременностью заинтересована, кровотечения не было, и мы пытались увидеть, что же в результате из этой беременности получится. Ничего не получилось. Была проведена гистероскопия, гистеролизектоскопия ей. Гистологически в результате гистологии элементы плотного яйца с некрозом и нагноением. Честно говоря, и после гистероскопии, после гистологии остались вопросы, мы так и не поняли, что это было. Возможно, многоплодная неразвивающаяся беременность, возможно, какая-то гидроптическая трансформация холена. Во всяком случае, возвращаясь к руслу нашей темы, это не развивающаяся беременность, это определенная ненорма. Диагноз неразвивающейся беременности здесь правомочен, но с учетом заинтересованности пациентки мы какое-то время беременность наблюдали, то есть протокол с повторным исследованием применялся. Вообще вот такие рекомендации, такие календари для диагноза неразвивающейся беременности были в течение последнего десятилетия опубликованы во многих публикациях, центрами профильными, рекомендуют не спешить с диагнозом неразвивающейся беременности в некоторых случаях и рекомендовать пациентке повторный визит. Итак, при первом визите мы можем судить о том, что беременность не развивается, если при копчико-теменном размере эмбриона от 3 до 7 мм нет его пульсации. Точнее, я бы сказала, что здесь я немножечко ошиблась. Здесь должна быть одна цифра. При копчико-теменном размере, прошу прощения. Бывают такие закрадываются ошибки в презентации. Неверно. Здесь нет пульсации эмбриона при копчико-теменном размере его 7 мм. Нет пульсации эмбриона при среднем диаметре гестационных полостей 20-25 мм. Нет желточного мешка при среднем гестационном диаметре 16-20 мм. 3 мм эмбрион совсем отсутствует при среднем диаметре гестационной полости 16-20 мм. Или двойной пузырек. В некоторых других клинических ситуациях мы рекомендуем пациентке повторные визиты. Повторный визит через 7 дней, повторный визит через 11 дней или даже через 14. Если пульсация эмбриона нет через 7 дней после его первичной визуализации, если мы уже увидели эмбриона через 7 дней нет при повторном визите, диагноз может звучать как дальше. Нет пульсации эмбриона через 11 дней после визуализации плотного яйца, после визуализации желточного мешка, замершей беременности. Нет удвоения среднего гестационного мешка при повторном ультразвуковом исследовании через 14 дней и нет эмбриона через 14 дней после визуализации пустого гестационного мешка. Ну, вот такие протоколы, они практически очень полезны, и ведь иногда нам не всегда, при некоторых консультациях, при некоторых оформлениях заключений нам не всегда бывает очень просто быстро высказать мнение о том, когда необходим повторный осмотр. И вот такого рода подсказки, такого рода протоколы, они очень полезны. Неразвивающаяся беременность вероятно и необходим ему дальнейший контроль, необходим повторный визит. В некоторых ситуациях, если мы видим пустую хориальную полость с взвесью, лучше не спешить. Да, возможно, эта беременность не будет развиваться, нужно посмотреть со временем. Неровная внутренняя поверхность, негладкий хорион. Или же какие-то элементы гидрофической трансформации хориона. Лучше в этих ситуациях не поспешить и пересмотреть пациентку повторно. Почему я уже третий раз произношу эту фразу? Лучше не спешить, лучше пересмотреть эту пациентку повторно. Вот две такие программы, смотрите. Вот такая ситуация, 7 недель. Что здесь, что нам написать? Мы-то с вами люди смотрящие, пишущие ультразвуковое заключение. Мы же должны пациентку уже отправить с неким выводом. Можно просто руками развести. Или 9 недель. И вот
9 weeks. Unfortunately, last year we had such a case in Kharkov.
Было ультразвуковое исследование в одном из частных центров. При исследовании врач-сонолог написал такое заключение.
Such a conclusion: 6 weeks pregnancy, non-developing one, and he recommended to make the uterine curettage. Based upon that, in 3 mm embryo, no heartbeat pulsation was registered. Same patient, 12 weeks, had such a pattern of quite well developing fetus. This pregnancy outcome was good with delivery of a term baby, but after pregnancy was over, the patient decided to claim against the sonographist, to claim moral and material loss. And this claim was legally very correct. That was a very conflict and nervous situation for the participants of this trial, for the owners of the clinic, for a sonologist himself. Such situations as a whole can be encountered in our practical routine, you should remember about the main conclusion we should draw from the whole situation about the diagnosis of undeveloped pregnancy. You should never hurry up to establish such diagnosis, because you risk to interrupt, to terminate the viable pregnancy. And the risk of termination of viable pregnancy is a very risky one. Such a practice was proposed in one of the publications on the topic. How many days should pass before a control visit should be made? How should be the diagnostic protocol? Such a formula was proposed based upon daily growth, daily gain, the average diameter of gestational sac of 1.2 millimeters. Such a formula for calculation of the number of days up to control visit, control examination. Simply speaking, with an average size of gestational sac 20 millimeters, the control is recommended in 6 days with 5 millimeters. The control is recommended in 12 days. And during the control, during the repeated visit, if there is no heartbeat signs, you can draw conclusions and recommend the patient some tactical actions to terminate the pregnancy, for example. I remind you this slide, which was already shown today. You have seen already this slide in the previous presentation. The viable pregnancy is characterized by doubling of HCG level every 2-3 days. The low baseline progesterone excludes progression of pregnancy. And I now refer you to the same mobile application, the online calculator, which has inbuilt, it has two different models, two different programs of calculation. Calculation of viability model, which calculates the risk or chance of the patients for viable pregnancy and for miscarriage. When using this sub-program, we introduce into the interactive menu the following data: the age, bleeding scale or score that can be no bleeding, spotting or intensive bleeding, average size of gestational sac, yolk sac size, and availability, presence or no of fetal heartbeat. And we get such diagrams which show us 100% risk of miscarriage or certain chance for viability. If such chances are there, obviously nothing will prevent us from inviting the patient for a repeated visit. We should always take those chances, use them. Now I'm coming to the end of the presentation. Obviously, all the tasks are not exhausted by these two lectures. Obviously, there are tasks number 5, 6, 7, and 100, 300. Those can be other clinical situations, live embryon, butt pains, bleeding hematomes, ambiguous ultrasonic founds in asymptomatic patients. We can talk here about the prediction of miscarriage risk or viability, and also multiple fetuses, diverse ectopic pregnancies. All this regards the third trimester are quite other stories. On the site of UZ School, on the preview, you can watch this books, video lectures, etc. Tuesday webinars. From my side, I invite obstetricians, gynecologists, sonologists to participate. And I want to conclude my presentation with this video clip. I want to say that reproductology is one of the few progressive specialties in medicine. I would name one of the most positive specialties in the medicine. I would name it the most positive one. I wish success to you and to your patient. I thank everybody for your attention. Inessa Nikolaevna, thank you. It was very useful. lecture with positive finalization when the embryo was dancing. It's a pity we have so little time. I believe we could say a lot more, but we have what we have. This is the reason for the next meeting. I apologize. Could you personally for me? I have some problem. Do you hear me now? Yes, yes, I hear you well. Could you repeat your last words? I didn't hear them. I want to say that I once more was convinced on that we were right when choosing this topic, because this section was a comprehensive one, very practical one. That is what missing. That's what we are missing normally in our day-to-day practice, meaning the strict criteria, strict terms, good timing in communication with patients who have still pregnancy, or we assume they have still pregnancy. Very clear and strict messages. Not to hurry. We shall visualize pregnancy. Nothing terrible will happen if we wait a little bit. If we don't wait and there is a pregnancy, the consequences could be catastrophic from the point of view of both medical, reputational, communicational with patients. Thank you for this wonderful lecture. Thank you for ideal timing. And I hope a lot that it is not our last meeting, but our conference has to go on. I want to thank MSD company for giving us an opportunity to gather such wonderful lectures, for the organization and for the support, and want to invite everybody to MSD Satellite Symposium, which will place tomorrow, 4 p.m., closer to the conclusion of the conference. Nevertheless, you know, always in the beginning and in the end of the conference, they are very interesting presentation to prevent people from going away. So I ask everybody not to go away, come tomorrow and to listen tomorrow's presentation. And I thank very much Inessa Nikolaevna, Karine, and Professor Lamarca for a very well organized session. Your experience, your presentations. Thank you very much. Have a good day. Thank you very much. It is not an easy job to facilitate such a conference. You have a wonderful schedule. I wish you success. Thank you. Dear participants of the symposium, I hope you are with us. I thank those who joined us right now. We completed the 3 first large sessions which were in parallel: the ultrasound school, live surgery, and the use URM. And then now the sections will follow consequently. And it's my great pleasure to give the floor to the facilitator of the next session, Zhuk Svetlana. Thank you, Alexander Mikhailovich. Good afternoon, dear listeners. I believe we shall use this time with benefit, and we shall start with the section number 1 under the name Certificate of Procreation, its components and how to provide them. It's a very powerful title of the section. I want to say that this session is supported by the official sponsor of the symposium, the company Gedeon Richter. Let us start our work. It's my great pleasure to give the floor to Helen Saunders, the director on medical issues, medical affairs of Gedeon Richter Company. The topic of her presentation is development, real-world use, and user experience of folotropin alpha. Please, Helen, we are listening to you.
Good afternoon to everyone. So yes, what I would like to do today is to go through with you the clinical development that was undertaken to achieve the registration for Bemfola, some real-world use data that we now have with the product, and also an overview of some user experience, i.e. the patients and the nurses who are actually using the product. There is often a misconception with regards to exactly what clinical testing goes into a biosimilar. So I would just like to emphasize that, there are full development that is tested before a biosimilar is allowed on the market. In the case of Bemfola, this was over 8 years of clinical development, including laboratory tests, phase 1, and a European phase 3 study. This was then followed in 2014 by the registration of Bemfola, which is a single-use pen available in 5 doses: 75, 150, 225, 300, and 450. Each pen is very distinctive due to its coloring, and this also helps the patients to identify which pen they are absolutely using. The phase 1 study to prove the pharmacokinetics was carried out using Bemfola versus the European originator Gonal-f. And what was seen from this study was that for all PK parameters, so area under curve, Tmax, Cmax, etc., that there was no significant difference between Bemfola and Gonal-f. And as you can see from the graph on the left-hand side, the 2 profiles are very on top of one another. So this study basically proved the proof of bioequivalence between Bemfola and Gonal-f. However, something that needs to be taken into consideration is the topic of glycoforms. This, I know, is something that is a very hot topic within the scientific community. And we know that FSH exists as a family of glycoforms which differ slightly in their structures. But what does this really mean? It has been shown in the scientific literature that the alpha subunit of the FSH contains N-linked carbohydrates at the ASN residues at the points 52 and 78. And these differ in both their brancing structure and also their sugar sequences. This in turn conveys variability in the circulating FSH isohormones. But in the real world, in the real life, what does this actually mean for the product itself? The group of Risetti recently carried out some tests looking at the different profiles of gonal-F versus Bemfola with different batches to test these different glycoforms and what was actually happening. What they showed, as you can see from the graphs, is that there is no difference between the products, irrespective of the batch that is used, despite the differing glycoforms. There is no major sort of preparation-specific signals at either the intracellular level or with regards to the steroid synthesis. And in turn, under the conditions that these products would normally be used, they are overall similar. There is no difference between them. So despite the slightly differing glycosylation patterns, this does not affect how the product is actually using in the real world. Further to the phase 1 study that showed the bioequivalence of the two products, a phase 3 study was carried out across 6 European countries, including 372 patients who were randomized. The key inclusion criteria for this study was that the patients had to be between 20 to 38 years of age on their first or second IVF cycle, with a body mass index 18 to 30 and standard basal FSH less than 10 and antral follicle count between 10 to 25. So fairly standard patients. The design of the study was such that everyone received a fixed daily dose of 150 IU of the two products. This, after day 6, could be reduced if there was any safety concerns. However, the dose could not be increased during the study. And all patients received downregulation with a GnRH agonist. The primary endpoint for this study, as requested by the European authorities, was the number of oocytes retrieved. What we found from the study was that with regards to the age of the patients in both groups, the mean age was 32 years of age. Over 95 to 92% of the patients were of Caucasian origins. In both arms, the mean FSH baseline concentration was 6.9, and likewise for the antral follicle count in both arms, the mean was 15. So there were no statistically significant or clinically significant differences between the groups at baseline, so they were highly comparable. With regards to the number of oocytes retrieved, it was found in the intention to treat population. For both arms, the mean number of oocytes was approximately 10. So again, very comparable. This was further validated by investigation of the per protocol population, which are obviously the pure patients who have done everything according to the protocol. And similarly, in this population, we have means of 10.8 and 10.6. The original hypothesis for the study was that if there was plus or minus 2.9 oocytes between the groups, they could be classified as equivalent. And as such, with the results that were shown, Bemfola was assumed to be equivalent in number of oocytes and comparable to that of patients treated with gonal-F. Now, we know that oocytes is obviously a surrogate endpoint for the ideal outcome for an ART cycle, which is a pregnancy. However, this study was never designed and never powered to confirm any sort of hypothesis based on clinical pregnancy. However, looking at the outcomes, we can see that in the first treatment cycle, there was a small difference between Bemfola and gonal-F, but this difference was not statistically significant. And in fact, in the second cycle in the study, this direction was actually reverted. So the pregnancy rate was higher in the Bemfola arm compared to the gonal-F arm. However, for both treatment cycles, there was no statistically significant difference between the two products with regards to the clinical pregnancy rates. Regarding some of the other secondary endpoints, for the total dose and the duration of treatment, both products had approximately 1,500 IU for a period of over 10 to 11 days. Similarly, with regards to the quality of the oocytes that were retrieved, in both arms, there was 83% of patients achieved metaphase 2 oocytes. And finally, for the fertilization rate in both arms, the percentage was approximately 64 to 66% of fertilization. So again, for all secondary endpoints, there was no statistically significant difference between the two products. This was the efficacy of the product. However, we know that one of the most important aspects during an ART cycle is the safety of the product. And the most important safety endpoint for you as clinicians is the occurrence of OHSS. What we found was that there was a slight increased proportion of mild and moderate OHSS with Bemfola. However, this was not statistically significant. And the most important aspect is those patients who unfortunately result in severe OHSS. And for both arms of this study, the incidence in both groups was 0.8%, which is completely in line with what would be expected for an ART cycle. And there were no statistically significant differences in the groups regarding the incidence of OHSS. So overall, from the phase 3 study, we showed that there was a clinical equivalence with regards to the primary endpoint, the number of oocytes retrieved. All secondary endpoints showed no statistical difference between the Bemfola and the originator Gonal-f. The incidence of the adverse events were as anticipated for an ART cycle, and there was no difference in the incidence of severe OHSS. Furthermore, there were no formation of any anti-FSH antibodies in the second cycle of the study. And this data has been published in the paper by Rettenbacher in RBM Online. This is the clinical data, but what does this really mean in real life? We know that the randomized controlled trials are very strict with regards to their populations and also very strict with regards to exactly what assessments a patient will undergo. But in the real world, we know this is not like this. You, as clinicians, will see patients of all categories with concomitant medications, with other illnesses. So we need to know what has been proven in the clinical trials can be replicated in the real world when all of these factors are taken into consideration. A study that was recently published by Ernesto Bosch and his group at EV looked at the treatment of oocyte donor and the subsequent recipient cycles using Gonal-f, Puragon, and Bemfola. And what they found was for all the parameters, so the total dose, the number of oocytes retrieved, the IUs required per oocyte retrieved, and also the ongoing pregnancy rates, there were no clinical or statistical differences between the three products with regards to these endpoints. Furthermore, a study that has recently been published by Ferrando and his group investigated 26 IVF centers in Spain. All patients had received Bemfola. And what they found, they subsetted the patients into poor responders, suboptimal responders, and normal responders. The poor responders and the suboptimal responders were according to the Bologna definition. What they found was overall, the clinical pregnancy rate, irrespective of which group these women fell into, was approximately 33.6%. And as you can see, ranging from 23 up to 37 in the normal responders. They subsequently compared this to the results from Spain that had been published by De Geiter in 2018, and this was looking at the Spanish registry, which includes patients who have received all types of product and all types of protocols. What they found was From these results, the overall pregnancy rate for the IVF was approximately 28.8. So the 33.6 that was achieved in these 26 IVF centers with Bemfola was in line with these results, and in fact was slightly higher than these results. Furthermore, a study that has been recently carried out in France, which is currently unpublished data, they investigated 19 IVF centers looking at over 9,000 treatment cycles. And what they did was they investigated the live birth rates according to the starting dose of FSH to see was there any difference depending on the dose the patient started with and their outcome. And what you can see is in each one of these groups, there were no differences between folitropin alpha, which included all types of folitropin alpha, versus the Bemfola. And actually in this population, there was over 20% of the patients were greater than 38 years of age. So obviously the slightly more advanced maternal age patients, where we would expect to see slightly lower pregnancy rates. However, all groups were comparable with regards to live birth rate. But what does this really mean for the users of this product? The main users are the nurses and the patients who will then take the products home and use them at home. One of the most important relationships is the training that the nurse will give the patient and the subsequent stress that the patient will feel to then go home and inject herself. These patients put themselves under a lot of pressure to perform everything correctly. In many cases, they have saved and waited long periods of time to undergo this treatment, so they want to make sure that they do it correctly. Therefore, a device or a pen that will give them the ease of use and the confidence that they are using this correctly is something that for them will be a very welcome addition. This was shown by myself and my team here when we looked at how both patients and nurses felt about the Bemfola pen under simulated conditions, where the nurses would train the patients and the patients would subsequently carry out a dummy injection. We then asked them to rate how easy it was for them to teach the patients in the case of the nurses, and for the patients how easy or difficult it was for them to use the pens. And as you can see from the paper that was published in 2018, all patients and nurses found the pen extremely easy to use, extremely easy to teach, and they were confident that they would be able to use the pen correctly. However, this was based on just assessing the Bemfola pen. So we have subsequently carried out a new study that is currently unpublished, looking at the impact of human factors. We're all human, we all make mistakes, and we all need to learn how to do things. So what we wanted to investigate was the suitability of the single-use pens, i.e. Bemfola, versus the multi-use pens, so the pre-filled Gonal-F and the self-assembly Ovalip pen. What we did was we identified, using the instructions for use, some critical errors that if they occur, they could subsequently result in a dosing or an administration error. So for instance, things such as needles not being attached correctly, the dosing windows not being checked for which dose they needed to administer. We carried out this assessment across 4 European countries. And in addition, then, we also asked the users to rate again their ease of use and their confidence in using each of the pens. What we found from this study is that overall there appear to be less critical errors with the single-use pens, and in fact we only found less than 10% of critical errors with the Bemfola pen versus over 40% of errors with the multi-use pens. The main errors that we found to be carried out with the multi-dose pens are that they are not primed correctly, or that this step is missed completely. And this could obviously result in a pen that is not functioning properly, and the patient would not necessarily know that before she tries to give herself the correct dose. And secondly, that the dose windows were not checked to see that they were at 0, which obviously could result in a patient giving herself actually an incorrect dose that could then become either a safety issue if she overdoses herself, or on the other hand, a cancelled cycle if she underdoses herself. The other biggest error that we saw was when a patient required a second pen to complete a dose. So for instance, she only had 150 IU left in her pen, but she had to give herself a 225 injection. So therefore she needed to take the second pen to top up with 75 IU. In the majority of patients, they were not using the pens correctly and trying to calculate in their head what they actually needed to give themselves in the second pen. And in the majority of cases, miscalculating because they were trying to adjust for any priming steps that they had done correctly. We also found that the time taken to actually give the cells their injection was slightly less with the single-use pens. So approximately 2 minutes compared to 3 to 5 minutes with the multi-dose pens. And in fact, in a couple of patients, we saw that they actually required nearly 10 minutes to give themselves some of the injections with the multi-dose pens. One thing that came out of the testing that we were actually quite surprised at, but we feel is possibly the world that we're living in at the moment, both the nurses and the patients viewed the single-use pen, i.e. Bemfola, as more hygienic. And they commented that they felt the fact that you give yourself the injection and the pen is then discarded is much more hygienic because nobody else is then touching it, whereas the other pens need to go into the fridge and someone else could be touching them, or you yourself could be touching them with your hands. So this was something that we were not expecting, but we found very interesting. With regards to the preference of the pens, we found that with regards to the nurses, they nearly 2/3 of them in all cases felt that the Bemfola pen was most convenient for the patient's daily life, and this was mainly due to the fact that the pen was used and then discarded. They would be more confident that the patient would dose herself correctly at home using this pen. And finally, they felt that the ease of selecting the dose was much more simple with the Bemfola pen compared to the multi-dose pens. Similarly, for the patients, they also felt that the Bemfola pen was the least stressful to use, and their comments mainly were there were less steps involved to actually give themselves the injection, and therefore they would feel less stressed to be giving themselves with this pen. They were confident that they would dose themselves correctly at home, and they also said that, yes, the ease of selecting the dose and just the simple ease of learning the pen were much more simple with the Bemfola pen. So overall, I hope that I have showed you that basically using both the clinical trial data and now real-world data that we have collected over a period of 6 years of Bemfola being on the European market, that we can produce similar results in all groups of patients compared to the originator product, i.e. Gonal-f. Nurses and patients find the pen extremely easy to teach, easy to learn, and easy to use. There are less critical errors that can occur with the single-use pens, and the single-use pens have the potential to ensure that the patient receives the correct dose, which obviously will be reflected in her outcomes and the safety. And finally, that the single-use pens are felt to be more hygienic for the users. Thank you for your attention.
Thank you, dear Helen. Dear colleagues, are there any questions? In the meantime, The questions will go in Q&A sessions, and now I want to introduce to you another guest from Belgium, Christophe Blokkel. He is the medical director of Reproductive Medicine Center in the University Hospital of Brussels and the invited professor of Zagreb University, Croatia, in the medical school for the chair of obstetrics and gynecology. He is also the chairman of the Belgian Society of Reproductive Medicine. Dear speaker, Christophe, he will deliver a presentation on the topic, should freeze-all be conducted for all of our patients, please.
Thank you very much, dear colleagues and friends. Of course, I'm a little bit disappointed not to be in your country and that we have to do everything through the webinar, but you know, this is the new normal. I can tell you that in Belgium, we are not the best pupil in Europe and all over the world. We are actually in very bad circumstances, increasing COVID numbers. So it's maybe better that I stay where I am instead of being with you. But that doesn't mean that I'm not motivated to share with you some data with regards to the freeze-all story after the nice lecture of Helen Saunders about Memfola. So first of all, the question that we should ask is, of course, why should we not offer freeze-all to all our patients, and should we maybe still perform fresh embryo transfers? Because, you know, today with such a nice vitrification program that we have, and in terms of avoiding complications such as OHSS, maybe we should do freeze-all for everyone. And we are happy to share with you this quite busy slide. It's a publication that we made together with some colleagues all over the globe. For example, Garcia Velasco, Dr. Pinborg from Denmark, and we looked at all the RCTs, randomized trials, comparing fresh versus frozen. And actually, if I can summarize this slide into these few words, in high responder patients, in PCOS patients, we obtain higher live birth rates when performing a freeze-all strategy. And obviously, we have lower risks of OHSS. When looking at normal responders, similar live birth rates are obtained in fresh versus freeze, but there is a lower risk of OHSS. One of the shortcomings might be the longer time to achieve a pregnancy. Of course, we need to be aware, and this I put in red, of the increased risk of preeclampsia and large of gestational age, because this is coming back in all the papers comparing fresh versus frozen. So we will come back to that topic as well. But let us start with regard to the time to pregnancy. Is it true that the patients need to wait after an ovarian stimulation protocol before starting their frozen embryo transfer cycle? Well, actually the answer is no. They can start immediately. And as you are very well aware, when we trigger with an agonist, we have the oocyte retrieval, and the patients start bleeding after 5, 6, or 7 days following the oocyte retrieval. Well, if we start immediately with our E2 treatment with the estradiol valerate or Progenova, then the pregnancies that are obtained were even slightly significantly higher as compared with delaying, with waiting 1, 2, or even 3 months. So this was a study that we performed in a retrospective way together with the colleagues from Vietnam, Dr. Len, and actually the results were also confirmed in other studies from Spain, for example, also showing that there is no problem to start immediately after a freeze-all cycle. So the time to pregnancy should be rediscussed. Actually, we are talking about a couple of weeks. When is freeze-all mandatory? When should we really perform a freeze-all? Well, there is a whole bunch of indications to perform the freeze-all story. It's, of course, OHSS, it's elevated progesterone. I would like to share with you some data about day 6 embryos. Then we look at the new dual stimulation and progestin-primed ovarian stimulation protocols. We will look into recurrent implantation failure and PGTA. So first of all, the question is, can we still permit ourselves a case of OHSS in our IVF population? It's not nice to see a healthy patient coming in and then a life-threatened condition or a life-threatened patient going out of the hospital or hospitalized in the intensive care unit. So then we could propose, well, let's go not for a mild, but maybe also not for a wild, but for a conventional stimulation with our antagonist. We trigger with a GnRH agonist. We use the nice vitrification program of your lab, and then we perform a frozen embryo transfer. And that was published in the opinion paper together with my, if I can call him my scientific father, Professor De Vroey, a couple of years ago, 2011, if I recall well. Talking about mild versus wild, talking about the number of oocytes retrieved, we have data. We have data in 15,000 women showing that actually, as you can see in the graph, the higher the number of oocytes retrieved, the higher the number of cumulative live birth rate. And you can see that there is a kind of a standstill around 27 oocytes. The curve is still increasing, but not at this speed. But actually, of course, we do not need to hammer our patients with too much FSH. I think that 27 oocytes is already more than enough, because looking at the fresh live birth rates, the optimal number of oocytes, it turns out to be around 13, between 7 and 20 oocytes retrieved. So we need to really distinguish between talking about fresh or cumulative live birth rates. But talking about eggs, are we talking about quality as well? Because it's always very nice to tell your patient you have 18 oocytes, but of course, does it mean that it increases also the number of competent blastocysts? Well, we have data about euploidy, about genetic anomalies, and I can tell you that the more oocytes are recruited, the more blastocysts with normal ploidy rates we will observe. So there is no issue in thinking that if we have too many oocytes, then we will have too many aneuploid blastocysts. It is not the truth. Because looking at this paper from Barish Atta, when he was in the United States, he published that already 8 years ago. He said, well, if I have 1 or 3 blastocysts, if I have 7 or 10 blastocysts, it is independent. The euploidy rate is independent of the number of obtained blastocysts. It is only dependent on the age of the woman. And as you can see, the euploidy rates are decreasing significantly with age of the patient. So interesting findings to see. But Elena Labarta from EV Valencia, she said, well, I want to look at the difference between a natural cycle and a stimulated cycle. Maybe there is a difference in euploidy rates there. And again, she could not determine any difference between natural cycles and stimulated cycles in terms of euploidy rates. So also interesting to see. So yes, we can be interested in a lot of follicles and a lot of oocytes. But then, of course, the question that rises is, of course, if you have a high responder, you need to trigger her with a gene-rich agonist if we use the antagonist protocol. But then, should we freeze or should we fresh? Well, the study came out last week, and we are very proud that it also got an HR alert last week from the people of human reproduction. So I would like to present with you these data from the so-called ICE trial, or implantation enhancement by cryopreservation of embryos. So this is an RCT in 220 patients in a fresh arm and into a frozen arm. So we did a regular ovarian stimulation. The patient had 18 follicles of 11 millimeters or more. So, and at that time, she was randomized into the fresh group, so agonist trigger, oocyte retrieval, and 1 injection with HCG 1,500 units 1 hour after the oocyte retrieval, the so-called Humiden protocol. In the other group, there was also an agonist trigger, but freeze all, and then preparation of the endometrium in an artificial way. These were the two groups. So per definition, since it was randomized, the same demographic characteristics and baseline demographics were observed in terms of age, body mass index, and as you can see, we obtained a high number of oocytes, 18 and 19 oocytes, and it was not statistically significantly different. But of course, this is what interests us more, and the primary endpoint was the pregnancy outcome, so ongoing pregnancy, and you can see that there is a non-significant higher pregnancy rate in the freeze-all arm as compared with the fresh transfer, with the so-called Humiden protocol. So of course now we regret that we didn't do a larger study to see whether this difference in 6% pregnancy rates couldn't become significant. But anyway, we stopped performing a fresh transfer because there was the OHSS that we still observed, although it was only a small dose of 1,500 units of HCG that we prescribed the hour after the oocyte retrieval. So we stopped our fresh policy and we perform in patients where we trigger with an agonist because of high number of follicles, we perform a freeze-all strategy. We know that there is a problem with the ovarian stimulation. We know that the hyperestrogenic environment creates an advancement of the endometrium. And then we have this player of the progesterone. We know that elevated progesterone is hindering us. We know that elevated progesterone in the late follicular phase will decrease, and you can see the red lines, will decrease implantation and live birth rates. But you should also look at the blue line from this paper of Healy in the United States. Well, they said if we perform a freezing or a frozen embryo transfer in elevated progesterone, then there is no impact. So you see that you can even increase the number of pregnancies by performing a frozen embryo transfer. So obviously, elevated progesterone levels during the fresh cycle are negatively associated with live birth rates. We know that, but not in a subsequent frozen embryo transfer cycle. So please do perform a freeze-all strategy when you have elevated progesterone levels. This is for sure evidence-based. About day 6 embryos, or the so-called spring embryo. Well, if you, and this you can observe in the graph, in all age categories, when looking at younger patients, less than 35 years old, or older patients, more than 35 years old, if you perform a cryo of your day 6 embryo, pregnancy rates will be significantly higher in these slowly growing embryos than performing a fresh transfer. So please, if you do have slowly developing embryos on both days 5 and day 6, do perform a freeze-all and replace them in a frozen embryo transfer cycle. What about dual stimulation? And actually, the strategy came from the colleagues of Barwald, and it has been taken over by Siginolfi. And Barwald said, well, actually, between 2 interovulatory intervals, you have maybe more than 1 follicular wave. And maybe we have to think of using this follicular wave that comes also maybe in the late follicular phase or in the early luteal phase. Maybe we should take this into account to perform a dual stimulation in terms of pooling our embryos, especially in the poor responders populations. Because if we obtain more oocytes, there is a higher chance of having an embryo transfer and having an increased pregnancy rate per embryo transfer. We are not talking about increased pregnancy rate per patient. No, it's increased pregnancy rate per transfer. But maybe psychologically it can also play an important role. There is lower chance of having discontinuation, having dropouts in our ART population. And also PGT. If we can obtain more oocytes and more embryos, we have a higher chance of finding a euploid healthy embryo. The cost should also be taken into account. If we perform an embryo biopsy once for a larger cohort of embryos, the cost will decrease significantly and in performing PGTA, for example. So these are strategies that we should really think of. Dual stimulation or the random start of stimulation, both in the, well, first of all, in the first ovarian stimulation, for example, here, starting in the early luteal phase, day 18 of the cycle, as long as you give enough FSH to your patient, regardless of the day of the cycle where you are, then you obtain a nice number of follicles and oocytes. And then you can start your second stimulation, for example, between 1 and 5 days following the oocyte retrieval of the first retrieval, and you can see that you obtain also a nice number of oocytes and even sometimes a higher number of oocytes. But of course, the question is it the right way to go with this second stimulation? Because what about the euploidy rates? But there again, I can tell you that based on this publication of Filippo Ubaldi from Italy, he said, well, patients, the euploidy rate will be even higher in the second stimulation as compared with the first stimulation. So there is no issue in thinking that the second stimulation gives a lower number of euploid blastocysts. It is not the truth. So also an interesting way of helping our patients, but of course there is a necessity to perform a freeze-all strategy again in those patients. Another nice story and a patient-friendly story is the PPOS. And all kinds of progestins, MPA, micronized vaginal progesterone, even dihydrogesterone has been used to prevent premature LH surges. And sometimes we start on day 2, sometimes we try to even start a little later in the follicular phase. Of course, we need to be careful and cautious with that, but this could also suppress adequately the function of the pituitary gland. So we can use it. Of course, let's be careful. because the data, and especially from Spain, show that sometimes the embryo quality could be less when using MPA. So we maybe need to wait for data about long-term safety before implementing this strategy in a generalized way. But it offers us, of course, very interesting topics, especially, for example, in oocyte donors, especially, of course, when we perform a freeze-all strategy. Should we freeze all in patients who have repeated failed implantation? Well, this is a prospective cohort study from our Egyptian colleagues, and the repeated failed implantation was defined as 3 failed IVF cycles with good quality embryos. And look at the data. Look at the significantly higher number of ongoing pregnancy rates in the freeze-all group as compared with the fresh ET group. So we certainly need an RCT to see whether this repeated failed implantation is also another indication to perform a freeze-all strategy, because in this retrospective analysis coming from Paris, in the group of Pietro Santulli, the first author was Mathilde Bourdon, she said, well, we did not observe a higher pregnancy rate nor live birth rate in the freeze-all group. Figures showed to be exactly the same. So there no differences. But of course, retrospective analysis, again, we should have more data. Ladies and gentlemen, this is what interests us most. It is the birth of a healthy child. What about the obstetric outcomes? And it is coming back. With the freeze-all strategy, we have more large baby syndromes. We have larger babies. When we look at the Belgian registry, we observe that frozen embryo transfers have around 150 grams larger babies. And of course, this is not dramatic. And of course, these studies are performed with slow freezing procedure. We need to wait for data in vitrification as well to see if this issue of large for gestational age comes back in the frozen transfer more than in the fresh. Or are we comparing in a wrong way? Because the ovarian stimulation as such could already cause a different placentation, and maybe we should compare apples with apples and not apples with pears, but something to take into account. The large baby syndrome in frozen embryo transfer cycles is there. But there is something else that we need to mention. There is something else, namely the way how we prepare the endometrium for a frozen embryo transfer. And I know this is a whole lecture as such, but I want to show these data. You know that when we perform a frozen embryo transfer cycle in an artificially prepared cycle, the chance of having preeclampsia, severe preeclampsia, and early onset preeclampsia will be significantly higher as compared with a natural cycle frozen embryo transfer with or without HCG. So maybe the lack of the corpus luteum and the substances like relaxin that we don't see in our artificially prepared frozen cycles could be the case. And of course, we need to study this. How can we circumvent the issue of the absence of the corpus luteum? Can we do natural cycle frozen embryo transfer for all our patients? It is a drama for the lab. We cannot schedule anymore. We cannot program anymore, or at least much less. Certainly, for example, in our hands, when we have 5,000 frozen embryo transfers per year, we really need to schedule and to plan and to program. And of course, the use of the artificially prepared programming is of course a luxury, but there we should see what to do. Should we change the progesterone into dihydrogesterone? Should we look at other medications such as aspirin to see how we can circumvent the issue? Or is the corpus luteum unreplaceable? We are performing studies, but in our hands, it was the same. The risk of preeclampsia in our institution in Brussels was higher when using the artificially prepared frozen embryo transfer as compared to the natural cycle. So we need to be very cautious in preparing the frozen embryo transfers. And we submitted our paper, well, it was actually Caroline Roland who submitted the paper now, and we will see whether it will be accepted. But we need to try to find a way how to circumvent the obstetric complications related to an artificially prepared frozen embryo transfer cycle. But ladies and gentlemen, look here at the benefits of the freeze-all strategy. We can schedule, we have better perinatal outcomes, less small for gestational age babies. We have more live births, especially in the high-risk population of PCOS and high responders. We have the OHSS free clinic, and the threats such as time to pregnancy, I can tackle that by stating that we are only losing 2 to 3 weeks, because I would like to tell you one small thing is that we are performing a study comparing 1 week versus 2 weeks of preparation of the endometrium with E2, and we have the same results. So again, the time to pregnancy has become shorter. The only issue is the more large for gestational age babies. Let's have a look. But doesn't it offer a luxury to start the stimulation at any day of the cycle? If we have the PPOS protocol that can gain interest, PGT for everyone, it's also a freeze-all in a day 5 blastocyst trophectoderm biopsy. No more weekends. We can postpone. We don't bother anymore about the progesterone. And yes, you know that I do love eggs, because the more eggs, the better. Thank you very much indeed.
Шановні колеги, ми маємо питання.
Dear colleagues, there are questions to our speakers. First of all, I would like to ask Christoph. The question is the following. At which day do you assess that the progesterone is elevated? At which day you assess progesterone for elevation?
Because we are always looking at the progesterone at the end of the follicular phase, which means the trigger day. And you know that based on the first landmark paper of Ernesto Bosch, the 2010 paper, he told us that as soon as you have a level of 1.5 nanogram per ml or more on the day of trigger, that pregnancy rates will be significantly hindered, both in the long agonist as in the antagonist protocol. But we recently looked in our database, and we looked at the duration of progesterone exposure, which means that the longer you have elevated progesterone, the more number of days you have elevated progesterone, the worse it is. And actually, we even made the comparison between the initial value of progesterone on the day of start and the progesterone at the end of the stimulation. And if the difference is really high between the initial level and the level at the end of the follicular phase, then the outcome will be hindered as well. But this still needs to be published. So let's try to keep the difference between the initial level and the level at the end the slowest possible. then we are fine.
Спасибо, господин Кристоф.
Thank you, Mr. Christoph. There is another question for you regarding large babies. You said large for a gestational age babies, they have problems with further health more often. Have there some studies for further development, for further health consequences for such babies?
Until now, we need to make a distinction between babies who are weighing 100 or 150 grams more, and then the real large for gestational age babies, and microsomia. Microsomia talking about 4,500 grams or more, 4.5 kilo or more. We have to acknowledge that this is still a rare event, but obviously you will never hear me say that that it is negligible and that we should not give any attention to it. Far from there. But please, let us have a look at the more recent vitrification programs. There is really a lack of data of children born after vitrification as compared with slow freezing. So I would not panic at all there.
Спасибо большое. Пока вопросов больше.
Thank you very much. Meanwhile, there are no questions, but there are questions to Helen. And the question is the following. You showed the experience of using Bemfola in France and Spain. Is there any practice of Bemfola use in Eastern Europe?
Yes, but unfortunately, we don't have any published data currently on sort of real-world evidence from Eastern Europe. But yes, the product is used in Eastern Europe and has been widely accepted in sort of many of the Eastern European countries.
Спасибо большое за такой короткий.
Thank you very much for such short but very concise and precise answer. And we continue our work now. Dear all, it's my great pleasure now to give the floor to Svetlana Ivanivna. As always, she has a very interesting presentation, underestimates threats to a woman's full reproductive function. Please. Dear colleagues, I was preparing very seriously for this presentation because I understand that the reproductologists are special doctors who have some different experience, different interests compared to obstetrician gynecologists. But we all do one and the same work. We all are concerned with one and the same issues. As Professor Blocker just said, the baby has to be born healthy, term, and doesn't matter was it conceived, was he conceived in a natural cycle or with use of ART. Today, I would like to consider the issue on the underevaluated threats of full-fledged reproductive function. What are those threats? The concept of providing for a full reproductive functions for a woman in sense of endocrinology. First of all, it means there should be a normal menstrual cycle. Obviously, the woman shouldn't have hyperandrogenism PCOS, acne, or some other physiological signs. And obviously, as it was already said, right now, talking about children with macrosomia, with large for gestation age babies. Very often this happens in patients with insulin resistance, and all that leads to reproductive functions. As regards infertility, to avoid such pathologies, the patient has to have ovulation in good quality for all sides. When needed, we do use IVF optimization, but these parameters, these constant values are very necessary, I just mentioned about. And the pregnancy, when at the background of problematic health, pregnancy occurs in the woman, she has for best continuation of the pregnancy, for the best course, this pregnancy has to have a physiological course. But very often women have insulin profile disorder. That is when large babies are born. And at the stage of pregnancy, the women get gestational diabetes. So the natural cycle regulation and hormone level maintenance is necessary. That is, I believe, a key to provide for a good conception and good pregnancy. The natural regulation of the cycle. And our modern possibilities in this sense are much wider now. It's my great pleasure now to announce for you the new product of Richter Gideon Company, which is a sponsor of our satellite symposium today. This is a product of cycle balance. That is the food supplement which is very well tolerated and in a natural way is regulating the balance of hormones and cycle, increasing the possibility of pregnancy. As regards the content of this product, which was created by order of doctors, of physicians, it contains 2 to 4 grams of myo-inositol and 200 to 400 micrograms of folic acid. Both components, you know about them very well, but I would like to allow myself to remind you on the role of those components. So, colleagues, the new innovation structure, the main function of myo-inositol and its derivatives is participation in the intracellular signal transfer and provision for functionation of a whole number of receptors. We know that now we are considering everything at receptor level of action. Insulin, reproduction hormones, growth factors, catecholamines. Also, it plays a role in the quality of messaging for regulation of intracellular calcium level, signal from insulin receptors, also in metabolism of lipids and regulation of cholesterol level in the blood, and also modulation of neurotransmitters activity. In the cellular membranes, myo-inositol is found in the form of phosphatidyl myo-inositol, and it is a precursor of inosite triphosphate and plays as a secondary messenger regulating the activity of a number of hormones such as insulin and FSH. You see how much complicated is, how much sophisticated is the influence of these components at the cellular level. To continue, just say it, I want to add that inositol-dependent proteins are very necessary to support the functioning of both cardiovascular and immune systems. through reduction of autoimmune inflammatory reactions. Also to support the central nervous system in case of cognitive disorders, depression, panic attacks. Systems participating in glucose metabolism, meaning in a signal cascade of insulin. Myoinositol is a synergist of the vitamins B5 and PP, and some minerals as well, namely calcium, magnesium, and folates. It's contained in large amounts in prostate, epididymis, and the seminal vesicles. It influences the functioning of spermatozoids, regulates the osmolarity and volume of seminal plasma, expression of proteins necessary for embryogenetic development, also influences the motility of spermatozoids. All this is confirmed. It is in small letters there, but it reads about a big number of studies, and you can see the names of the authors conducting those studies. As regards the historical information, myoinositol was discovered by German scientist Liebig in 1848. He obtained it from the wheat growth. In 1902, this product was classified as B8 vitamin. To remember it, I would like you to remember this product as B8 vitamin. Myoinositol is vitally necessary micronutrient. Nearly 3/4 of its daily need is being synthesized mainly from glucose in the liver, but the other part is coming into the body with food. Very often it happens that nutrition modality of a person is not very good, and so a need is appearing to supplement this drug. So whom for could it be indicated? First of all, to support the physiological functioning of ovaries, meaning all those women who do plan pregnancy and who want to realize full-fledgedly their reproductive function. To regulate the cycle as well. I mean, those adolescent girls with disorders of the cycle, and also the women of early and middle reproductive age. Also for the patients having problems with insulin resistance, hyperinsulinemia, hyperandrogenism, dyslipidemia, meaning all those manifestations of metabolic syndrome that we are classically taken into account. Also to treat the ovulatory dysfunction, once more, the disorders of ovarian menstrual cycle, that is what that's how our practical slang says. To restitute fertility and to reduce metabolic risks in PCOS patients, to improve IVF results due to increase of the number of mature oocytes and embryos of good quality, and also to treat and to support the hormonal status in women with acne and with anti-age. I would like to give you rather large evidence-based data regarding the drug and its components. One of the studies performed by Papaleo in 2007 states that myoinositol restitutes the spontaneous menstrual cycle, ovulation and fertility, and doesn't promote multiple pregnancies. According to this study, 72% with PCOS renewed ovulation at the background of only being treated with myo-inositol. In 1992, one of the scientists, Chu, obtained the results of the first study on the efficiency of MI in women in IVF programs. And the elevated MI levels were found in samples of patients' serum after the pregnancy occurred, meaning this component of cycle balance preparat is not only play an important role for pregnancy to occur, but also to support normal development of embryo. And I believe it is extremely important for reproductologists. Another study, which was conducted in 2012, says about that this drug or its component improves the efficiency of IVF protocol and the quality of oocytes in the women without PCOS. Also, I have to show you this study exactly in IVF cycles. The women with PCOS also participated in that study. The results showed a significant reduction of unmature oocytes. That's how the study found very positive influence of myo-inositol on improvement of oocytes and in IVF cycle. Another very interesting study conducted in 2013 regards the capacity for increasing the number of pregnancies in PCOS patients with use of IVF. 3 months before treatment, the drug was prescribed for such women, and it allowed to further on reduce the number of hyperstimulations, which unfortunately not very often but take place in our practical activity. And colleagues, this study proved the improvement of pregnancy course in such women and the rate of pregnancy occurrence itself. So, colleagues, this slide shows myo-inositol as enhancer of fertility in women with PCOS at any level of any stage of treatment. Also, I want to show you this summary slide regarding the survival of the cells and their growth. It regards CNS, it regards the mood of patients who get this product. It regards osteogenesis, metabolism, all very important functions of the organism are found under certain regulation, are regulated somehow by this drug. Another topic I would like today to discuss with you, colleagues, or another component of the problem of reproductive function in women, it is the iron deficit. Just recently, attention was paid, people started to pay attention to this topic. Once more, under the request of the physicians, including obstetricians and gynecologists, new drugs were created, including the drug I will talk about today. As regards statistics, colleagues, according to the data of WHO, 100% of all women with menses, they belong to risk group of iron deficient conditions. As of today, colleagues, we clearly differentiate what is the iron deficient state and what is the true anemia. 500 million women, according to the statistics in the world, do have different manifestations of anemia. And exactly the iron deficit is dangerous for the so-called reproductive reserve. Those are women, adolescents, reproductive age women, and also further on for the mothers and for the neonate babies. Especially, it is important for the development of the central nervous system of the fetus because a huge amount of oxygen and energy is needed for its development. I will demonstrate you the terrible consequences of iron deficit influence impact on the brain of the baby developing intrauterine. This is this impressive statistics on the iron deficit, talking about its production for reproduction and for the relevant consequences. The iron deficient condition with no anemia yet, but look, 75. From 75 to 95% of all anemias are connected with iron deficiency. 63% of children in utero have hypoxia if the mother has iron deficiency, and 20% of maternal mortality is related with anemia. Exactly. The consequences of antenatal deficit is increase of psychic disorders, bipolar disorders in the neonates, autism, almost 3 times higher neonatal mortality, frequent retardation in mental development of those children, the risk of miscarriages, 1.5 times higher risk of perinatal death of fetuses and colleagues. We should also take into account such terrible statistics. So once more, I would like to underline that animal study proved that iron deficiency shouldn't come to anemia level to impact brain. The exhaustion of iron in the tissues, which is determined by a level of ferritin in the CNS, is inhomogeneous. The gray matter is suffering quicker than the white matter, and the architecture is very vulnerable. And myelinization processes are very tolerant but sensitive to anemia, meaning the brain will suffer in the brain of in utero child as the first one. The functional disorders are accompanied by neurons structure changes, and then it will result in all those complications and all those negative consequences I just mentioned about. But we have what we have, as we say, and many scientists and practitioners were thinking about these issues, but no, it's impossible to totally solve it. So preliminary solution was made. It's better a little bit than nothing. Upon the results of a large-scale studies conducted in 2017-2018, it is known that even the very small dosage of iron, supplementation of iron, even without achieving recommended dose, allows to improve the metabolism of microelement in the organism of the pregnant woman. And it is positively influencing the condition of the fetus in utero. The pregnant women who were taking the minimum iron dose at the 36th week of gestation had lower ferritin level and concentration of transferrin receptors, and iron deficient anemia risk was high, but those indicators, colleagues, were normalized in 6 months after delivery. And the babies in the age of 6 months had no deviations registered in the status, in the neuron status. Dear colleagues, the intermediary conclusion could be drawn from there that the subcompensation of iron deficiency with low doses of iron was not sufficient for the mother, but allowed to prevent visible, non-desirable consequences of anemia in children. Those consequences are low weight at birth and IUGR. Agree with me. These problems are now very heavy for our obstetrician practice. I mean those two pathological conditions. And we have to align with WHO. We have to listen to their recommendations. And the best way to prevent iron deficiency complications is to correct iron disbalance even before pregnancy occurs. During gestation, especially at its beginning, it's important not only to support but also to replenish the stores of iron. This prevention is required by all women with menses because you remember the slide, all of them belong to risk group for further anemia, and they belong to the so-called risk group for anemia and iron deficiency. As the need in iron of embryo, fetus and the neonate is very high, so we should be concerned and we should provide for an optimal neuron status before conception even. This is a recommendation to all women of reproductive age and to adolescent women to use iron supplements, 30-60 milligrams every day within 3 months, one time a year. Those with iron deficiency even 2 times a year. The preventive measures are wishable and mandatory. These preventive measures are non-complicated and safe prevention, which will allow young women to maintain iron depot in the so-called resource-ready state, and this woman will be ready at any time to bear pregnancy. With iron deficiency, the pre-gravidary preventive administration of iron during 3 months is critically necessary. It will allow to renew neuron status and to accumulate the necessary 700 milligrams of microelements necessary for conception and for the needs of mother and fetus. At the same time, WHO recommends supplementation of folates starting from pre-gravidary stage up to the 12th week to prevent defects of neural tube and other congenital malformations, and also to improve metabolism of iron, absorption of which is difficult when there is benign vitamin deficiency. Colleagues, we know the postulate everything should be made in time. Postponing prevention for the future is very dangerous. The medical treatment of iron deficient anemia in early term pregnancy has many negative features. Main reason is compliance observance, meaning the adverse side effects of iron-containing drugs. Due to multiple non-desired side effects of iron drugs, the patients do stop to use them due to the deterioration of intestinal epithelium and the availability of gastrointestinal complications. I would like to remind you on the modern trends in the reproductive medicine and obstetrics. First of all, demedicamentization of the pregnant women, meaning using this lower use of chemical agents. Another very important issue is using the so-called supplement therapy, additional therapy, meaning using biosupplements, and it is clearly described by WHO recommendations. So colleagues, the newly created product I repeat, as a request, as an order of physicians, the diet supplement therapy is used in the situation when there is an increased need of the organism in the iron, meaning the period of pregnancy planning, excessive blood loss during menses, limitation in nutrition, when using tumoral treatment, children in the period of active growth, sportsmen, women in perimenopause, in pregnancy, and breastfeeding. This is the drug, tablets containing heme iron. They developed for special situations when normal nutrition diet doesn't allow to get a sufficient number of iron. Administration use is shown on the bottom of this slide, 1-2 tablets once a day for 3 months and even more. What is a heme iron? Why pharmacologists created this drug? And why everybody prefers to use it? Because hemoglobin and myoglobin do have heme iron, and it is uptaken 8 to 10 times better by the body than the non-heme iron. These are the advantages: better tolerance, better absorption, no side effects. And colleagues, to conclude with, I show you the portrait of a patient who can use this drug. It allows to avoid typical symptoms of iron deficiency, and the women are tolerating well this supplement. This supplement belongs to a natural source. In conclusion, I would like to stress on that upon calculation of WHO, not less than 500 million of women are suffering from anemia in the world, because any bleeding would be menstrual or even chronic bleeding from the gums increases the risk of iron deficiency. Every month, as even a healthy woman loses about 30 milligrams of iron, and it is gradually exhaustion, depleting the contents of this micronutrient in the element. That's why WHO is insisting to prevent anemia even before it is manifested. We now are under infection pandemics like COVID, but anemia is being believed to be a non-infection epidemic now. And the payment, the consequences come during pregnancy. Not only obstetrician gynecologists have to fight the consequences of iron deficiency anemia, but also therapeutists, hematologists, pediatric specialists, neurologists, and pedagogues who conduct corrective programs of the children who have problems with psychics and development. Let me finish with this my presentation. I am very thankful to all those who listened to the end and who will use the data I have shown you in their practical activities. Thank you. Thank you, dear Svetlana Ivanovna. As always, there is a lot of questions, but we have only 2 minutes, dear Svetlana Ivanovna. An interesting question. If the patient was taken to TEMA but refused due to discomfort, could it be prescribed therapy right away after that? Obviously, she can be prescribed. Also, I showed the content of iron in this supplement. For a certain time, it will replace it. How long before pregnancy iron supplements should be taken? I would add how long before ART program. I mentioned in my presentation, if a woman or a girl of young reproductive age has problems regarding excessive menses and the bleeding from other place, not necessarily from reproductive problem, it is desirable to start using this drug already at that time. Talking about preventive purpose, it should be started 3 to 6 months before pregnancy. Doesn't depend what will be the way of getting that pregnancy. Can there happen overdosage of myoinositol? No, it never was, and it may not happen ever. Thank you. We are closing with this our session number 1. I thank Svetlana and all our speakers. We have a short break for 15 minutes, and we will have another very interesting section number 2. Meet you in 15 minutes. Thank you, everybody. Thank you.
In life. Gideon Richter, health is our mission. Pharmaceutical research is like life. You have to make difficult decisions while staying focused. Foresight is crucial, just as is being well prepared. This requires stamina, persistence, and constant commitment. And if we stop to ask ourselves, is it worth it? The answer is always a definite yes. Since our therapies heal people, and that is our ultimate goal in life. Gideon Richter, health is our mission. Pharmaceutical research is like life. You have to make difficult decisions while staying focused. Foresight is crucial, just as is being well prepared. This requires stamina, persistence, and constant commitment. And if we stop to ask ourselves, is it worth it? The answer is always a definite yes. Since our therapies heal people, and that is our ultimate goal in life. Gideon Richter, health is our mission. Pharmaceutical research is like life. You have to make difficult decisions while staying focused. Foresight is crucial, just as is being well prepared. This requires stamina, persistence, and constant commitment. And if we stop to ask ourselves, is it worth it? The answer is always a definite yes. Since our therapies heal people, and that is our ultimate goal in life. Gideon Richter, health is our mission. Pharmaceutical research is like life. You have to make difficult decisions while staying focused. Foresight is crucial, just as is being well prepared. This requires stamina, persistence, and constant commitment. And if we stop to ask ourselves, is it worth it? The answer is always a definite yes. Since our therapies heal people, and that is our ultimate goal in life. Gideon Richter, health is our mission.
Доброго дня, шановні колеги. Я всіх вітаю з ювілейним 15.
Good morning, good afternoon, dear colleagues. I welcome everybody with Jubilee 15th Forum of Reproductive Medicine, and we're starting the second session today. We shall have 4 presentations in this session from Belgium, Portugal, Kazakhstan, very well-known speakers and very esteemed speakers. Also, I would like to notice that our session is supported by our good friends and reliable partners, the company Business Healthcare. And thanks to this good support, hopefully our session will be conducted at high level. It will be rather interactive, powerful, and interesting for everybody. I would like to say that new era in the reproductive medicine, in human reproduction, is a challenge for all of us. Because the new era means new look at the things we all know very well already. You look at the standards we use every day, sometimes to the drugs with which we work more than 1 euro, even more than 1 decennium. So it's rather difficult way, rather thin balance between the standards of evidence-based medicine and sometimes even between some empirical approaches. We shouldn't go that way, obviously, because shouldn't go very deeply there, because by living personalized approach in the reproductive medicine, we should stay within rather clear limits, clear range of evidence-based medicine. And it's my honor now to introduce to you Samuel Santos Ribeiro, a doctor from Infertility Valencia Institute from Lisbon, Portugal. He will read on new era in the management of the support of luteal phase in ART to balance effectiveness and safety. Samuel Santos Ribeiro, Portugal, please.
For your very kind presentation. It's an honor to be presenting to you today this very interesting topic, which I hope over the next 25 minutes I will be able to cover as adequately as possible to you. So, as was presented, the objective of today was for us to overview a little bit about the novelty going around luteal phase supports. And I'm going to talk to you about the novelty, but it would be important first to talk to you about what was the mainstay information when we were talking in the last 3 or 4 years or last 5 years. And that was actually a meta-analysis coming from the group of van der Linden, which basically was proposing that however you looked at luteal phase support, the outcomes that you had were always the same, regardless if you had intramuscular or oral progesterone given, intramuscular, vaginal or rectal, or oral, even if you gave low dose or high dose vaginal progesterone, even if you did it microionized or synthetic, even if you did it in a ring or a gel, regardless of how you gave the drug, you were always having exactly the same outcome of equivalence. And there was insufficient evidence to say that one particular protocol was better than the other. So it's important to start that whatever we do, and it seems by this simple meta-analysis that we do a lot of things, and whatever we do, it seems from the first original analysis that the results are always the same. And over the next minutes, what I would like to discuss with you is that despite that, we seem to have more information to give us that maybe things aren't exactly the same, and then it's not only trying to meta-analyze everything that will give you the results. And well, although we all know these results and that giving the medication is the same, it's interesting to look at this result from Weibusch, which shows you a survey of what physicians actually prescribe. And it was a very big study done worldwide. And what it showed you was that 70% of the physicians were using vaginal-only luteal phase supports. And when you see the comparison with the results from 2009, you notice that there was actually an increment of what was being used, and that IM, or intramuscular administration, decreased substantially in favor of an increase of the vaginal approach. So the objective here of today was to try and understand a little bit more the choices of both patients and physicians and why we decide on one luteal phase support over the other. There's also the objective to give a little bit of new information regarding the effects on the pregnancy outcomes of these multiple luteal phase supports that exist. And it's also, with today's presentation, my objective to look a little bit forward into the future and see which are the missing things that we have regarding luteal phase support that needs to be reassessed, including measuring progesterone and even deciding how we do our embryo transfers to start with. So the first thing, and off the bats, I would like to tell you that I'm not going to discuss ACG as an alternative to luteal phase support. And the reason why I'm not going to do that is the data is very clear that it doesn't give you more pregnancies, it only gives you more OHSS. So in my view, and I believe that I'm not the only one sharing this opinion, the use of ACG is something from the past, even though some will tend to give it as a rescue approach. When it comes to the satisfaction of the patient, however, these are the two most classical approaches that are mentioned, and it's what people like to call the American approach and the European approach, or in one case, intramuscular versus vaginal. And none of them are perfect, right? So with the injectable, one should expect that there could be injection site pain and also a possible risk of infection. But there, on the other hand, in the vaginal approach, there are more difficulties in the administration. Patients don't like the irritation and the discharge that it also causes. But overall, when you look at the satisfaction of the patient, and the patients are the reasons why we are here, it seems like the vaginal approach gives them a more satisfactory experience when they are coming to be treated. And these are two studies showing those results, also with visual feedback of how patients were satisfied. And you notice that there was a near doubling of their satisfaction classifications in the study from Yusuf Polsky. There is also another matter, and then now it comes to why do physicians choose one drug over the other? Well, there are many reasons that one can consider to do so. And in the early studies, the first reason to consider maybe using injectable progesterone was the belief that the levels of progesterone in the blood were very, very important. And now I'm showing you results from both Cincinnati and Bourgain, trying to not only assess how much of the progesterone that you give actually circulates in the body, but also trying to assess what that gave in terms of endometrial receptivity. And these are results already from the 90s with Claire Bourgain, looking at a comparison between both oral, vaginal, and intramuscular biopsies. And what you noticed is that the vaginal approach was the one that was giving less out-of-phase biopsies. And it was also interesting to notice, however, that regardless of the type of circulation or the quantity of hormone circulating, which was much higher in the intramuscular approach, well, it seemed that the pregnancy rates were otherwise comparable. And Claire Bourgain's was also a very important data to show that oral progesterone was not a great alternative. And this came to do with the bioavailability of using micronized progesterone orally, that it seemed to not work well during to the first pass. Besides that, it also gave a lot of somnolence. And this came put into, again, into a possible question if can we do something better giving patients oral medication with dihydrotestosterone. So in the objective to compare it with micronized vaginal progesterone. And what this was done and what was compared in, for instance, the Lotus study, was to try and assess that, to see if giving oral synthesized medication would work better than giving micronized natural progesterone. And the results were similar. They showed similar pregnancy rates, similar tolerability, and similar safety. And everybody thought, well, now we have really new data and we can really change everything. Well, it actually really isn't really new data. And if you look at the results coming from before and also the results from this meta-analysis, you will notice that there are actually quite so many studies already being produced comparing the synthetic versus the natural progesterone vaginally and orally. And you see that indeed we already knew for a very long time that the results were very, very similar. So even though we knew for a long time this, why do patients and physicians still tend to give vaginal progesterone more often? Well, one of the points that are many times given is the concern that by giving oral hormones and synthetic hormones, you may be putting into jeopardy the safety of the patients. And really, to be honest, I know that there are studies out there. I'm actually presenting you the study of Zakut, specifically looking at the safety to the child. The examples I gave you before were examples of concerns to the mother. And when you look at the studies to the child, which is the most frequently cited one, you notice that many will, in this retrospective study, mention that indeed the use of a synthetic progesterone could give you a worse outcome and more risk of having fetal heart development issues. Well, this wouldn't be, to be honest with you, my first concern, although it is something we need to be concerned about, but there's not enough data to say that. And when you look at the RCTs, they don't seem to give you that same information. And nonetheless, it is a concern that we need to check out better and see how it could be. However, I don't really think this is the main reason why physicians tend to prefer vaginal progesterone. The reasons why I prefer vaginal progesterone has to do mainly with monitoring and the possibility of us going into the future when we assess luteal phase support. And to give you a little detail of why we believe that this may be the next step to help increasing the pregnancy rate for our patients, I want to show you a little bit about what are the ranges of the doses that currently are used in terms of medication. And what you notice is that there's a huge difference, not only in the dose, but also in the way that we administer progesterone to our patients, something that technically should be standardized, right? And it seems to look correct in all these cases, and everybody thinks that this is reasonable. But the question I want to ask is, let's look at the data. And it's funny for you to notice that if you actually look at the data, what used to be very bad, which was vaginal progesterone, well, it actually with time started to be very good. And I'm showing you here the results of the first meta-analysis comparing intramuscular and vaginal progesterone. And what you will notice was indeed it was showing a huge advantage to giving the intramuscular routes. But please look at the data and notice that all these results are based specifically or mostly in 2 trials that used very low doses of vaginal progesterone on a daily basis. As time passed by, things got a little bit better. And instead of having such a huge relative risk of a huge difference, this relative risk now became smaller and the odds ratio became 0.73. So the more studies we included seemed to give you a less detrimental effect of progesterone. So it seemed that patients and physicians were learning how to use vaginal progesterone more. There was an update in 2008 of this study, but that was later withdrawn. And here are the most recent results, or the latest results from Van der Linden in 2012, comparing specifically intramuscular and vaginal versus plus rectal approaches. And what you notice specifically is that indeed time, in other words, the change of dose of progesterone seems to be what cured the problem that used to exist with vaginal administration of progesterone. And this question of dosing is something that we see all over the studies when you actually assess studies looking at comparing various routes of progesterone. I show you this first study from Silverberg, where he tries to compare the live birth rates in young and older women using vaginal gel and intramuscular progesterone. And what this study originally concluded was that young women that use vaginal gel will have much better results. And you would at first instance think, wow, why is this so different? And why do we notice this in young women? Well, if you really look at the data with some calm, you will notice that actually the older women were using higher doses of progesterone if they were over 40. So it seems to be one of the possible reasons why the results are so different between the age groups. Another study from 2017 was comparing frozen embryo transfers with both vaginal and oral progesterone, and also with other alternatives such as agonist and ACG combined. And what you would notice in these instances is that the ongoing pregnancy rates seem to be better in the vaginal route. And this goes a little bit against the data I was telling you using the oral synthetic route, that we already knew for a long time that it was better. Or, not better, equivalence. But when you assess this with calm, what you notice is that the dose being given by Zaire in their study was a very, very low dose of oral synthetic progesterone, and that could be the reason why the pregnancy rates were so low. And the studies go on. Yet another randomized controlled trial presented in 2017, originally comparing vaginal progesterone with subcutaneous progesterone, and again showing advantage of the vaginal route. And it's first seen that, well, the subcutaneous would not be a good idea. Well, it seems like the dose here in this case could also be the issue, and that most physicians now are using subcutaneous progesterone in a higher dose, in a double dose, than the one that is presented here. Finally, and one now on the opposite side, was an interim analysis presented also of an RCT in 2017. And they were comparing, again, various routes of administration, but they, in the middle of the treatment, decided to compare those that were taking injectable, combined injectable and vaginal, and only vaginal routes. And what they noticed was that in the one taking the vaginal route, the pregnancy rates were something like 15 to 20% lower. The only problem is that they compared with a progesterone dose that we tendentially no longer use, of only 400 milligrams per day. And the primary weakness of the study was actually presented by the authors themselves, saying that they don't know, in fact, what are the optimal doses and timings to give of progesterone. They just use one that they were used to using. And that comes to the future and what we are trying to discuss when it comes to what can we do to increase the live birth rates of our patients, assessing the serum progesterone levels. And I'm presenting you data from the EV group, specific from Elena Lavarta, in which she compared both in the donation and fresh general population in frozen embryo transfers. Can we measure outcomes of our progesterone on the day of transfer, and does that give us different pregnancy outcomes? And what she clearly shows in both studies is, regardless of the source of your oocytes, there is such a thing as having poor administration or poor dosing of vaginal progesterone, and you need to check that, and you need to be able to compensate for that if that is the issue. And so did Thompson in 2018 publish a very similar outcome, this time in fresh outcome results. Their study a little bit different because they propose not only a low threshold, but also a very high threshold in which progesterone may be too much administrated. And again, this all points to a difference in how we treat our patients, looking at personalized luteal phase support, something that is only possible if you are administrating in the vaginal route your medication. Another potential solution that some have been pointing is trying to eliminate the hindering effects of ACG and proposing to replace altogether that effect with a GnRH agonist. And you all certainly know that we can use the GnRH agonists for triggering, and that it is much shorter in activity, even when compared to the natural triggering mode caused by the pituitary. And in comparison to ACG, indeed, the effect is much, much shorter. However, let's look at the data when you try to compare what So would call aggressive luteal phase support, so very high doses of estradiol and progesterone in the luteal phase after agonist triggering. And what you will notice is, unfortunately, the pregnancy rates are lower even when you go to this very aggressive agonist triggering, luteal phase support after agonist triggering. And it's something that puts us in a difficult position because ACG is our routine, and this maybe not will be the easiest way to do things. So others proposed, let's consider the possibility of giving ACG, but in a smaller dose on the day of oocyte retrieval to supplement luteal phase support. This first proposed by Maiden was a very great idea, and was specifically used in those which are performing or had a high response. So the idea was to eliminate ACG and use it only a little dose for luteal phase support. And I'm showing you now the results from a recently published trial which compared exactly that. This proposal of using a small dose of ACG on the day of oocyte retrieval versus simply doing what most centers are doing, which is the freeze-all approach and transferring the embryo afterwards. And what you notice here is, although not statistically significant, the clinically difference in terms of clinical pregnancy rates was almost 10%. Almost 7%. And that is an important number that could have maybe came out as being significant if the sample size was larger. More importantly, specifically in this high-risk population group, the OHSS rate was also rather high in those that did ACG. So it seems like this also is not the greatest alternative that we can have. Some has proposed that we use even lower doses of ACG, or even measure multiple times progesterone and only give shots of ACG or new agonists. But these are all very early days, and more data is needed before applying these sorts of luteal phase coastings or rescues in patients that you want to have an optimal and safe luteal phase support. So it's not only a question of dosing, but some have questioned if it's not a question of timing, on the time exactly that you put in your progesterone. And yeah, the data is more specific, saying, well, so long as you don't give your progesterone before oocyte retrieval, it seems like the results will be more or less the same, even for some people that only give it slightly after embryo transfer. And we even can look at this in frozen embryo transfer cycles, and what you will notice from these multiple studies is that many patients, and this in donation program, give very, very different days of progesterone exposure. And even in normal autologous cycles, what you will notice is people giving 2 days of progesterone and 5 days of progesterone. So there's a huge variation of the timing to start progesterone. But when you look at the RCTs, and I'm showing you now the results of 2 RCTs in day 3 and day 5 embryos, 2 whole days of difference of dosing did not give any difference whatsoever in terms of pregnancy rates. And this again is in similar line to the recent results of Carlos Simon, just published this year, which showed that by personalizing embryo transfer, indeed you might increase a little bit the pregnancy rates, but it's not going to be the likely cure of infertility. You're not going to change the pregnancy rates that we have completely. On the final note, even in natural cycles, there is a recent study comparing various different days of doing your embryo transfer. On 1 day after an LH peak, 2 days after an LH peak, or on day 7 after 2 days of an LH peak. And what you notice is that the pregnancy rates, again, are very similar. So it seems like the window of implantation isn't as narrow as we originally thought. So this is important, however, and we need to know that it's mostly a question of dosing and measuring this dose, because our patients are more importantly thinking about cumulative pregnancy rates. The pregnancy not of the first transfer, but the pregnancy of all the transfers altogether. And what they ideally want is that all these numbers are pushed to the maximum possible. And for that comparison, and looking at the last slides I would like to show you, we would like to compare the natural cycle versus the artificial. And we thought that the luteal phase support differences here were finally resolved by this huge trial from the Antarctica study, which was comparing specifically that in a multi-center level. So it seems when you look at this huge RCT called the Antarctica trial, that this trial would be the say-it-all and resolve the issue. It was a randomized controlled trial, it was multi-center, it did have the problem that it didn't look at live birth, but it was even a non-inferiority trial, so it was actually the perfect trial on paper. Unfortunately, when you look at the results, you've seen that it might not be exactly the study that's going to tell you finally if a natural cycle is the best alternative when compared to the artificial cycle. The first thing you notice is in the natural cycle, endocrine monitoring was not done. What you also notice is that 20% of the cycles were cancelled in both arms, which is something much higher than what we are used to. And finally, it also gave you a very low number of live birth rates, which is a pregnancy rate that we are not used to in modern day pregnancy, in modern day medicine. So unfortunately, in my view, the Antarctica study hasn't told us yet what is the best way to transfer our embryos. Now, to save some time, I'm going to unfortunately skip a little bit the information that I have regarding the more comparisons of the natural versus the artificial cycle. If you want to have that in discussion, we can do it. I want to go directly to the take-home messages to be respectful to the other speakers. And what is important for us to know is that although patients will generally prefer vaginal progesterone due to its convenience, we will need more head-to-head studies to compare their side effects and also the benefits that one can have. There is the advantage of a more predictable uptake, and this is why I believe that more and more physicians are transitioning, like we saw in the first slides, to use more and more vaginal progesterone. And we need more information on the dosing and the timing issues, which have riddled all our previous studies. It's time for us to sit down and talk more about the potential standardization of our doses throughout the clinics. And this is basically what I'd like to talk to you. Thank you very much for your attention.
Samuel, we are sincerely thankful to you for your brilliant presentation. I would like to remind everybody, to the speakers and to the audience, that all the questions will be discussed during Q&A session to take place after the last presentation about 5 p.m. Kyiv time. And also I want to stress that the speakers have to adhere to certain time schedule, 30 minutes for the presentation. And now it's my pleasure to give the floor to our next speaker, our great friend, Paul Piet from Belgium. Paul is a doctor of pharmacy, senior researcher, scientific researcher of Antonio Di Pace Clinic, the member of the board for International Federation of Fertility Belgium. Paul will read a presentation, progesterone support in women with threatened miscarriage or with recurrent miscarriage at late pregnancy terms. Paul, please.
Thank you for this nice introduction. And so my talk of today will be about progesterone supplementation in women with threatened or recurrent miscarriage and later pregnancy maintenance. So that's my conflict of interest slides. And for those who are interested, I wrote 2 publications recently on the pharmacodynamics, the safety of progesterone, and this never-ending story about this fascinating hormone. So just as an introduction slide, I want to explain to you that really recurrent pregnancy loss is emotionally frustrating for couples. Experiencing loss often is a frustrating challenge for their physicians. So this frustration often results in the recommendation of unsubstantiated tests and therapies of dubious efficacy. So that's where we are now. We don't know exactly how to manage threatened or recurrent miscarriage on an evidence-based medicine point of view. But we know that it's a real problem because miscarriage, which by definition is a pregnancy loss in the first 23 weeks, will happen in 1 in 4 pregnancies. And that will induce a lot of anxiety and a lot of depressed women. So it's a real medical concern. We all know since a while that progesterone is crucial in pregnancy. It stimulates the uterus growth and it induces endometrial differentiation. So low progesterone in the early pregnancy was always associated with threatened miscarriage. So we know since a while that a threatened miscarriage has something to do with low progesterone level in the early pregnancy. So we try to understand a little bit better how works progesterone to protect all the pregnancy. And we understood that progesterone has a unique pharmacodynamic profile, and all those characteristics in terms of pharmacodynamics are related not only to the mother molecule progesterone, but also to the metabolites who will bind the several progesterone receptors, because you know there are many, there are 3 at least that we know, the progesterone A, B, and the C progesterone receptors. At the end of the day, we know that it's crucial that progesterone will modulate the maternal immune response. As you may know, the fetus is considered by the mother as a semi-allergenic allograft, and it will be rejected by the mother if there is no enough progesterone production in the background. We also know that progesterone is crucial to improve the uteroplacental circulation, and probably also very importantly at the end of pregnancy, it's important to notice that progesterone blocks the production of cortisol-releasing hormones and inflammatory prostaglandin, who will lead to a premature labor. But probably more importantly, in the early pregnancy maintenance, to favor the implantation, you have to know that progesterone reduces the uterine contractility, antagonizing the oxytocin receptors. And that's probably new data that we have, who plays a very important role to explain what Samuel was showing you in the previous presentation, why progesterone is so important to improve implantation. So we know exactly now how works progesterone to protect the early pregnancy. But a lot of new data came in between 2015 and 2020, and that's what I want to share with you in a couple of slides. So you know that the beginning of the story was the PROMISE trial run by Hari Komarazami in the UK. It was a preventive trial to look at the role of progesterone in recurrent miscarriage. So those population of pregnancies were enriched based on the fact that all those women had an history of previous miscarriage. And you know that in such a risk population, the rate of miscarriage is quite higher. And so the intention of PROMISE trial was to show how progesterone works in recurrent miscarriage prevention. And then came later on, 2019, by the same author, also in the UK, published in the New England Journal, a rescue trial, which is called the PRISM study. And in the PRISM study, they were looking at the effectiveness of progesterone in threatened miscarriage, but this time they enrich the risk population, not only based on a history of previous miscarriages, but also on bleeding. And after those two studies, there was a lot of guidelines, meta-analysis, and new publication showing how progesterone works in those two indications. And there was a first recommendation by the ESHRE expert committee in 2017. And then came the very recent guidelines for the risk of threatened or recurrent miscarriage in IVF population. For sure, there was an update of the Cochrane review database. And more importantly, and I will show you the conclusion of those two very recent key publications, one in the American Journal of Obstetrics and Gynecology, summarizing all the results of PRISM and PROMISE trial, and more importantly, a cost-effectiveness study published in January 2020 in the British Journal of Obstetrics and Gynecology. So before going deeply in the details of those two trials, we have to have a look, first of all, to the Cochrane review. And what's important to note is that for all systematic reviews, and that's true for Cochrane reviews also, the weaker the design of the study included in the Cochrane review, the less reliable conclusions are. And that's very important. And if you look at the most updated Cochrane review about the effectiveness of progestogens for the prevention of miscarriage in women with a recurrent miscarriage, you can see that the design of the study, the quality of the study are more or less very weak. And it's all about very old studies. So the authors were saying that they are uncertain if treatment of threatened miscarriage with progestogen compared to placebo or no treatment has any effect on the rate of congenital abnormalities. So the Cochrane review raised the problem about the safety of those drugs when you use it for threatened miscarriage. And again, when you were looking at the author's opinion, for example, of the Pandian study, which was included in the Cochrane review, all studies were of poor methodological quality except the Pandian study. So you can see how weak was the Cochrane review, even updated in 2019. However, the conclusion of the Cochrane review was that the number of miscarriages for women giving progestogen supplementation compared to the placebo was in favor of the progestogen intake, and you had about 27% lesser number of miscarriages. It was quite consistent to all the studies, but again, the evidence was relatively weak because the design of all those studies was weak, except one, and that's what I want to share with you, the Komorazami study, the PROMISE trial, published in 2015 in recurrent pregnancies. So that's why we will focus mostly on those study results. And you can see that another study, the Kumar study with the oral progestogen, was not so nice in terms of quality of the study. And that was the reason why the ESHRE expert committee made some comment about the results of this Kumar study. So at the end of the day, there was no clear differences between subgroups or miscarriage and different route of administration, but there was a lower rate of miscarriage, moving from 27% in the placebo group to 20% in the progestogen group. There were other systematic reviews about the effectiveness of progesterone or progestogens in prevention of recurrent miscarriage. But as Giancarlo Di Renzo and a lot of experts in the field were mentioning, they were comparing apples and pears because they compare different progestogens, vaginal progesterone, and also all those studies were very old, before the 90s. So it was questionable to look at the real conclusion from this old systematic review. So if you look at the ESHRE guidelines, and you will see that they made some comments, for example, about the Kumar study that you saw in the Cochrane review. And the problem from the Kumar study is that most of the women miscarried before they took the treatment because the high live birth rate who was mentioned in the placebo group. It's absolutely not usual to have 83% of live birth rate in women with recurrent miscarriage. So definitely the ESHRE expert committee was questioning the results of the Kumar study because this unusual high rate of live birth rate in the placebo group, meaning that all those women who took a progestogen, which was dydrogesterone, by the way, in this study, they started dydrogesterone intake after they miscarried for most of those women. A second comment from the ESHRE expert committee was about the Saccone meta-analysis that I showed you in the previous slide. And the ESHRE committee considered that this meta-analysis was flawed by the quality of the older included studies. So what is the real evidence of uncertainty we had in the effectiveness of progestogen for threatened or recurrent miscarriage before PRISM and PROMISE trial? You can see the quality of the trials was very poor. There was a very small number of participants included even in the Cochrane review. The confidence intervals were wide. There was no standardization of the treatment protocol. They included women with 1, 2 or more miscarriages, and there was no stratification by age or by previous losses. Different types of progesterone or progestogens supplementation, different routes of administration were compared. And that was the reason what it was absolutely mandatory, and that was the NIST recommendation in the UK, to go for randomized controlled trial and to explain why we did need clinical trials in demonstrating the effectiveness of progesterone in prevention of threatened or recurrent miscarriage. And so the NIST recommendation was to look at evidence-based pyramid and to take only into consideration randomized double-blind control studies and to look at the systematic reviews only of those randomized control studies. And that's the reason why Ari Komarazami in the UK initiated this program with the PROMISE trial first and the PRINCE study. So the question raised by Professor Ari Komarazami was to think about one very key question: is there a place for progesterone in the management of miscarriage, knowing that before the PROMISE trial was done, the evidence was very weak based on the Cochrane review, based on the expert opinion at the ESHRE, and so on. So the question that Ari Komarazima was raising, he tried to find the answer in two big trials: the PROMISE trial, which was the effectiveness of progesterone in recurrent miscarriage, and the PRISM study in threatened miscarriage. And we will deep dive into those study results. But before looking at the data, it's very important to understand why progesterone should be efficacious in women with recurrent or threatened miscarriage. And that was a very nice study by the group of Ogasawara in Fertility Sterility 2000, showing that independently of the number of previous miscarriages, the rate of abnormal fetal karyotype remained very stable. But at the same time, you can see that the rate of miscarriage increased dramatically by the number of previous miscarriages. And that's probably in this blue zone that progesterone works efficiently to prevent, threaten, and recurrent miscarriage. And based on this study, Ari Komarazami decided to stratify the women at risk based on the number of previous miscarriage. Who more previous miscarriage, who more or higher the risk for miscarriage. And that was nicely shown in a lot of studies in 2010 by Bhattacharya or by Magnus in 2019. And all those studies were nicely summarized in the recent publication in the American Journal of Obstetrics and Gynecology 2020, showing that who higher the number of previous miscarriage, who higher is the risk of a recurrence of risk miscarriage. You can see in case of 4 previous miscarriage, you multiply by 10 the recurrence risk for another miscarriage. So definitely recurrent miscarriage was a very important risk factor. And that raised the question by Ari Komarazami, how can I enrich my population to be sure that I will show some effectiveness of vaginal progesterone for the prevention of recurrent miscarriage? For example, if you treat an unselected population, you will be able only to solve the problem probably in 50 of those 1,000 patients. It's 5%. But if you enrich your population, meaning that you include only women with a history of previous miscarriage, the risk of miscarriage will increase dramatically, and that will be the way to demonstrate if progesterone can work in this enriched population. And that's exactly what he did in the PROMISE trial, looking at women who are not an age which was lesser than 38 years, and the woman with at least 3 previous miscarriages. And what they find in the study, in the PROMISE trial, was that there was a clear biological gradient showing that progesterone works even better the more you have previous miscarriages in the history. And that was probably the main conclusion from the PROMISE trial, even if in the global population we didn't reach a statistical significant level to demonstrate efficacy of vaginal progesterone. In this study, they use Ultrasound vaginal progesterone 400 milligram twice a day until 12 weeks of gestation, and they were showing nicely that progesterone was working even better if the number of miscarriages was increasing. And that's the reason, based on the PROMISE trial results, that's the reason why Ari Komarazami was designing a second study and then stratifying and taking into consideration not only women with a history of threatened miscarriage, but also women with bleeding in the early pregnancy. And that was the design of the PRISM study. So the PRISM study was an independent, randomized, double-blind, placebo-controlled study conducted with the aim to evaluate vaginal progesterone compared to the placebo in women with vaginal bleeding in the early pregnancy. And the first and the only one randomized controlled trial in the history of progesterone enough powered and with high methodological quality to evaluate live birth rate as an endpoint, not the rate of miscarriage after 20 weeks of gestation. So it was the first randomized placebo-controlled study to look at the live birth rate in those women with bleeding in the early pregnancy and 1 or 2 or more miscarriages in the history. That was exactly the answer to address all the weaknesses related to the previous meta-analysis and the Cochrane review. And that's what Ari Komarazami was looking for. Before looking at the results, it's interesting to know that you need some effect size to demonstrate efficacy. For example, if you know that in the placebo group, in such a population at risk, the live birth rate will be 72%, you know that the miscarriage rate is about 28%, which is double more than in the Kumar study. And that's why this study was appropriately designed, because all those women in the placebo group had a miscarriage in 28% of the cases. We know that there are chromosomal miscarriages in half of this population. And the assumption of the PRISM study was to demonstrate that progesterone works in half of the cases. And that leads to an improvement in 3.5% of live birth rate. And that's exactly the results of the PRISM study, because when we were looking at an increase of 3% of live birth rate, that means that you have to treat only 29 pregnancies to save one baby if you administrate vaginal progesterone. That was the pragmatic conclusion of the PRISM study. If you look at the live birth rate after 34 weeks of gestation, you can see that the live birth rate was 3% higher with the vaginal progesterone group, borderline statistical significant, and there was an extra 54 babies saved in the progesterone group. And you will see that in the overall population, including women with a karyotype malformation, it was a borderline statistical significance. But on the next slide, you can see that again, and exactly such as in the PROMISE trial, who more there were miscarriages in the previous pregnancy, who better progesterone was working. And in all those pre-specified subgroups of the PRISM study, you can see that if there were a recurrent miscarriage, more than 3 miscarriages or equal to 3 miscarriages in the history, vaginal progesterone was increasing the live birth rate by 28%, which was highly statistically significant, P0004. That means that in this subgroup, definitely with a level 1 of evidence, we can consider that vaginal progesterone is protecting women from a miscarriage if there has in the history at least bleeding and 3 miscarriages. But interestingly, in the PRISM study, looking at this other pre-specified group, the woman who had only 1 or 2 miscarriages in the history, also progesterone, vaginal progesterone, was protecting the woman against another miscarriage, and it was an increase by 5% of the live birth rate, statistically significant. So you can see that the conclusion from the PRISM study are crystal clear, showing not only that you have a biological gradient of efficacy, more miscarriages in the history, better progesterone works, but it's statistically significant if the woman has at least 1 miscarriage in the history, and the number of patients to treat was 18 if there was 1 miscarriage in the history, and it was only 7, which is really impressive. You have just to treat 7 pregnancies to save 1 live birth in the case the woman has an early bleeding and at least 3 previous miscarriages in the history. So that was the crucial findings from the PRISM study. So what Komarazami did in the American Journal of Obstetrics 2020, he pulled together the results of the PRISM and the PROMISE trial, and you can see that you increase the live birth rate by 3% in this unselected population, because you include PRISM and all the PROMISE trial population, and even though pulling together the results, you are nearby the highly statistical evidence for increasing your live birth rate by 3%. What did also Ari Komarazami in the American Journal, he pulled together all the existing data, and that was the most recent meta-analysis 2020 published in the American Journal by Komarazami. And you can see that not only for threatened miscarriage, but also for recurrent miscarriage, vaginal micronized progesterone at the daily dose of 400 milligrams twice a day protect the woman against a new miscarriage. And it was in both cases statistically significant. So it's also very interesting to note that in this meta-analysis, the major contributor for those studies was the PROMISE trial and the PRISM study, including probably about 70 to 80% of the patients included in this meta-analysis. So we have now really the evidence that really vaginal progesterone can save about 54 extra babies because you increase your live birth rate by 3% at the condition, and it's become statistically significant, that you take into consideration women with bleeding in the early pregnancy and at least one or more miscarriages in the history. As Samuel was presenting in the previous slide, I think that when you deal with intervention or progesterone intake during the pregnancy, the safety concern is very important. And as you can see in this slide, when we put together PROMISE and PRISM study, there was absolutely no more congenital abnormalities or abnormal high number of termination of pregnancy. You can see that the numbers are the same in the progesterone group and in the placebo group. So PRISM and PROMISE trial was very conclusive about the safety also of progesterone during the pregnancy, which was not the case for other progestogens, and that's just an example of the ZACU trial that Samuel was mentioning, showing that there is a concern with synthetic progestogens, in this case dydrogesterone, with the abnormal high rate of congenital heart diseases in those mothers who took oral dydrogesterone during their pregnancy, and there was an odds ratio about 3 in this publication in the Lancet. More recently, by another independent group in Israel, there was also safety issue concern raised with dydrogesterone exposure in the first trimester of pregnancy, and that was based on a database of 2.5 million patients in Israel, and they compare all women taking a progestogen during the pregnancy versus women having no intervention, and against the results were suggesting that there was an increase in hypospadia, congenital aortic insufficiency, spina bifida, congenital hydrocephalus, and overall cardiovascular malformation, a odds ratio statistically significant increase in those women who took oral progestogens during the pregnancy. So safety is certainly a concern, and those findings were not only true in natural pregnancy, but it was also true in pregnancies coming from IVF patients. So that was published recently in the Prenatal Cardiology Journal 2020, suggesting this safety concern with dydrogesterone. So all those progesterone in terms of safety are not equal. And I mentioned in the beginning of my presentation this very recent publication in the British Journal of Obstetrics and Gynecology demonstrating cost effectiveness, which is very important too. And as you can see in this elegant graph, the cost effectiveness, the more you are in the upper and the right side of the graph, the more you are cost effective. So most cost effective and most effective are here. And you can see that in the lower part of the graph and on the left side, there are not so much points. So that was the study demonstrating, giving evidence that progesterone is likely to be a cost-effective intervention, particularly for women with at least one previous miscarriage in the history. So the management of threatened and recurrent miscarriage, which is now proposed and suggested to the NECE guidelines, is to look at women with a pregnancy lesser than 12 weeks of gestation, making the difference between women who have no bleeding or women with bleeding. If there are no bleeding, we know that vaginal progesterone will work nicely if there is at least 3 or 4 previous miscarriages, and the dose is vaginal progesterone 400 milligrams twice a day. And the intention to treat is very significant in this population. If the woman has bleeding in the early pregnancy, you need to administrate progesterone at the condition that the woman has at least 1 previous miscarriage in the history, and you have just to treat 18 pregnancy to save 1 baby in case of 1 previous miscarriage in the history. The dose is exactly the same based on the PRISM and the PROMISE trial, 400 milligram vaginal progesterone twice a day. So that was all the organizations who participate and sponsor the PRISM and the PROMISE trial. As you can see, those studies were not driven by any pharma industry, but was fully endorsed by the National Institute for Health and Research. And so to summarize my presentation, when and how much vaginal progesterone do we need to take? If we speak about the first trimester, you look at vaginal bleeding and at least 1 previous miscarriage, 400 milligrams twice daily will be administered at least until 16 completed weeks of gestation, and you can continue until 36 weeks by 200 milligrams for the prevention of preterm birth. And in women with recurrent miscarriage, 400 milligrams twice a day will be administered at least until week 16. And in some trial, like the Ismail study, they were recommending to administer progesterone until week 28. And the recommendation is to start the progesterone as soon as possible, even in the preconception stage during the luteal phase, because we know by the Stephenson trial that who early you start progesterone, who better it works. And for short cervix detected at any time in singleton or twin pregnancy, the daily dose of progesterone will be 200 milligrams until week 36 of pregnancy. So in conclusion, the role of progesterone in the physiopathology of pregnant women is crucial from conception till delivery. There is a strong biological plausibility to support exogenous progesterone for preterm birth, for luteal phase support, but also now we know for the management of prevention of recurrent and threatened miscarriage. The optimal dose and duration remain to be determined, as Samuel was mentioning in pregnancy maintenance, but the neonatal effects, the health infant, and more importantly, the cost effectiveness with vaginal progesterone is now available with a level 1 of evidence based on all those randomized placebo-controlled trial, recent PREDICT study, the FMF study, the PROMISE, the PRISM study, and the OPTIMUM trial. So I thank you for your attention and happy to answer your questions.
Paul, I would like to remind all the questions we shall discuss at the final Q&A session, which will take place at 5 p.m., after 5 p.m. Kyiv time. We are now following the schedule without delays. It is very good. So all the questions will happen after 5, even earlier if somebody will shrink the presentations. Also, I want to remind everybody that we are waiting for your questions to be made in the chat of Association of Reproductive Medicine. You can send them as message. to the telephone to your discretion. So we shall start to discuss the question in 42 minutes. Now I want to propose you a very short video which will illustrate brightly at least 1/3 of the previous presentation of highly esteemed Paul. This video regards PRISM and PROMISE study, which very brightly and vividly visualize everything Paul was delivering about in the recent 15 minutes.
Hello, I'm delighted to be able to share the PRISM study findings with you. Our clinical trial explored the effects of progesterone treatment to prevent miscarriages in women with early pregnancy bleeding. More than 4,000 patients from across 48 hospitals in the UK took part in this trial. The intervention was vaginal micronized progesterone Utrogestan 400 milligrams taken twice daily from when the bleeding started to until 16 weeks of pregnancy. What did we find? The live birth rate in the progesterone group was 75% compared with 72% in the placebo group. We had 54 extra babies in the progesterone group. Now, we had a pre-specified hypothesis that progesterone effects may be better in women with increasing numbers of previous miscarriages. The reason is that an increasing number of previous miscarriages is linked to an increasing risk of a euploid miscarriage. It is such euploid miscarriages that could be rescued by a treatment like progesterone. Was there a subgroup effect according to the number of previous miscarriages? If there were no previous miscarriages, progesterone treatment was not associated with any increase in live births. However, in women who had 1 or 2 previous miscarriages, if they are bleeding in the current pregnancy, progesterone was associated with a 4% increase in live birth. And in women with 3 or more previous miscarriages and current pregnancy bleeding, there was a 15% increase in live birth. No safety concerns were identified from progesterone treatment. The question is, of course, what should we do in clinical practice? Our recommendation is that if a patient with no previous miscarriages bleeds in early pregnancy, we will recommend supportive care. However, if a patient with 1 or more previous miscarriages bleeds in early pregnancy, we would recommend vaginal progesterone treatment with Utrogestan 400 milligrams twice daily from presentation to 16 weeks of pregnancy, in addition to supportive care. This trial was only possible because of the commitment of hundreds of research nurses across the UK and thousands of selfless women who took part in this trial. Thank you.
It's a wonderful video. Thank you, Mr. Piet. Also, I would like to underline and focus on that. It's always a pleasure when we are work with golden standards such as micronized vaginal progesterone to support luteal phase to prevent from recurrent miscarriages and other early and late losses. The vaginal progesterone, Utrogestan, is for a long time already the most popular way of supporting the luteal phase. And there are studies, and it is a special pleasure, which confirm our very correct and right way towards ideal and clear luteal phase support. I would like to switch now to our third presentation. And I want to introduce Vyacheslav Natanovich Lakshin. You know him perfectly. He is an old friend of Ukrainian Association of Reproductive Medicine, Doctor of Medical Sciences, Professor, correspondent member of the National Academy of Sciences of Kazakhstan, the President, Chairman of Kazakh Association of Reproductive Medicine. His presentation will be on the new possibilities of superovulation stimulation in IVF programs in patients with infertility and donors of our size. Thank you very much, Vladimir Vladimirovich. It is my special pleasure to participate in your symposium. I especially thank Bizen Company for the invitation, and obviously I'm very sorry we're online. I hope this is last online symposium and the next ones will be offline. The topic of my presentation is dedicated to new opportunities of IVF programs with use of new approaches to stimulation. I would just like to remind you that the goal of ARTs is to achieve viable pregnancy and delivery in maximum short terms, and to minimize the number of failures, to reduce multiple pregnancy frequency, which is always connected with problems, to help as more patients as possible, and to minimize the number of possible applications. One of the most serious problems in the modern reproductology is the problem of older reproductive age. More and more such women are happening among the patients of our clinics. There are several approaches. From one side, there are many attempts to prolong the reproductive function of women as long as possible, to support the quality of the cells of the oocytes, different programs, natural cycles, the special programs allow to retrieve several oocytes. And such technologies as cytoplasm transfer, etc. And an alternative program is donation with pro and contrast in both of them. Recently, a very promising is the program with replacement of cleavage or spindle, when this element is transferred to the egg cell of older woman and she gets high energetic support due to the transfer of mitochondria. There is also a possibility to perform transfer of blastomeres into the donor from the donator. There are such attempts. There is an attempt of transfer of donor cytoplasm. This is not very successful method. And finally, the improvement of oocyte quality by transfer of autosomal mitochondria. All those methods are aiming to prolong the life of oocyte in the women of older reproductive age. Today, these researchers have passed from laboratory to clinical trials. There are even first publications which allow to obtain pregnancy in older reproductive age women. I like the study of Tanaka, which says that the clinicians should be oriented on the experience of the previous studies, not to be in a hurry to implement into practice little-known studies where the consequences have been studied for such studies. So we should be careful and conservative in that sense. We understand that there is continuously a balance of risk to benefit, efficiency and safety, the indicators and eventual complications. And obviously today, these complications which may happen, we have to understand that the efficiency of ART program, the rate of birth are not overweighing the life endangering issues. So it's a pity we have very little information on those complications. Everybody has to be as honest as possible. in this sense. I would like to raise today the issues connected with ovulation induction. Today we are talking about the principles of personalized medicine. I do completely agree with Ernesto Bosch on that there should not be generally recognized, generally accepted stimulation protocols. Individualized, personalized approach should prevail. A separate protocol to each patient. Strategy choice for induction and superovulation should be based upon the data of objective biomarkers. The goal of any stimulation of ovulation is to get as more high-quality oocytes as possible. In the number of around 15 according to different studies. What happens if we have more oocytes? This balance between efficiency and safety should be prevailing. And very correctly, one of IVI clinics director said, Juan Antonio Garcia Velasco, that right treatment for the right person at the right time. Certain balance between too much and too little should be there. So the Cochrane database calls more and more for individualization of gonadotropins dosage and selection of the drugs. Personalization, yes, is very important. It's important in the process of hormonal monitoring, trigger, selection of embryology, protocol, and preparation for transfer. Oocyte donation is an important program for realization of reproductive function of patients by embryo transfer, by transfer of embryo received by fertilization of the cell with the sperm. These are latest ASHRAE data published in 2017. We do see that averagely in Europe about 70,000 programs are conducted with donated oocytes. There are not so many countries where those donation programs are conducted. Talking about the pregnancy rate per aspiration, so it is the highest one, and it comes to 200%. Moreover, we can be oriented on this indicator of an assistant. All the rest can be different, different age, different pool of patients, and there are European data of almost 50%. They're different, depending upon how many clinics in the country are reporting which countries it is mandatory. We see that this difference in data goes in between 21 to 36. Ukraine has the highest data. Maybe not all the clinics are reporting, or maybe they found an interesting solution of the problem and achieved the highest results. Same for pickup, for puncture, for ICSI. And here is the pregnancy rate in women with donated oocytes achieves 20 to 87% when used freezed embryos. A little bit less for one transfer, 30% when using fresh embryos. These are data on the acceptability of oocytes donation in different countries. In certain countries, there is paid donation is prohibited. In UK, a number of other countries, you may not conduct anonymous donation. There are many limitations in some European countries. In some European countries, this is a prohibited issue, or there are certain requirements to donors. In our countries, in most of our countries, the donorship is permitted, even anonymous donorship. Only in Muslim countries, the donation is prohibited, where IVF clinics exist. In our neighboring countries, Azerbaijan, Kyrgyzstan, Uzbekistan. In Azerbaijan, Tajikistan, and Uzbekistan, there is no donation allowed. In Kazakhstan, there is paid donation allowed. Not more than 20 children could be born from one a woman. Indications for donation are clear when there is no ovaries or preterm exhaustion, preterm depletion of ovaries, or syndrome of resistant ovaries, with multiple failures of own oocyte program, and with recurrent miscarriages, which is not resolved with use of own oocytes. Any program makes a balance between doubts, frustrations, different informations. It's not easy psychologically for many women and coupled to switch to these surrogate maternity programs. Obviously, an emotional preparation should be made with psychological support. Financial support should be the financial resources needed because the state, the country doesn't support. Choice of all size donors. In Europe, there are banks of all sizes. Our countries are more cautious. Anyways, there are many relations and acquaintances, especially in the families with high birth rate. Today we have agencies, newspapers, internet. There are banks of both fresh and frozen oocytes. Rather big opportunities. Our law says it can be made before 35 years of the donor with a history of absolutely healthy child, etc. The risks of donation programs should be taken into account. We know that genetic risks from the donor side, risks for recipient which may arise, risks for donors which may arise during stimulation and puncture pickup, like different reactions and injuries, and certain risks for the doctor in case of some medical violations. Same for donors, same as for any IVF program, any patient who has to deal with the medicine. This is a list of these risks and eventual complications. There are long-term risks for donors in sense of health, in sense of the progeny. That is why the number of children from one donor is limited. We are trying to create national register of donors, but we fail with this because there is a problem. When in Kazakhstan the donor is not anymore needed, or there are countries where they pay much more for donorship. We know that many women from Kazakhstan go to Ukraine and Georgia, where eventually they are paid more for donorship. In this sense, in this case, there is no sense for registered donors because the real number of donors can be much more than registered. Certification issues are also here. Personalization, to look for more saving approach for diagnostics and treatment. We have to have a larger number of mature sites of good quality, the possibility to transfer them in a fresh cycle if it's possible, and we have to minimize all risks for intensivity of treatment, risk of complications, psychological discomfort, cost of treatment, and equal possibilities as well. The donorship uses all standard protocol which are used outside of donorship programs as well in the patients, in the ART programs, short protocol, antagonist protocol, non-standard protocol, stimulation, including, and the protocol with gestagens. I would like to dwell on now. All the existing protocols, obviously there are risks of preterm LG search, poor controllability. The drug has to be exactly prepared for the program, and there is a need for subcutaneous injection, talking about agonists and antagonists, spontaneous ovulation, side effects, or luteinization of follicles is a concern of us, and also stop of follicles growth. The use of gestagens in ART programs. The old publications from 80s, which gives the news on that progesterone has a critical role in ovulatory LG search. The studies showed the increase, the elevation of progesterone levels before LH search. The progesterone is able to block LH search and also impacts the growth of follicles. and that is why contraceptives containing progestin only have been developed. You know how mistaken can be approaches when we prescribe gestagens for the support of luteal phase, not from 16 days but earlier. That's when we block ovulation in reality. You know there are many progesterones, and the possibility to impact, to influence on endometrium and to inhibit ovulation. Micronized progesterone is one of the most studied ones. We know that progesterone is a hormone that is generated by cholesterol, and the progesterone then gives rise to different other steroids, so its role is rather high. Since 2000, there are studies in China mainly published possibility to use progesterones for stimulation of superovulation in RT programs. The well-known first Chinese study, 123 patients with PCOS were recruited into this study arm. They have been administered Ultrasound and HMH since third day, and then viable embryons were obtained for transfer. Another Chinese study which proved that with peroral Ultrasound use, it is an efficient way to block preterm LH surges. Another Chinese study which showed that the treatment with Ultrasound and HCG, maternal CGG was possible in this program. The stimulation of ovaries with progestins may be first choice to preserve quality of oocytes. It was the first work in 2016 by Antonio Lamarca. These studies laid ground for us to conduct same studies. Since 2018, we were the first in the post-Soviet NCIS and maybe in Europe. We haven't seen such works. When Ultrasound, the micronized progesterone, was prescribed since the second day of stimulation cycle instead of an antagonist, which normally is prescribed when follicle achieves 14 mm size since the 9th day. That is how we managed to stop preterm luteinization and preterm LH surge. These are our data for 3 years, 201 program of stimulation, 2 groups of patients. The main one for donors of oocytes stimulated with micronized progesterone, as a second group with the same donors but with use of antagonists. The groups were similar in age, mainly women under 35 years, with similar IMT, with similar BWI. In the first group with Ultrasound Peros, most of them have got the dose of 200 mg and the large part, 8%, 100 mg. In the control group, those have been antagonists with short agonist protocol and a long agonist protocol. Small part has got antagonist. In the first arm, compared to the second one, there have been no great difference, but the combined prescription of FSH and LH was in the first group, 82%. That was just by case. We analyzed all the stories and saw that we have got the percentage of mature cells, which was not different, same as the number of obtained oocytes, retrieved oocytes in the group of studies. Then we divided the group with micronized progesterone on 2 subgroups. 34 donors whose oocytes have been solved in fresh cycle, which have been given for fertilization in first cycle. Another group where the group was divided. You see, by fertilization method, the groups were quite identical. 47% IVF ICSI and 53% ICSI. In the second group, there were more programs with ICSI. Embryological protocol wasn't so different. The percentage of rate of fertilization was equal to 52% in donors, a little bit higher in Ultrasound group. We compared two groups. They were not different in fresh or frozen cycle. More cancellation of transfer was connected with that frozen and transferred embryons. The cryopreserved embryons were transferred after frozen. We also used PGT. You see that the groups were not so different in the number of unemployed embryons. The young women, up to 40%, they have been unemployed embryons. In the first group, employed made 60%, the second 59%. Cryo transfers of frozen embryo transfers. You see, the groups were very small, 8 and 6 patients respectively, and the pregnancy rate was not different in both groups. Also, we left the frozen embryos retrieved during the program. No great difference in pregnancy and fertilization rate. Pregnancy 45%, in the second group 38%, and the number of intact oocytes in the group of Ultrasound was higher. The quality of oocytes which were transferred after freezing, but it requires additional studies. The percentage of fertilization of those oocytes also was higher. This study, by the way, we are continuing this study. We are now believing in this method of use of micronized progesterone for stimulation of ovulation in donors and also for transport programs. Patients from Uzbekistan and Tajikistan comes to us, and it turned out to be that progesterone works better to prevent this LH surge. Our conclusion says that the number of fresh, mature and intact oocytes in both groups wasn't practically different. The rate of fertilization and vacillation in donors with stimulation by micronized progesterone has no significant differences from the results after standard stimulation. The number of employed embryons was the relevant. Whom for can we propose stimulation by micronized progesterone? For the donors of oocytes when there is a need of cryopreservation of freeze-all embryons after genetic study of embryons with the risks of PCOS, multifollicular ovaries, with cancellation of embryo transfer due to different reasons, for patients with spontaneous ovulations in the previous stimulation protocols, for patients with confirmed luteinization of follicles in the previous stimulation protocols, and obviously for the convenience of patient and physician. The so-called transport schemes are used. I'm happy to be able to share our experience of conduction of programs with use of micronized progesterone. I want to thank you for the attention, dear colleagues, and I am looking for future live meetings. Thank you very much. Vyacheslav Nathanovich, we are very thankful to you for your brilliant presentation with an incredibly big practical effect and significance. I believe that there is no way will be many questions during the discussion panel, and we shall switch to it very soon already. The President of Association of Reproductive Medicine in Ukraine, Mr. Yusko, is joining us. Thank you all, the audience. Thank you very much to Samuel, Paul, and to Vyacheslav Nathanovich. Thank you very much. It's my great pleasure. It was my great pleasure to listen to all the reports Very interesting. Thank you very much. And I want to, for this interesting session, to be continued by Vladimir Kotlik, controversial issues of hormonal endometrial programming. Please, Vladimir Vladimirovich. Thank you very much. Dear colleagues, it's a very interesting issue, and I would like to stress on that the first slide, first picture, I believe it is very efficient and interesting. It is a metaphoric representation of the changes which happen every month in the organism of the woman and in the endometrium. If you look attentively, this is a mythical bird phoenix, which every month basically dies and rebirths like endometrium in a woman. You can see the contours of ovaries, uterine tubes, and uterus here. I believe it's very interesting picture, but we have to understand that improvement of the pathophysiology of endometrium development was promoted by modern tools of cellular and other studies, and also a change of structures underlying the endometrial receptivity, what we call functionality or possibility to generate the so-called implantation window. It's a very important point. We have to optimize and to provide for high accuracy of patients' management tactics. Let's look at this slide. We shall move automatically to the right. Why so? Because we love very much the luteal phase. The proliferative phase is just a given orphan we pay very little attention to. We even do not understand, and we are forgetting about such term exists as proliferative defect, the defect of a proliferative phase. We always talk about luteal phase insufficiency or deficiency, and we forget about proliferative phase defect, even don't mention them. But really the situation is much more complicated, and we do understand that estradiol, which is a key factor of induction for cascade mechanism both at molecular genetic level and at the level of cytokines, and internal factors of cellular exchange metabolism is intermediating this exchange through two signal ways: nuclear and steroid-induced. Two nuclear receptors have been identified, the one alpha. Into the nuclear way to estradiol, it is linking to beta or alpha receptor. The activated estradiol ligand is translocated into the nucleus, where it recognizes specific elements of hormonal response, very frequently located near the promoter areas of target genes. Estrogens also modulate gene expression helped by nuclear non-direct mechanism, including mechanisms of interaction of estrogen receptors with other transcription factors, which in its turn are linked to the related DNA elements. In the alternative membrane ways, estrogen can act through G proteins coupled estradiol receptors located on the plasma membrane, and also is involved in the activation process is the inosine phosphate and cascades of protein kinase. All these cascades are quickly activated and influencing transcription factors. Downstream, and we'll see it. Different ways activated when estradiol is linked. This process can be classified on four main cascade signals: phospholipase, also phosphatidylinositol 3 kinase, also protein kinase. All those 4 passes provide for a lot of opportunities for interaction with some other passes. The cross talks between signal passes allow to get a wide reach. It activates different signal passes depending upon the response of the cell and of its physiological state. I want to underline that when estradiol is connected, is binding to estrogen receptors, it produces a quick translation of signals and structural and relevant changes result in the number of presses, namely synthesis of protein by free ribosomes and plasmatic reticles, accumulation of the relevant fibers, mitochondria, Golgi apparatus, the nucleus increases in size, and chromatin becomes visible. The nucleuses of different cells are increasing in proliferation phase. The endometrium achieves approximately 8 to 10 millimeters in its size at the peak of its height. It is also the day number 9 or 10. It is a norm. And here we have a very interesting point. When I was reading this monograph, it was quite a news for me. And exactly, the endometrium peak falls to the time when the estradiol level is still increasing. What it proves to? It proves to that there are some endogenous slowing down induced by endogenous proliferation. We don't know about this signal. What we have in 2 pathologic cases. In the first one, when there is no such a break, we have uncontrolled endometrial proliferation resulting in hyperplasia, but main questions we will touch in this presentation is hyperplasia of endometrium, thin endometrium. What problem is this? Where it is hidden? How can we influence it? That break that stops endometrium proliferation not at 9th or 10th day at the height of 9 to 10 millimeters, but at the height of 4 to 5 millimeters. A rather interesting picture we have here, which kind of an original view at endometrial changes represented by London. So it is a proliferative phase in the center. If you look attentively, you see it is highlighted in orange color. And at point 2, it is divided on several branches. There's 4 passes which can act together or separately. Proliferative phase defects, which we define as thin or hypertrophic endometrium, when we see them more frequently in women with multiple miscarriages, with recurrent miscarriages. A recurrent miscarriage means endometriosis, sometimes PCOS. All those issues result in that the hyperplastic endometrium has low proliferative activity, has a defect of proliferative phase, which obviously further on results in problems with receptivity. I will not dwell on those issues, they are obvious, colleagues. All those structural violations, disorders of endometrium have to be removed before planning embryo transfer. It is obvious. I would like to dwell on an aspect concerning the upper middle picture in the slide is chronic endometritis. Why I want to dwell on this, although it is quite controversial topic, is kind of a scandalous topic, because many reproductologists and even gynecologists, whilst having own understanding on that chronic endometritis is, according to International Classification of Diseases, is a formal official diagnosis, but has it really such fantastic share with multiple recurrent implantation failures. And I have got a very interesting text by Archibald Donald and colleagues, which is dated with 1911. In the whole gynecological branch, there are no such prevalence of cases like chronic endometritis. It is year 1911. This term has been commonly used to denote a class of cases which are well known clinically but difficult to define. That the whole subject is still in a state of confusion is apparent to everyone whose duty is to try and give a clear account of minor gynecology to medical students. At the present time, one turns in vain to the pathologist for the light. Nevertheless, we propose in this condition to continue the use of the name chronic endometritis with definite statement at the outset that we do so merely as a matter of convenience. Colleagues, 110 years passed since that time, no basic changes, I observe, frequently speaking. On one side, there is worse statistics where chronic endometritis is as a reason of recurrent implantation fail shows 10%, but every second biopsy contains endometrial cells in high concentration. When I say every second biopsy with endometritis, where it is, means reproductologist who wants to detect something in the poor woman or in the vivid imagination of a pathologist. It is a discussable, argued question. A fresh paper by Cecilia Valdez, by the way Carlos Simon participated in. It's more philosophic nature. It goes about that implantation disorder of endometrial origin. Is it pathology or not? When the endometrium doesn't change, the authors on the pages of Fertility and Sterility Journal believe this is not a pathology. It is our failed attempt to synchronize a developing embryo with receptive endometrium. It's very interesting perspective, and I do agree with it by 100%. It's well known from Noyes times that the same implantation window, the same receptive endometrium, has a certain variability. What is the reason for that? The reason is we don't have 100% clear instruments as of now for its exact study. In 1950, Noyes formulated his opinion, stating that the histological picture of endometrium sometimes doesn't match its functionality, doesn't correlate in any way. There is no correlation with the changes characteristic for high level of secretory transformation of endometrium. This slide shows the historic way which led us from a histologic assessment, structural assessment of endometrium to its functional aspect. To that, what determines its receptivity, the capacity of comprehensive dialogue between embryo and uterus. First time it went the speech about implantation window in 1950, and the attempt to study it, in my opinion, a successful attempt, but this position has to be yet should be criticized a little bit today. It was this study by Diaz Guimero and Carlos Simon, starting since 2011, when the method of endometrial receptivity way first was started in the scientific links, and now it arrived to practical level. In 2014, this was the year of a wave, of a tsunami of first studies. Everybody was enthusiastic about. Everybody thought the problem is solved. We have the beard of the God, of the Lord. We have this golden clue allowing us to perform 100% successful embryo transfer by genetically testing it and morphologically monitor it and study it. Embryo has to 100% conduct a effective dialogue with receptive endometrium if its receptivity was proved at the molecular and genetic level. That was our opinion at the time. And many studies which were converted to monographs, very interesting monograph by Carlos Simon, I recommend all of you to read it. It underlines big perspectives of using sequencing of endometrial receptivity at the level of the relevant number of genes in the expression. All those aspects are not promoted by a little disadvantage. As Valerie Hertz was thinking, the heart of a beauty is prone to change like May's wind. In this case, the variation and changeability of endometrium in structural and functional changes is conditioned by alternative splicing and results in that, unfortunately, the information we receive from ERA is 100% matching the cycles during which we tested it, we studied it. It doesn't give us a 100% certificate we can be sure about that receptive, pre-receptive or post-receptive endometrium will be exactly in the cycle planned by us for embryo transfer. That's why the new horizon is what gives us an impression from transcriptome. Those are metabolites, proteins. Why so? Because basically we can study them automatically in the cycle we plan the transfer for, but it is the era of studies up to now. It goes not so quickly like the era of ERA was passing the endometrial receptivity array. But we expect that during our life we shall get the first positive results already. I don't want intentionally to dwell on immunological studies moments, just to note here that when we colleagues take a decision on the diagnostics and treatment of the so-called immunologic factor, I have nothing against the immunologic factor as the reason for recurrent pregnancy loss, recurrent miscarriage, but it goes about immunological factor as a factor of recurrent implantation failure. I want to underline here that the reproductologist, when acting from the position I do believe or I do not believe, it is not quite correct in sense of attitude to yourself and to the patient. We don't have a high-class evidence level for efficiency of using diagnostics and further treatment of eventually not existing immunologic factor which somehow would influence implantation. That's where we have to stop and to look at the eyes of the truth, to look at your own eyes and also evidence-based medicine data which do not support these issues. much popular aspect concerning the study of microbiota. We all agree it has high significance, but the question here is about the accuracy of this study. This pupil, a very thin catheter, entering the cavity of the uterus and retrieves its content, which is not sterile. What do we have here? I'm sure, and I'm sure that many of you are not sure that we get exclusively pure aspirate of uterine cavity. It's impossible to penetrate with catheter the uterine cavity without contaminating its bacterial viral flora, which may be contained in the protection layer of cervical canal and in the cervical content. I'm not sure this method is by 100% perfect. Most probably due to that, the contamination with bacterial flora, with vaginal cervical flora, can have an influence. The scanning electronic microscopy left for us such beautiful pictures, which on top of this beauty and wonderful corals have no other clinical significance and implications, have only historic significance not connected with diagnostic value in the sense of endometric receptivity assessment. Let us switch to more practical issues. The time is flowing, and we shall now discuss the methods influencing the endometrial programming. Eventually, we shall follow this, we shall walk on this very thin border between standard therapy, I mean HRT, and talking about adjuvant therapy, which already is beyond adjuvant therapy part, talking about double transport, which really has significant positive effects, and all the rest is very doubtful. Scratching, use of growth factors, immunotherapy. I will talk about it a little bit later. Using uterine relaxers and stem cells. The British Fertility Society Policy and Practice Committee, talking about adjuvants, they do not find sufficient grounds to recommend this method in the state institutions. I have visited few clinics in London 5 years ago. I know the adjuvant and empirical therapy is used rather broadly there, but not in the state IVF entities. It's a very interesting table describing lipid emulsion, intravenous immunoglobulin, corticosteroids. It shows real medical indication for the use of these drugs. It is a second column. The third column describes side effects. If we use them and understand that the clinical effect is not proven or is doubtful, we know that these adverse events described when using practically all the adjuvant therapy drugs. So better use nothing than these drugs producing such adverse events. I will not dwell on adjuvant transfer, just talking about sexual life, to wake you up if you are now sleeping. Want to say that the latest studies confirm the opinion of many authors. We have even 2 meta-reviews here on that there is even no reduction of birth rate for live birth rate, who are not limiting themselves in sexual life, but even there is a significant elevation, growth of pregnancy rate, without impacting ongoing live birth rate. ongoing pregnancy or labor rate. There is no negative impact. That's 100% sure. I believe if we remove these barriers for the patient and they will feel themselves more free and psychologically relaxed in our programs, the pregnancy rate will be higher, if not so greatly, but at least somewhat higher. Why I repeat this picture? Because we are coming now back to the tools we have within evidence-based medicine. I mean, it's just two agents we have here, estradiol and progesterone in the upper left corner. These two substances launch rather complicated and deep process you observe in this slide. The process of proliferation of endometrium, process of correct secretory changes which should result in the opening of the so-called implantation window. That's practically everything. I would like to talk to you about the practical issues of use of estrogen priming. They are outlined in these diagrams. These are two ways of using transdermal estradiol, estrogel, rather easy ones. Very frequently, reproductionists use the monodose. The studies show that the clinical efficiency is quite the same. But basically, if we approach natural aspects, if we move back to nature, like they say, it's better to use a dose of with minimum, from minimum to a middle one, 1.5 to 5, 6, the maximum milligrams of estradiol. Regarding the use of micronized progesterone, no questions here. When achieving 7 to 10 millimeters of endometrial thickness with its normal ultrasonic picture and with normal pattern, micronized progesterone can be supplemented with progesterone, and accordingly at the 6th or 7th day of progesterone use, there are certain controversies at which day progesterone should be transferred, should be embryo transferred. Many clinics make it as the 6th day of progesterone or 7th, although they indicate P6, but they don't calculate the 0 day. These are some nuances, but it doesn't critically impact pregnancy rate. It remains within same range. Would it be 7th or 6th progesterone day for embryo transfer? That's why I'm more prone to use a dose which is increased, not the monodose, but the increase in dose, because it's more natural. I already mentioned on the types of protocols. They are not relevant, not significant. Would be monodose or increased dose, same clinical result. We have. I want to repeat that the administration ways are critical. It has been proved that the oral estradiol forms, whilst having similar clinical effect, do have much more of adverse effects, of side effects. If patient safety is a priority for us, we have to understand that transdermal route is more safe for the patient. It has no first passage through the liver. In 100%, it is tolerated without allergic reactions and without generating side effects connected with headaches, breast edemas, high risk of cardiovascular disease. Only after first passage through liver, the level of estrone is increasing, which can result in cardiovascular disorders and venous problems. Endometrium sickness is important, but the studies shows that the structure and pattern is more correlating with receptivity than the sickness. I will dwell here on just a second, talking about the aspects that there is no basic significance. Would it be 5 to 7 days or more than 2 weeks? Is the estrogen priming? Same results for pregnancy rate, for miscarriages rate. It is higher if we prescribe empirically quite early the progesterone, earlier than 7th, 8th day of estrogen. It was mentioned a lot during today's presentation about Ultrasound. I will not add to this, to that high appreciation, high evaluation made by the practitioners and by the scientists. Just I want to say that in my practical activity, when talking about uterine hemorrhages, especially after embryo transfer, their rate is much lower when we use 800 milligrams of progesterone. You will see those doses in many studies, because the standard dose we use is 600. But if there are grounds to think, to believe that the patient might react with hemorrhage or bloody spottings after embryo transfer, which is brings great stress to the patient and less stress for reproductologists when the patient calls them tonight, it's better to give 800 milligrams, 600 milligrams intravaginally, and the last capsule of Reproduction at night. Conclusions, colleagues. I will not repeat everything I said because I already violated the time schedule a little bit, but I would just want to say that the conclusion that those drugs which don't have the first passage, as first hepatic passage, and which were approved for efficiency and safety, I mean transdermal estradiol for estrogen priming and the micronized progesterone for intravaginal micronized progesterone for luteal phase support, these are the golden principles. The experience shows that even the platinum standard we used, and luckily we have such a study as PRISM, it's rather fresh. Seems no confirmation, no proof is needed. Everything is quite obvious, but I want to underline once more that it is a special pleasure that the fresh studies confirm, dear colleagues, that we are following the correct way. Thank you for your attention. The right way. And I believe we should switch to the discussion. Questions and answers, please. Can we have questions?
With respect to our foreign colleagues, foreign speakers, I would like to start our discussion panel in English, and we have a few questions for to our participants, to our speakers. Just a moment. Can we see our speakers in the screen? Спікери нас чують чи ні?
Our foreign speakers, do they hear us? Can you hear us?
Чують.
Also.
А хто нас чує? Вибачаю.
Sorry, everybody is in place now. Okay, very well. Paul is here. So the first question
to Paul. Vaginal bleeding is a common complication of pregnancy in patients after IVF. A patient who receives 600 milligram per day vaginally, what is the tactic in case of treating miscarriage? Question to Paul. Paul, are you hear us?
Ще раз просить, ще раз до Поля. Він не почув питання.
Paul?
Paul, can you hear us?
Samuel, can you hear me? Samuel, can you hear me? Good. Okay.
I hear you
Question to
perfectly.
you. Samuel, how to combine different form of progesterone in equal proportions, intramuscular and vaginal, or it's better to increase the dosage of the vaginal and reduce the intramuscular? A question from the Ukrainian reproductive doctors.
Yeah, that is a very, very interesting question. So the question is, once we notice that the patient hasn't observed correctly the progesterone, what should we do? And so at the end there, I can tell you the practice that we have in EV, and it varies a little bit country to country. In EV, Spain, or the majority of the Spanish clinics, they will do subcutaneous supplementation together with the vaginal approach. In Portugal, we do it a little bit different. We replace the vaginal with the intramuscular approach, but we do it just due to logistical issues, because we have intramuscular and we don't have subcutaneous. It has only to do with that. It has nothing to do with anything else. And what I can tell you is that we have internal data which we are trying to collate now and publish. And what we notice is, regardless of the strategy that you use, situation one, if you start new supplementation from the day of transfer onwards, you're still rescuing adequately. Situation two, the decision to perform intramuscular or subcutaneous plus vaginal seems to rescue both adequately. So the most important question in our view at this moment, or in my view at this moment, isn't what is the best way, but is, are you measuring your progesterone on the day of transfer or not? Because if you're not, 25% of your patients have an injured outcome. And basically, that is the answer to my question.
Thank you very much indeed. Thank you. Paul, are you hear me?
Yes, I hear you.
Perfect.
I lost.
Perfect. At least, can I repeat? Paul?
Yes. I can answer
one question from Ukraine.
Question.
Okay.
Yes.
Vaginal bleeding is a common complication of pregnancy in patients after IVF. A patient who receives 600 milligram per day vaginally, what is the tactic in case of a treating miscarriage?
Okay, so probably Samuel can also ask this question, but in my experience and based on all the clinical trials we did with our vaginal progesterone, in IVF patients, we know that by increasing the daily dose of progesterone, you will decrease the bleedings. And we have a lot of experience, for example, in patients with oocyte donation and so on, or for replacement therapy. When you increase the progesterone intake, the daily progesterone intake, you decrease the bleeding. When we did the non-inferiority study comparing, for example, Ultrasound 600 milligram with quinone, which is 90 milligram, we know that with quinone gel, you have about 1 patient in 2 who will face bleeding problem in IVF cycles. and with Ultrasound 600 milligram, it was about 1 in 5. But we know that now the trend is to use higher daily dose, as the previous speaker was mentioning. And so when you use 800 milligrams daily, you decrease the rate of bleeding. So my opinion, in my experience, at least based on clinical trials, increasing the daily dose, you decrease the bleeding. And that was our experience in the PRISM study, where we were using 800 milligram twice a day, 400 milligram twice a day, which is 800 milligram. We didn't have any bleeding. And if the threatened miscarriage is caused by a progesterone deficiency, probably that progesterone increase, the daily dose of progesterone will decrease the bleeding profile.
Okay, thank you. And one more question for you, Paul. How likely is the teratogenic effect of testosterone when it's used in ART protocol with the subsequent transition to pregnancy support with micronized progesterone? I think in combination.
You know that there is no face-to-face study, and so all the data that we have about the safety concern with oral progesterone are based on observational studies. That means that we are not sure that the oral progesterone is the cause of those heterogeneity or congenital heart malformation, but at least in terms of pharmacovigilance, we call it an unsafety signal. So, and that's why probably worldwide we are using, and the clinicians prefer to use vaginal progesterone, because there is absolutely no safety concern when you use progesterone, which is the hormone of pregnancy. Definitely, there are now 3 independent studies, one in Singapore, one by Zakut in the Band de Gaza, and the third one in Israel, 3 independent studies coming to the same conclusion that there is a systematic increase, probably about double the rate of congenital heart malformation when you use oral progesterone in the early pregnancy. The problem is that we have a huge experience with oral progesterone when you start the treatment after 6 weeks of gestation. Unfortunately, we don't have any experience except for the Lotus 1 and the Lotus 2 study. We don't have so much experience when you initiate your oral progesterone before the implantation. And that's why we need additional studies. And that was the conclusion of the expert committee at the ESHRE level, who changed the recommendation 6 months ago, going for a conditional recommendation for oral progesterone, but a strong recommendation for vaginal progesterone. And as Samuel was mentioning, in the website survey, which was updated in 2018, there is a trend to use more and more vaginal progesterone instead of oral progesterone for IVF cycles. And as Samuel was mentioning, certainly in a frozen ton embryo transfer cycle, where there is a real need to monitor progesterone blood level. And as you may know, we cannot measure progesterone levels when you use oral progesterone, because the active hormone of progesterone is a 20-alpha dihydrogesterone that you cannot measure in blood.
Thank you very much indeed. And last, very short question to Samuel. What is the percentage of testosterone used in IVF cycle in Europe, approximately?
Yeah, well, so I wouldn't be able to give you a correct cipher, because the study that was presented, they didn't really show, to my knowledge, a division between continents. What I can give you is the experience from the 3 countries that I've worked before. And what I've noticed is that the use of oral progesterone is somewhat increasing, but it's very individual physician dependent. So you won't notice that it's tailored. It's one physician will use it systematically while the other will not. There are some studies which, in my view, are very interesting, coming collectively from the Iberian Peninsula and France to assess the use of replacing injectable progesterone with dihydrogesterone. So in this case, to use synthetic oral when you have a low measurements. But even then, to my knowledge, it's not a very common phase. It is increasing, in fact, but now we saw again a trend going back down after the unreassuring data regarding safety and the updated guidelines.
Thank you. Is Vyacheslav Lakshin with us right now? No? No. Unfortunately, no. There are some questions to Lakshin. Thank you very much indeed. Thank you for our participation. Thank you for our excellent presentation. Thank you for so high level of our interactivity and very high interest into the discussing panel. And thank you for the organizers, and thanks for the company, pharmaceutical company, Bezen Healthcare. And I would like to resend the word our president of Ukrainian Association of Reproductive Medicine, Professor Alexander Mikhailovich Yusko, to the closing words.
Дякую, Володимир Володимирович.
Thank you, Vladimir Vladimirovich. This is the advantage of a last session. Although the time is already exhausted, but we may ask questions and get answers. I thank everybody who, up to this late hour, was with us. Today was a very tension, but very interesting day. We have to digest all this. We have to sleep overnight. So tomorrow to meet for the second day, which I hope will be not less interesting and will be same saturated as today. We plan to meet at 9 a.m. and to work up to 6 p.m. I thank all the sponsors who today supported during our first day of symposium. I do thank technical support team for a very intense but efficient work. I thank everybody, all of us, and I wish you be healthy. Take care of yourself. To meet you and to meet you tomorrow as well. Goodbye.